गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय हे
गजवदन वक्रतुंड महाकाय दशावतारी आम्ही धरितो तुमचेच पाय दशावतारी आम्ही धरितो तुमचेच पाय
हे गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय वक्रतुंड महाकाय वक्रतुंड महाकाय सुखकर्ता दुःखहर्ता वार्ता विघ्नाची दुर्वी पूर्वी प्रेम कृपा जयाची सर्वांगी सुंदर शेंदुराची कंठी झळके माळ मुक्ता फळाची जय देव 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 रत्न खचित फरा तुझ गौरी कुमरा चंदनाची उटी कुंकुम केशरा हिरे जडित मुकुट शोभतो बरा झुणझुणती नुपुरे चरणी घागर्या जय देव 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 जय देव
कृतत्ताण लंबोदर कृतत्ताण विघ्नेश्वर कृतत्ताण जागृत वेकिट कनक वेकिट कनक वेगन कृतत्ताण जागृत वेकिट कनक कनक जागृत वेकिट कृतत्ताण कृतत्ताण कृतत्ताण
स्तवितो तुम्हा संकट अमुचे विलयाला जा
स्तवितो तुम्हा संकट अमुचे विलयाला जाओ
स्तवितो तुम्हा संकट अमुचे विलयाला जाओ हे गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय वक्रतुंड महाकाय वक्रतुंड महाकाय लंबोदर पीतांबर परिमल वंदना सरळ सोंड वक्रतुंड त्रिनयना दास रामाचा वाटपा हे सदना संकटी पावावे निर्वाणी रक्षावे सुरवर वंदना
जय देव जय मंगलमूर्ती दर्शन मात्रे मन कामना पूर्ती जय देव जय मंगलमूर्ती दर्शन मात्रे मन कामना पूर्ती जय देव 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 जय देव
Good morning, teachers, colleagues, and dear students. Greetings from Pune. The COVID-19 pandemic has taken its toll on the health of the population, healthcare systems, and economic status of countries worldwide. There were many challenges to manage these patients, especially with the newness of the disease, rapidity of spread, uncertainty of progress of patients with respiratory failure, and lack of physical communication with relatives. Challenges faced by the caregivers were shortage of beds, medications, and manpower ratios, possibly due to attrition and illness. Due to variations in healthcare systems, demographics of population, and racial considerations, different regions need to generate endogenous data. It has been difficult to capture data due to high workloads. Large number of patients staying for 10 to 14 days, increased doctor-nurse to patient ratios due to caregiver burnout and illness may have also contributed to untoward outcomes. The battle has been long and fought hard with variations in urban and rural robustness of the healthcare delivery systems, demographic and racial variations, and predisposing risks to severe infection leading to death. Globally, as of 11th of November 2021, there have been 25 crore confirmed cases of COVID-19, including 50 lakh deaths reported by the World Health Organization. As of 11th November 2021, a total of 760 crore vaccination doses have been administered. The World Health Organization estimates that nearly 1,15,000 healthcare workers could have died from COVID-19 in the period from January 2020 to May 2021. These deaths are a tragic loss. There are also an irreplaceable gap in the world's pandemic response. Let us observe 1 minute of silence to pay tribute to the heroes who lost their lives treating humanity. The WHO declared 2021 as the International Year for Health and Care Workers with a concrete action plan to protect health and care workers, strengthen the data collection and reporting on infections, ill healths and deaths among healthcare workers due to COVID-19, to protect the health and care workers during and beyond the current global COVID-19 pandemic, and to accelerate the vaccination of all health and care workers all over the countries. Encouragingly, the reported rate of infections and deaths among health and care workers has reduced over time, but the world cannot be complacent. More work is needed to minimize the risk of infection in the workplace. Lastly, the role of the intensivist has been exemplified in the pandemic, where skill, knowledge of all systems, understanding physiological variables, imaging is undertaken by the lone warrior at the bedside. It is now more than ever the importance of the ICU doctor, the intensivist, has been brought to the forefront. So ladies and gentlemen, let us treat ourselves to a scientific feast over the next 2 days virtually and hope to meet in better times next year. Tough times do not last, but tough doctors do. Thank you. I now request Dr. Shirish Prayag, the chairman of the virtual Best of Brussels, to come and give his opening remarks.
Thank you, Kayanwish. Thank you all for joining us this morning for the 8th Best of Brussels. We had 7 Best of Brussels sessions which were continuously run with a break last year. And this year we have been forced to have this virtual Best of Brussels. We hope sincerely that next year onwards, we are going to physically meet and have the regular Best of Brussels the way it was conducted all along. This year, the focus inevitably will be slightly skewed because of the COVID pandemic, and a significant portion of our lives has been affected by the presence of COVID in the intensive care, and therefore naturally enough, some of the sessions will be dedicated to COVID and its management. However, overall critical care has also progressed over the last couple of years, and we hope that we will be able to have a scientific feast as always from the team of ECSEM. And we are ever grateful to Professor Jalui Vincent, Dr. Daniel Debakar, and all other colleagues from Europe, especially from Belgium, who have always joined us over the last 7 years, who continue to be associated with this Congress, and who have very generously participated in this year's virtual meeting as well. So thank you, Jalui, thank you, Daniel, thank you, everyone, and thank you all for joining us. Let's sincerely hope that this meeting fulfills our scientific needs to a certain extent until we meet again next year in July 2022 in a real world platform. Thank you very much.
So let us begin with session 1. The session topic is on COVID-19. Let me introduce the first speaker, Dr. Manu Shankar Hari, consultant intensivist, consultant in the intensive care medicine at the Guy's and St. Thomas Foundation Trust and NIHR clinician scientist. He is the chairman of the Sepsis Quality Improvement Project in the hospital. Dr. Manu's research focuses on lymphocyte biology and epidemiology of sepsis. He was awarded the prestigious NIHR Clinician Scientist Award in 2016. He was recognized for his contributions to sepsis research with the Anxis Intensive Care Global Rising Star Award in 2017 and International Sepsis Forum Lowry Fink Fellowship in 2019. Dr. Manu's research explores ways to improve outcomes in adult critically ill patients with sepsis and with ARDS by linking the illness immunobiology to interventional trial design. Today, he will speak on COVID-19 disease. Is it really a cytokine storm?
Hello, and thank you for the opportunity to discuss the topic, is COVID-19 a cytokine storm in critically ill patients and hospitalized patients? My name is Professor Manu Shankar Hari. I'm a critical care physician and chair of critical care medicine. Before I start my talk, just want to acknowledge my funder. I'm funded through an NIHR Clinician Scientist Award, and these are my views, not necessarily of the Department of Health, NHS, or the NIHR. The only conflicts of interest that I need to highlight is that I led the interleukin-6 antagonist prospective meta-analysis coordinated by the WHO, which I will discuss towards the end of my talk. When we think about viral infections, SARS-CoV-2 has kind of generated a tremendous amount of immunology literature. Basically, it boils down to the virus being sensed by the host cell through the ACE2 receptor and the TMPRSS2, and through the SARS-CoV-2 spike protein and the receptor binding domain of spike protein. Once you get this interaction, the host cell can undergo directly cytotoxic effect. It can also stimulate the renin-angiotensin aldosterone system, resulting in tissue injury, remodeling, inflammation, vasculopathy, vascular permeability. There is endothelial damage with fibrinolysis and thrombin production, and there is a dysregulated host immune response to infection that is associated with what we are going to talk about, which is the cytokine release syndrome. And there is a interaction between inflammation and thrombosis, and we all kind of understand that idea that there is an immunothrombosis in the context of COVID infection. So it's a complex biology, and I've been asked to talk about one element of it, which is the cytokines and cytokine storm. And I just want to make three broad points using some simple examples, starting with what are the different types of cytokine responses or immune responses to pathogens, and then bring in the idea that the cytokine responses are completely dysregulated in the context of moderate to severe COVID-19 infection, talk a bit about the IL-6 and IL-10 levels, and then finally wrap it up with IL-6 receptor antagonist. So when we think about the host immune response to pathogens broadly, these are the things that we think about. What are the different types of immune responses? What are the key transcriptional factors, particularly for the T cell response? We think about the pathogens and the corresponding transcription factors, key mediators, and effector cells. So the type 1 immune response, the key transcription factor is TBAT. And the common reasons why you get the type 1 immune response is primarily because of intracellular pathogens and viruses. Sometimes some fungi could also cause them, and protozoal infections. The key mediator here is interferon gamma, and interferon gamma will enhance the TBAT expression, and therefore there is this vicious cycle. Now, the effector immune cells for a type 1 immune response are the NK cells, the cytotoxic T cells, and the Th1 CD4 T cells. The second type of immune response to infection in the innate and adaptive immune system is mediated through the transcription factor GATA3. And here, the pathogens are mostly helminths, and the worms, such as which is much more common in the tropical areas, are the primary drivers of this type of immune response. And the key mediators here are slightly different, which is IL-4, IL-5, IgE. And the cellular mechanisms involved are different too. You got eosinophils, basophils, and mast cells. And in fact, there are reports of changes within all of these cell populations within COVID-19 as well. And the third kind of immune response is the type 3 immune response, which is the transcription factor is Rho gamma T. There is the fungi and bacteria are the common pathogens, and the predominant key mediators are the IL-17 and IL-22, and the effector cells being neutrophils, amongst other cells. So when we think about the immune responses, what you would expect to see is a viral immune response, which is the TBAT1, interferon gamma, and NK cell. With that sort of basic immunology, let's look at what happens in COVID-19. And this is a lovely work published in Nature very early on in 2020. This is from the group led by Akiko Iwasaki, and the first author is Caroline Lucas. And what they did was to take patients who are uninfected healthcare workers, moderately ill patients who are defined as patients requiring hospital admission with supplemental oxygen, and then around 33 odd severe patients who are in critical care unit on a mechanical ventilator, some of those who go on to die. And the authors measured around 70 cytokines in patients in all of these three groups of patients. So the figure on the right essentially highlights the changes in cytokines. The lower left triangle is the moderate group, and the top right triangle is the severe group, and the magnitude of change is color-coded, so is the p-value, so the significant differences. There are a few points I want to make here. First is there is a tremendous difference in cytokine profile between moderate and severe. There is an increase in type 1 cytokines, type 2 cytokines, type 3 cytokines, and chemokines and other mediators of inflammation. In other words, moderate to severe COVID-19 patients show evidence of not only viral, classical conventional immunology, viral infection immune responses, they also show evidence of helminthic immune responses, and they also show evidence of bacterial immune responses. In other words, it's a complex cytokine response that you see in moderate to severe patients. And this cytokine response changes over time and is associated with illness progression. And I think perhaps the most important thing to highlight here is that idea that we are not looking at one type of cytokine response or immune response. We are looking at quite a complex immune response that is altered due to a simple viral infection. So the standard type 1 responses alongside the type 3 and type 2 responses. And I'm just going to kind of add a layer of complexity to this broad immune response by just bringing in the IL-6 and IL-10 as a focus. We published around the same time the COVID-19 immune signature. We used around roughly 350 odd immunological parameters. We measured the cellular subsets as well as immunoglobulins and cytokines. What you see in COVID-19 patients is, if you follow the volcano-like plot here, what you see in COVID-19 patients is a decrease in the T cell compartment, particularly T cell lymphopenia. Not only the CD4 alpha beta T cells, CD8 T cells are decreased, V gamma delta T cells are decreased. There is a decrease in some subsets of B cells. There is an increase in activated T cell subsets, plasmablasts, and IL-6, IL-8, and IL-10. And those of you who do immunology for a living, you would realize that the IL-8 is often associated with a neutrophilic kind of immune response from bacterial rather than a viral immune response. But we are seeing a tremendously different immune response in COVID-19. And we also go to show in this manuscript that there are clusters of immune responses that are distinct in COVID-19. And each of those nodes that you see here represents a dominant immune response in patients. And one such immune response is a triad of molecules, which is IL-6, IL-10, and IP-10. An increase in IL-6, IL-10, and IP-10 is associated with an increase in risk of severe disease and progression of disease in those with moderate disease. And I think here is where the question that was posed by the organizers of the conference, do we think it is a cytokine storm? The unequivocal answer from me is that in most patients, it is a cytokine breeze. There is no storm here, at least based on the cytokine levels that you see and the clinical variables that you see. So what you're seeing in patients with COVID-19, just to explain the graph here, y-axis is the concentrations of different cytokines. X-axis are patients who are controls, who are seropositive and seronegative, which are healthy controls. And then you got low, moderate, and severe COVID-19 patients, and then a lower respiratory tract infection in turquoise blue. The COVID-19 are in orange. What you see in COVID-19 is that there is an increase in IL-6, IL-8, IL-10, and IP-10. There is a dose-response relationship between IL-6, IL-10, and IP-10 in that as the severity goes up, the concentrations go up. And the IP-10 concentrations are higher than that of a lower respiratory tract infection, whereas the IL-6 and IL-10 concentrations are similar to that of a lower respiratory tract infection. In other words, patients with lower respiratory tract infections have got a similar cytokine levels compared to that of COVID-19. And that's not just our data. This is data from Amsterdam, where they looked at the TNF concentrations and IL-6 concentrations and IL-8 concentrations. On the x-axis is COVID-19 with ARDS, sepsis with ARDS, sepsis with no ARDS, out-of-hospital cardiac arrest, and trauma. What you see here is that patients with COVID-19 have TNF levels that are lower, IL-8 levels that are lower, and IL-6 levels that are lower when compared to sepsis and ARDS. And their levels of cytokines look similar to that of trauma patients. And if you're still not convinced with this argument, what we and others have done is to look at the plasma levels of cytokines reported in previous ARDS studies and compare that to that of COVID. And here I want to kind of focus your mind into these two data first. So these are the alveolar fact and sales trials. And what you see here is the IL-6 levels. IL-6 levels are very high in patients with ARDS. And the comparative severe disease data is shown here. The IL-6 levels are high, but not as high as these, even after accounting for differences in measurements. What I want you to focus on now is the hypo versus hyperinflammatory ARDS, and the IL-6 levels in hyperinflammatory ARDS are significantly higher compared to that of COVID-19. In other words, even though you get an increase in IL-6 levels in COVID-19, it is still lower than many of the ARDS patients that we have looked after. And therefore, just based on the levels, you can't call it cytokine storm. But based on the clinical manifestations, you may be able to say that these patients have got an excess cytokine, but that's about it. There is no storm. And I want to kind of bring in the notion of IL-6 blockade. And just to kind of give you a very brief summary, this is the manuscript that's published now in JAMA. It's an open access manuscript, so if you can easily access it. And if you can't, please email me and I will give you access to that manuscript. And in this manuscript, we had roughly 10,000 patients, around 27 trials. We had trials with tocilizumab, trials with sarilumab, and one trial with siltuximab. What you see here is the overall, the 28-day mortality is lower in patients who get IL-6 receptor antagonists compared to standard of care or placebo. And in this manuscript, we looked at the cytokine levels, look at the CRP levels when available, and an increase in treatment response. Again, coming back to basic immunology, if you have an increase in IL-6 levels, you would expect to see an increase in CRP. And therefore, if you have a higher CRP, you would expect a greater benefit with IL-6 antagonists. We did not see such differences in benefit. So the benefit occurs irrespective of the CRP levels. In other words, measuring IL-6 to treat IL-6 receptor antagonists will not work, and there are biological reasons to why that may not work. For those who study IL-6 biology, you may know already that you have the classical IL-6 signaling, which is IL-6 binds to an IL-6 receptor, and therefore you get a blocking of that response would get a benefit. You can also have circulating IL-6 receptor, IL-6 combinations, where the IL-6 blockade may not necessarily, IL-6 levels may not necessarily truly reflect the concentrations of IL-6 in circulation. So there is no need to measure IL-6 to give IL-6 receptor antagonists. And I just want to make one more point here, which is in patients who received usual care or a placebo, as in open label and placebo-controlled trials, the treatment effect remained. So for the last 10 minutes or so, I was trying to explain to you that COVID-19 is characterized by excess cytokines. Cytokine levels in COVID-19 are lower than that you observe in sepsis and ARDS in critically ill patients. Most patients with COVID-19, what I would call as patients having a gentle cytokine breeze. There is no evidence of cytokine storm as you see in following cell therapies, CAR T cell therapies in particular. There is no evidence that such severity of illness occurs in the context of raised cytokines with COVID-19. IL-6 receptor antagonists seem to improve outcomes, so do corticosteroids, and the combination of those two seem to have an additive beneficial effect. And I thank the organizers again for the invitation and the opportunity to discuss this topic with you, and my email and other ways to contact me out there, and hope you have an enjoyable conference. Thanks very much.
Thank you, Dr. Thank you, Dr. Manu Shankar Hari, for that lucid talk on interleukin 6 and the cytokine breeze. The questions These are all pre-recorded sessions because of a time lag. And we will like to take your questions, either putting it in a chat box or then in the JAMA session, which will be held at 4:30 in the evening. So kindly jot your questions down and please send them across to us, or then you can ask them live at 4:30 in the evening. Coming to the next topic, I would like to introduce our second speaker for the day, Professor Pierre Singer, who is Professor of Anesthesia and Intensive Care at the Sackler School of Medicine, Tel Aviv University, Israel. Dr. Singer has over 30 years of clinical and academic experience. He currently maintains appointments as the Director of the General Intensive Care Department, Head of Institute of Nutrition Research at the Rabin Medical Center, and Director of Metabolism Laboratory at the Medical Center. He was chairman of the Israel Society of Clinical Nutrition from 2005 to 2009 and chairman of the European Society of Clinical Nutrition and Metabolism 2010 to 2014. Dr. Singer has supervised more than 50 clinical and academic research theses. His area of interest is emergency medicine, nutrition, and diabetes.
I am the director of the General Intensive Care at the Benetton Hospital, Tel Aviv University in Israel. And I will be happy to share with you some new topics that are developing in our country. So the topic today is how to predict the need for invasive mechanical ventilation. And of course, these are my disclosures. And in the intensive care, there are always more and more requirement for non-invasive ventilation using some high-flow nasal cannula or BiPAP or prone position with high flow. And there is a delayed recognition of respiratory failure and prolonged use of high-flow oxygen therapy or non-invasive ventilation that may lead to increased mortality. Just last weekend, I was participating to a large non-invasive ventilation conference in Italy, and our Italian colleagues were focusing on the fact that the later we are deciding for intubation, the higher the mortality. So this decision to initiate invasive mechanical ventilation is not clear-cut. And more in the period of COVID-19 with respiratory failure, where we use a lot of non-invasive ventilation and high-flow oxygen therapy nasal cannula, well, in this category of patients, the dilemma is really true. There have been some successful prediction to know when to use mechanical ventilation. One of them is ROC score, which is using the SpO2, FiO2, and the respiratory rate. And when in this study it is more than 4.8, well, the probability to be free of mechanical ventilation is higher. Others with high-flow nasal cannula oxygen therapy have been using the ROX4, and the ROX index is in here more, if it's lower than 3.8, the mortality is much higher. And the predictive value of the ROX index seems to be one of the best of the different predictors that are existing. And for instance, COVID-19 and ROX index has been also used, but you can see that the levels of the ROX index may differ from one study to the other. In our unit, we decided to create an ICU data intelligence system, which is changing the approach to the hospitalized COVID-19, but also the rest of the population. We started in September 19 with a collaboration between a group of working people doing big data and artificial intelligence and our staff in the hospital ICU. And together with that, we decided to change the focus of our interest into the COVID-19, and we want a large grant of the Israel Innovation Authority to work on COVID-19 in this field. This is our group. And actually, we did a lot of work from April 2020 until today to create a cloud capability to perform on the go prediction on critical question on COVID-19, to adapt this system capability in the medical center, and to try to do active monitoring of hospitalized patients and actually to do the assimilation and testing. So we choose a two-step solution. We first trained with a machine learning on the large mimic database that is existing on the cloud, and then to train the results on a pre-COVID-19 general population, and then to adapt this to a smaller COVID-19 cohort. So first of all, we had a big work doing a transformation of our data of the hospital to the MIMIC3 tables in the same language, so that we will be able to take all the data from our center and to do it in an analysis that has been done on the MIMIC and with the language of the MIMIC. So this was very important. The data items were patient demographic, admission, vital, laboratory, treatment, etc. So what we wanted to do is to use XGBoot with sliding window, the good machine learning method, to try to find the prediction for 6 hours, 12 hours, 1 day ahead, and to know if the patient will need or not an invasive ventilation or not. You can see that the adaptation of the machine learning model from MIMIC to the Rabin Medical Center database was performed. And what was the results is very interesting, because our predictive results to know if the patient would need an invasive mechanical ventilation reach an area under the curve of 0.92. So 6 hours in advance, we were able to predict with a very high precision if the patient will need mechanical ventilation or not. We calculated the deterioration risk, and for each positive prediction, we calculated the distance from the threshold. And this was very important as well. So the next step was to try to find a comparison between the MIMIC database, the Rabin Medical Center, only the second wave, the MIMIC and adaptation with the third wave, and finally, the Rabin Medical Center experience of the third wave's data, which was available on COVID. And what we could see in this screenshot is the fact that we were able to predict if the patient had a high chance to be ventilated or not, according to the 4 possibilities. So you can see the population we recruited. This was a large amount of people, 34,000 patients in, or even more than, you can see here, much more male than female, like every time in the MIMIC3. In the MIMIC3, only the ventilated patients, the Rabin Medical Center and the Medical Center COVID, and all these steps after steps were doing adaptation and then create the prediction of the deterioration risk. These are the features obtained by the XGBoot, and you can see that lactic acid and cardiac output are very important. In the Rabin mapping, we could see that the arterial base excess, the heart rate, the respiratory rate, the ROX index, the PaCO2 and the PO2 are the main features. And here are the example of online decision support that we created. It was not only to create an algorithm that was important, but also to support the physician to know when he had to ventilate a patient. And you can see here an example of patients that are very oscillating, not deciding really if the patient should be ventilated or not. And it was not decided to ventilate this patient until the decision-making was stable. And at that time, we decided to ventilate the patient. This patient had a low probability of no consensus to start invasive mechanical ventilation, and the patient was not intubated, and finally the patient improved. So you can see that the areas of the curve of the prediction was for the MIMIC database 0.87, without adaptation on Bellinson 0.77, Bellinson alone 0.83, but MIMIC on Bellinson with adaptation even increased the prediction possibility. We did also a Shapley adaptive explanation to try to understand better why were the prediction so important. And we had 4 steps, 4 windows in the physician interface. The first one was actually looking to all, this is an example of our hospital system called ALMA, and this is like monitoring of what's going on in our unit, and we have the list of all the patients. And for instance, you can see that we have here a prediction of ventilation which is 0%, and another which is 83%. And so in a glance, you can see how many patients are in your department and how many of them will need mechanical ventilation. Then you will have a second interface, which is the trend, because if the patient is very unstable, it's difficult to make a decision. But if this prediction is very stable, like in these patients, you can see that actually you will reach the decision easier. A third physician interface is to explain through the sharp explanation why the prediction is so high, and it is based on pulse rate, less on respiratory rate, more on temperature, less on age, and this is helping also the physician how to decide. And the last physician interference is again the trend of the different features over time, telling you that definitively there is a strong message, and really it's a drill down into the data. So in summary, we have established a practical solution for utilizing artificial intelligence medical decision support for hospitalized patients based on electronical mechanical records. We are training on large database. We are creating an algorithm adapted according to the source database. And for COVID-19, we succeeded to forecast online and predict if the patient was deteriorating very much and how much chance he had to be intubated, why were the reasons to take such a decision, and definitively our intention is to enlarge this system, and the ICU, this will be most probably the answer for tomorrow. Thank you very much.
Thank you, Dr. Singer, for the lucid explanation and the liaison, and showing us the liaison between artificial intelligence to clinical medicine. Coming to the third topic of this morning's session, let me introduce Professor Massimo Girardis. He's the Director of Anesthesia and Intensive Care Department of Modena University Hospital, Modena, and Reggio Emilia and University Hospital of Modena, Italy. Professor Massimo Girardis has numerous assignments, study and work experiences abroad, as well as rich corpus of publications and scientific activities. He also holds the position of Associate Professor at the Department of Surgery, Medicine, Dentistry, and Morphological Sciences. His special interest is in transplantation, oncology, and regenerative medicine. He will now be speaking on immune response and therapy in COVID-19.
So, good morning, or good afternoon, good night. It depends on your time now. It's a very great pleasure for me to be here. Thank you so much for the kind invitation to this Best of Brussels. I'm Massimo Girardis. I come from Italy, Modena University. I'm an intensivist with some interest in infection, immune response, in general immunology. My issue today is to discuss with you about immune response and therapy. in patients with COVID-19, severe patient with COVID-19. Before to start, I just want to share with you my conflict of interest. I have no specific conflict of interest for this talk. Looking into the story of therapies, pharmacological therapies for COVID-19, I tried to summarize in this old slide all the treatment that we have up to now, starting from antiviral treatments, moving to monoclonal antibodies, anti-inflammatory therapy, and thereafter to the therapies for interstitial pneumonia, to avoid oxidative stress, and to manage endothelial dysfunction and coagulation. We have plenty of intervention possible, but at this time, we have not all the intervention proved as beneficial, and probably with some intervention that could be harmful in the patient. But, the story of intervention during these 2 years has been so, I say, crazy, because if we look to the indication coming from guidelines or randomized control trial on who and when we have to start specific therapy. In this case, I'm talking about antiviral, anti-inflammatory therapies. In this cloud of words, you can find a lot of very common words used for inclusion of patients in randomized control trial, as well as in guidelines: hypoxia, steroids, therapy with steroid, dysfunction, organ dysfunction, lymphocyte count, microthrombi, renal dysfunction. So I think that it could be more complicated than we believe today to understand which is the right therapy at that time for that patient. And in this way, I'm in some distress looking to the inclusion criteria as well as recommendation in the guidelines concerning the indication of the patient who could have benefit. In fact, when we look to the last indication from the WHO, you have in the right part of the slide, we know that therapy as corticosteroids, remdesivir, dexamethasone again, and cytokine blocking agents, the indication is not based on a specific biomarker or a specific clinical condition of the patient in terms of immune response, but is based on risk factors, time, severity of the patient in terms of PaO2, FiO2 ratio level, need of oxygen therapy, need of mechanical ventilation, if the patient is shocking or not, and incredible, on the location of the patient. If the patient is at home, in hospital, and if it's an hospital in normal ward or intensive care unit. This is, of course, it depends on many things. Particularly at this last point, the location depends on your organization of healthcare system. For this reason, I think that many of us believe that risk factors, time for starting or for the first positive swab to the clinical presentation of the patient, the severity, and particularly the location are not related to the state of the patient in terms of viral replication and immune response. Definitely, I think that we can't have this kind of picture in the heterogeneity of the patient with this homogeneous pathology as COVID-19. Despite this pathology is quite similar in all the patients, the time of presentation, the time of care that you have to provide to your patient depends on many things. And first of all, depends on the immune response of the patient. So I feel distressed when I keep my guidelines and I try to apply to my patient, because at the end of the story, I decide to start with steroids or not, if the patient is at home or not, or if the patient receives oxygen or not. But the need of oxygen depends from many things different from the inflammation of the patient. I think that concerning immune response of COVID-19 patient, we had a lot of massive information coming from experimental study, not only. Many of the study on immune response of the patient, on pathophysiology of COVID-19 are theoretical studies. But at the end of the study, I think that we can summarize the process of from infection to organ dysfunction in COVID-19 in 4 phases: upper and lower respiratory infection, lung injury associated in 2 phases, early stage with inflammatory cyanide molecules in the alveoli with activation of the immune response, a second phase in the lung called progression and formation of edema and microthrombi. The transition from a lung pathology to a systemic pathology is the 3rd phase, and the 4th one is the activation and loop of activation, reload of activation involving the endothelium. So we had at least 4 different phases. Again, one is the infection of the upper and lower respiratory tract. The second one is the initial response of immune system at the lung level. The third one is the so-called transition from lung to systemic inflammation. And the fourth one is the loop between lung and systemic inflammation with the perpetuation of inflammation and endothelial activation. And we have many information, more specific information, on the immune response. Together with our friends of the European Group of Immunology Sepsis, we try to define 2 different phenotypes of immune response. In the early phases, it's quite similar in all the patients, but after the first phase, maybe 1 week more or less, we have 2 different pathways. One is for favorable, for good outcomes with an increased number of immune cells, dendritic, monocyte, and T cells. On the other side, we have the so-called bad outcome, bad disease, severe disease with a decrease of immune response in terms of cellular response. And when I close my eye, I think all my patients that arrive in my ICU, now we have admitted more than 600 patients in my ICU. We have a sort of heterogeneity of patients in terms of cellular presentation, immune presentation. And so the question is was correct to apply in all the patients the same? All the patient, I mean, it was patient who needs intensive care admission, so mechanical ventilation, non-invasive, but in terms of immune response, they were quite different. So my question every day is correct that I apply the same scheme of therapy, the same therapy for all my patients, because you know that from guidelines, all the patients needing mechanical ventilation should receive the same therapy. I think this is at the end not correct. And when I think to the immune response in COVID-19, I summarize in my mind the same story of sepsis with 2 phases. The first phase is a pro-inflammatory phase. As in sepsis, probably in COVID-19, we have a less increase in pro-inflammation phase, at least in the first stage of the pathology. And at the same time, we have a balancing of inflammation and immune response, trying to make a compensation of hyperinflammation. And the difference probably to what we know up to now is that the hypoinflammation, the trying to decrease the hyperinflammation phase, the immune suppression in patients with COVID-19 is more pronounced than in sepsis. In fact, it's quite normal to a patient at ICU admission with very low count of lymphocyte, very low HLA-DR on the monocyte, and in a very early phases, this patient may develop secondary infection on viral reactivation. So finally, I think that putting all together 4 phases, cellular response, hyperinflammation, cytokine storm, I think that we, at least for my knowledge now, I suggest to have an approach as in sepsis. 2 phases, 2 different mechanisms. One is hyperinflammation. The second one is the immunosuppression phase. Probably in our ICU patient, many of the patients arrive with a sort of immune paralysis, at least after 1 or 2 weeks of infection, viral uncontrolled infection, because at the end of the story, you know that the viremia in this patient also after 15 days is very high, and there is a clear relationship between viremia and outcome of the patient. So, is it correct to apply the same therapies in all the patients, regardless of the phases? Early phases with high viral load and hyperinflammation, late phases with decreasing of viral load and immune suppression? I think this is not correct, totally incorrect. And the reason was a really pragmatic reason for having this clear-cut indication of recommendation from the guidelines. If you are at home, you avoid to start with steroids. If you're in the hospital, start steroid. If you need oxygen, you can use cytokine blocking agent if your pathology is worsening and so on. I think this is clear-cut indication coming from pragmatic trial, but at the end of the story, each patient is a different story. As an example, for steroids, from trials as well as from pathophysiological and all trials, trials before COVID-19 in patients with acute injury ARDS, we know that probably we have a window of opportunity for beneficial effect of steroids, probably in the early phases during the pro-inflammatory phase, not very early, because probably the early treatment with steroid can increase the viral reapplication, so increasing the viremia or the viral load in the lung, meaning a potential progression of disease. But we have a window during pro-inflammatory phase. If we use steroids later, we don't know anything about that. We don't know if these steroids could be helpful. And for sure, if we apply steroid therapy in the late phases with a clear immune suppression of the patient, immune paralysis, probably we have a risk of increasing of infection, particularly, as we know, fungal infection. The same story could be for cytokine blocking agents. Up to now, we know that, again, this is not a specific therapy. This is an anti-inflammatory generic therapy against anti-leukin-6 or 1 or anti-JAK. And again, we have a window of opportunity, and the window is during the pro-inflammatory phase. So if I try the same therapy in patients without hyperinflammation, probably we have as steroids potential risks, and especially in patients with after ICU admission without any hyperinflammation or after steroid therapy. If we don't measure any hyperinflammation marker, if we don't measure any immune suppression marker, probably we could have the risk of potential harmful effects of cytokine blocking agent, as clear now from many trial and indication. An example, what about the effects of anti-inflammatory steroids and cytokine blocking agent on the development of new infection, in particular the breakthrough infection or secondary infection in ICU patients, and bacterial, fungal, and viral infection? We know from literature that the risk of VAP, invasive pulmonary aspergillosis, and viral reactivation is very high in COVID-19 patients, more than in other ICU patients. And there's any effect of cause effect between anti-inflammatory therapy and these infections, or the risk of infection. if we use the meta-analysis that lead to the recommendation guidelines, the first one is on steroids in the upper part of the slide, and the second one was on the antagonist of interleukin-6, you can find that there is no suggestion that this therapy may have adverse events, particularly in terms of infection, both for steroids and for cytokine blocking agents, in particular anti-interleukin-6 drugs. This is true? Probably yes, but when we look to the trial included in the meta-analysis, and we seek for a report of fungal or viral reactivation, it's a quite strange story. In the 7 trials used for steroids indication, no trial measure viral reactivation, and only 3 out of 7 trials, fungal infection was investigated properly. So it's quite the same story for anti-interleukin-6 trial included in the meta-analysis. Only 5 out of 22 randomized control trial included was considered in fungal infection, and only 1 in 20 patients was considered viral reactivation. This is for me a very again distress situation, because I think that I'm concerned on that, because when we treated this patient, we have some very important surprises since the first wave in March 2020. And we received during our COVID-19 wave in Italy from other ICU 2 patients with acute liver failure due to reactivation of herpes viridium 1. Both the patients received steroids and tocilizumab, and after more or less 15 days, they developed a severe herpes virus reactivation with acute liver failure, and both of the patients died. I think that this is my conclusion. I think that this is a composite take-home picture. The first one is on the right side is, please remember that when we have to use therapies for COVID-19, we have to consider the situation of the patient, particularly the inflammatory and immune response of the patient with specific biomarkers. Very easy. Biomarkers for hyperinflammation, ferritin, interleukin-6 concentration. I'm in favor of reacting protein C, but at the same time, you have to measure the potential immunosuppression phase of the patient. I like so much to use a lymphocyte or neutrophil to lymphocyte ratio that could give you an indication of the immune suppression of the patient. And specifically, I suggest to measure viral reactivation in the blood and in the lung, herpes and cytomegalovirus. The second point is it's important, as I say now, to measure. And if I don't measure, I can probably care something as viral infection and fungal infection. And the last is in the central. Please remember that COVID-19 is more or less an homogeneous pathology, but the patients are not an homogeneous population, and the heterogeneity in response of inflammation immune response may have a difference, may give you the difference in terms of treatments, and may do the difference for survival of the patient. I thank you again, and I hope that my lecture was interesting for you. That's all. And if you need any comment and discussion, I will be live. No, send me an email. Thank you so much.
Thank you, Dr. Massimo, for a wonderful talk on the indications of antiviral and anti-inflammatory therapy, depending on the different phases of the illness, and highlighting the use of the neutrophil lymphocyte ratio to consider viral activation in the later stages of the disease. We come to the 4th topic today, that is introducing the next speaker, Professor Alan Combs. He is a professor of intensive care medicine at the University of Paris, Pierre et Marie Curie, Paris. He's a senior intensivist at the Critical Care and Cardiology Department of the Petit-Salpêtre Hospital in Paris. His main research interests are care of the critically ill cardiac patient, mechanical circulatory assistant and extracorporeal membrane oxygenation, and rescue therapies for severe ARDS, including ECMO, and pulmonary infection in the mechanically ventilated ICU patients. He will be now talking on VV ECMO and extracorporeal CO2 removal in COVID-19 severe patients.
Hello, I'm Alain Combe. I'm the head of the ICU at La Pitié-Salpêtrière Hospital in Paris, France. And it's a privilege for me to be here with you today to discuss the role of ECMO in COVID patients. This is first on my disclosure slide. Well, let's get back 18 months ago when the first cases of severe COVID-19 were reported with patients with acute and severe respiratory failure, mainly coming from China. And this is one of the first papers published reporting the use of ECMO in this context. And actually, the results were quite poor. In that series, only one of the 6 patients who got ECMO survived. And a few weeks later, there was the publication of that small review article, which gathered all the cases published in the first weeks of the pandemic in China, with a mortality as high as 94%. Though there was a big question mark about the utility of ECMO in that context. In March 2020, the epidemic reached our country, and we first gathered a group to define what may be the indication of ECMO in that context. And basically, we stuck with the EOLIA entry criteria, with 2 criteria of severe hypoxemia and 1 criteria of severe respiratory acidosis, resulting of a major decrease in lung compliance and increase in the PCO2 and a decrease in the pH of the patients. And we also used more stringent indications related to, for example, age. We limited age to 65, max 70. Also a major discussion about patients who had massive obesity, let's say BMI over 40 to 45, those who had severe comorbidities like advanced COPD, cardiac failure, cirrhosis, or those who have oxygen, patient with severe immunocompromised status, also because a lot of data has accumulated about the low survival rate of these patients with the classical forms of ARDS. We also excluded cardiac arrest patients, mostly except those with witnessed and very short no and low flow time. For those patients who had been on mechanical ventilation for more than 10 days, was also a discussion and was contraindicated for most patients. And of course, those who had multiple organ failure, maybe except patients with isolated AKI, acute kidney injury, because this actually was a feature of the disease. This is the first paper we published about the first wave, which hit France in March to May 2020. We treated more than 80 patients here in La Pitié-Salpêtrière, and those patients were a little bit different as compared to the patients who were randomized to the EOLIA study, those randomized to the ECMO group. There was mostly a major difference in those patients who were prone. It was 94% for COVID patients. It was only 56 for patients who had been randomized to the EOLIA trial. And overall, those patients were at a body mass index which was higher, also more severity when looking at the SAPS2 and the SOFA score. These 2 scores were higher. The PF also was very different. It was 62 on average. It was 73 in EOLIA trial. And there was no difference in compliance, because originally for COVID patients, there was a description of preserved compliance. This actually was not true for those patients who needed ECMO. The mean PaCO2 was, however, very similar between Eolia and COVID-19 patients. And this is the main results of this first series of patients with a good survival rate up to day 60, which was very similar to the rate which was observed in the Eolia trial, was 31% here, 35 at day 90. Once again, very similar to the Eolia study. No major differences regarding the complications, except more pulmonary embolism in COVID-19 patients. And we now know that thromboembolic complications was also a main feature of COVID-19. Reassuring data about the rate of stroke, especially hemorrhagic stroke, just a slight increase from 2 to 5%, but very limited. What was also strikingly different between Eolia and the COVID-19 patients treated in this first surge in France was the longer time on ECMO. It was 20 days, close to 3 weeks in median. It was only 11 days for the Eolia trial. And of course, the ICU stay was also longer. We observed more ventilator-associated pneumonia, but clearly linked to the longer time spent on mechanical ventilation for these patients. And later we published the experience of the larger Greater Paris area, where during that first pandemic, we treated more than 300 patients on ECMO, and most of them were retrieved from a non-ECMO hospital to an ECMO facility. The overall survival was less favorable for this global experience within the Greater Paris, with a survival rate at day 90, which was 46 instead of 65% in our Lapitié series of patients. And when looking at subgroups, clearly there was an age impact with a more higher mortality for patients over the age of 50. Also a strong impact of the delay from intubation to the time the patients received ECMO, with a mortality which was clearly significantly less when this time was less than 3 days before ECMO. Also, the case load in the year before ECMO, case load in terms of VV ECMO only, was very important in terms of outcome, with a significant lower mortality, and actually was almost twice lower than in those centers we treated less than 30 cases. This 30 cases threshold was highly significantly associated with mortality. And reassuringly also no impact of the transfer on mobile ECMO to from a non-ECMO center to an ECMO center, which is very reassuring for the strategy of networking within an area. More recently, we published the outcomes of the global experience we get here. We were centralizing the calls for indications of ECMO in my center, and there was close to 600 calls, which we got here in Lapitié-Salpêtrière, and we evaluated the outcome of those patients for whom the first answer was ECMO, yes, for sure, and right now. Okay, maybe you can optimize mechanical ventilation, so ECMO, no, not yet. And when looking at the outcome of those two population of patients, this was quite similar, and once again, very reassuring. And when looking at those patients who had the contraindications, we got an answer of ECMO, well, probably not, no, never. The mortality was close to 90%. So now let's review the international experience of VV ECMO for COVID-19. First, this very interesting report of a center in the US close to Chicago, using the Protect Duo, which is a jugular to pulmonary artery dual stage cannula, which needs to be inserted in the hybrid room using fluoroscopy and transesophageal echocardiography. Is maybe a bit tricky to position, but still a very similar population of patients that we also had here in Paris regarding the age, the sex ratio, and the BMI. The mean PF ratio was 69 in these patients. And also original was the fact that they extubated on ECMO on average around 1 week to 10 days post cannulation, the patients, most of the patients, and they used awake ECMO for an additional 2 to 3 weeks before the patients were decannulated. And with this strategy, they had a very high survival rate, which was close to 80%. 1 year ago, the ELSO International registry data were published in that Lancet paper, which overall included more than 1,000 patients. And here, when looking at the mortality, it was 37%. However, you should be aware that it's a hospital mortality, and 30% of the patients were discharged to a home or rehab center, 10% were discharged to a long-term acute care facility, 17% were discharged to another hospital. So there may be additional deaths here of all those patients for whom no actual survival was known up to day 90. So I guess that the mortality may have been between 45 and 50, up to 50% in this population of patients. They were able to evaluate the factors associated with deaths in the hospital. Age was a strong predictor, together with those patients who had immunocompromised status, chronic respiratory diseases, pre-ECMO cardiac arrest. The lower PF ratio was associated with mortality as well, and those patients who had acute kidney injury and those needing some form of cardiac support at the time of cannulation. This is another paper published by a US group, 190 COVID-19 patients treated with ECMO with a median PF, which was clearly higher than in other series of patients, was 72, but with 1/4 of the patients having a PF over 90. This is the centers here which included patients, and they use a very sophisticated methodology, which is called a target trial emulation of ECMO with another group of patients who did not receive ECMO, and they were able to show that ECMO was associated with a better prognosis in these patients. Also interesting data from the Middle East and India, the SWAC-ELSO group, a large series of patients, more than 300 patients treated with ECMO, and 25% of those patients were treated in newly established ECMO centers. Overall, the survival rate was around 50%, but the interesting point here is that the survival rate was very similar to a newly established center and those were established for a longer time, which is encouraging for the future should we launch established new centers during a massive pandemic, with the fact that these new centers should clearly collaborate with established centers for the management of patients. And less favorable outcomes. Here is a large series from Germany with a lot of centers doing ECMO. And when looking at the mortality, it was close to 75% here with an impact of age, also in that series of patients, and the number of days of mechanical ventilation, but clearly showing that when there is no centralization of ECMO, once again in Germany, there's a huge number of centers with probably much less experience in each center, the mortality may be very high. And now a few words of the latest, the more recent data published in the last few months and weeks. And this is a letter published in Intensive Care Medicine a couple of weeks ago about 310 COVID-19 patients treated in Spain and Portugal. And they divided their experience in two waves. The first one from March to June 2020, and the second wave from July up to December 2020. The median PF was 76, so maybe a bit higher than in the first published series of patients. This is here the distribution of centers, once again through Spain and Portugal. And these are the results of that study. The patients supported during the second wave were significantly older, had more comorbidities, and less frequently were treated at the high volume center. This is very important here. The time between admission to ECMO was longer, but not the time since intubation. So it was mostly the time on high flow oxygen, on the non-invasive mechanical ventilation, which was longer in that series of patients. And the PF was slightly higher during the second wave, probably a bit less severity regarding the PF. And another major feature, which is quite interesting here, is that those patients who had co-infection in new onset pneumonia during ECMO was more frequent during the second wave. And during second wave, obviously, those patients had received corticosteroids before being on ECMO. And you can see here that the mortality of patients treated during the second wave was significantly higher. It was around 40% during the first wave, was more than 50 during the second wave of the pandemic. Those are the data from the ELSO registry, also comparing group A1 is the first wave in experience center, group A2 is the second wave in those same experience centers, and group B here is the second wave, only the second wave, let's say after July 1st, in those patients who were treated in newly established centers we did not treated patients during the first wave. There were some differences between the groups here, maybe a slight increase in age during the second wave, more comorbidities as well, more bacterial pneumonia, like in the Spanish also reports, more infections, more bloodstream infections, and also the time on non-invasive ventilation, and those patients who had been on non-invasive ventilation was longer, maybe suggesting here an impact of high flow in those patients. And once again here, the percentage of patients who had been on dexamethasone increased significantly from 40 up to 80% during the second wave. And when looking at the mortality, it significantly increased here from the first wave here at the experience center, around 40% up to close to 50 in those same centers during the second wave. And it was even higher in the newly established centers, those who had less experience with treating of the disease. And when looking at the factor associated with mortality was very similar, except there was a major impact here of the centers and also an impact of the wave of the disease, mortality being significantly higher independently during the second wave of the disease. And this is here our experience in Paris, also comparing the first and the second wave in La Pitié-Salpêtrière. And we also found an increase in mortality. This is here, the probability of dying during the first wave was 37. It was 47 in our patients during the second wave. And we cut the date of the wave here before July 1st, 2020, and after July 1st, 2020, here, including patients up to the end of the year 2020. No data for now on those patients treated in 2021. And as in the other series of patients, we also found that those patients treated during the second wave for sure at a higher rate of treatment with dexamethasone, and also a longer time on non-invasive mechanical and ventilation and high flow oxygenation before ECMO. So in conclusion, not all COVID-19 patients die on ECMO, especially very good results during the first wave, higher mortalities in the second half of 2020. And we do not have data on the latest since the Alpha and Delta variant, and especially the Delta variant, which seems to be associated with a much higher mortality and maybe different characteristics of the patients. Clearly, longer times on ECMO, longer ICU stays, more frequent lung infections, other complications may not be that different from previous ARDS treated with ECMO. Do we need for an update in ECMO indications? Maybe. Maybe do we need to lower the age limit? Should we include the pre-ECMO non-invasive mechanical high flow also in the total ventilation duration in the discussion for cannulating patient? These are open discussions we clearly need to have in the future. And with that, I would like to thank you for listening, and once again thank my team, which is still treating COVID-19 patients. This pandemic is not over, and we really hope that one day we will be able to meet once again together. Thank you so much for listening, and once again, thank you for inviting me.
Thank you, Professor Combs, for a lucid lecture on ECMO and ECOR removal. Now we come to the end of the first session, and I would like to call upon Dr. Shivkumar Iyer to chair the second session. Dr. Iyer needs no introduction. He is the head of Department of Intensive Care at the Bharati Vidyapeeth Medical College and is a past president of the ISCCM.
Without further ado, we are exactly on time. So Professor Jean-Louis Vincent needs no introduction. Suffice it to say that his H index, the number of times he's been cited, is humongously high. And he has an H index of 183. And all of us know him because he's been regular visitor to India for the last so many years. So let's start the talk. This keynote lecture is supported by Acumentis.
Hello. Good to be with you. Sorry for doing it in the distance. It's good to be back for the BOB meeting, which is always very successful. Our last symposium went very well. It was again a face-to-face meeting, and people were very happy about it. We missed many of you, unfortunately, but I hope you will join us next March for the 41st edition of our ISICEM. So please try to join. But the question comes, how COVID has changed our ICU practices? Quite substantially, I must say, and I can group these aspects under 4 P's. First, preparation. We have done a good job in expanding the number of ICU beds in the CCU, in the recovery room, etc. And we try to discharge some other patients home. We try to decrease the activity of some sectors in the hospital. And we expanded exactly as we did in 1919 at time of the Spanish flu, when there were tents in the fields around the hospital. The army brought some tents in some parts of France, for instance, or in China, they could go to a sports stadium, or they could build a hospital very quickly. So we could expand the number of beds, including in Moscow, which did the same, or in the UK, they transformed a convention center in a COVID unit. But we learned that this is not sufficient. It's not just a matter of ICU beds. We need to have these beds equipped. We need to have enough respirators. And the factories, the manufacturers could not bring much more respirators to us, even when we had the money for it. So we had to use anesthesia ventilators, which are certainly performing less well than our ICU ventilators. Or as we know, we had to ventilate more than one patient with a ventilator, which was a real challenge. We also learned how to improve hygiene, minimize the risk of contamination, and we expanded the use of non-invasive forms of respiratory support, including helmets, or including very simple respirators, as in Brussels, the Audi car factory could make, or in the UK, Mercedes did it. They had some time, they were producing less cars, and so they could contribute to provide us with some simple respirators. Now, it's not only beds and material, of course, it's also personnel. And at time of pandemics, personnel can also be ill. So we need to rely on some helps coming from other departments, from the operating room, from departments which had less activity. And very importantly, we know that we cannot continue to take care of some patients and invite the others to take care of other patients. No, because the quality of care would not be the same when a non-intensivist takes care of the patient, right? So we had to work in a pyramid way of organizing things. So the intensivist would give advice and monitor what less experienced people would do. Likewise, the ICU nurse has had to supervise other nurses who are less trained and less experienced in the care of the critically ill. So that's something that we needed to really put in place. And like in the Spanish flu period, we could rely on help of clearly much less trained and experienced people. In some places, in the US in particular, they worked with different teams. The anesthesiologists were doing only the endotracheal intubation. There was an airway team with pneumologists and respiratory therapists, an IV catheter team coming to do particular procedures. It was a challenge to bring these nurses and other doctors in the ICU in this difficult time period when they had to use isolation procedures. So there was a risk of burnout. We needed education, reassurance, psychological support. We needed to simplify administration, a lot of things that we learned. How to stay in the room and avoid going in and out of the room and repeating all these measures. Ulsters could help, or little things. And we expanded the use of echo-Doppler techniques in our ICUs. Very interesting. They could be used for various procedures. And we even went back to peritoneal dialysis because it requires less movement in and out of the room than hemofiltration. So it's all a matter of space, stuff, and systems, like in the industry. The Japanese people have told us quite clearly what the 6S really means. We made a lot of progress. understanding that this is not only a lung disease, but, you know, of course, there is a lot to say about the respiratory management of these patients. But there is also what people call the cytokine storm, the host response. It's not really a storm. The word, I think, should be avoided, because in some patients, the cytokine levels are not so elevated. In some they are, and even more than in other community-acquired pneumonia in the ICU. But in other cases, it's not so impressive. So there is some heterogeneity there. And we also learned that in COVID-19, one could find endotoxin in the blood. With a viral disease, yeah, it's probably coming from the gut. But it shows that there is some overlap between viral sepsis and bacterial sepsis. And endotoxin can contribute to the release of endogenous mediators. Actually, the host response is more complicated than a cytokine storm, as of course, B cells and T cells are largely implicated. So we could speak about a viral sepsis. We did an early autopsy study in these patients and found viruses in virtually every single organ. And of course, we know that these patients may develop multiple organ failure. So by definition, it's an infection with organ dysfunction. That's what we call sepsis. So yes, it is viral sepsis, and this expanded our considerations about sepsis, which is not only bacterial. There could be some differences, but still it is a form of sepsis. The coagulopathy may be a bit different than in bacterial sepsis. We could speak about CAC, COVID-19 associated coagulopathy. And so it was interesting to note the pathophysiological alterations involving the coagulation. And of course, coagulopathy and endotheliopathy clearly go together. So we had lots of discussions about how to perform anticoagulation, and we learned that we need to be relatively, how could I say, moderate with our anticoagulant strategies. This paper will come out next week. It's a review in the Lancet that we wrote on prevention and management of thrombosis in hospitalized patients with COVID-19 pneumonia. Heparin could even be used by inhalation if we think that there is an intrapulmonary process that may benefit from it. And there are already large trials on inhaled heparin, very interesting. We would have liked to still have activated protein C. You know, as we know, it may decrease mortality in septic shock, but unfortunately, we did not have it. We did not have thrombomodulin. Maybe there is a place for antiplatelet agents. We still need to study that. Well, let's speak about specific treatment. There is a lot to say about it. Many negative trials and loss of time with the hydroxychloroquine story. I'm going back to it, even though it's an old story, because it made a lot of harm to our field and to our patients, because a small trial created much trouble, too much noise, and Fabio Taccone and I rang the bell already early in this Lancet paper when we said, you know, stop this kind of thing. But as you know, hydroxychloroquine was available widely, and people wanted to have it, to use it before we had one trial after the other showing that this is not an effective therapy, even as prophylaxis. Hydroxychloroquine does not help, and azithromycin does not help either. So it's a shame, because there was a lot of money going into trials with this particular agent when the grant money could have gone to other therapeutic strategies. Ivermectin is not more effective, but it's also available widely so that some people would like to use it. There is even a meta-analysis in favor of ivermectin, but don't believe it. Clearly, the evidence is not there for ivermectin. So we could go on. Remdesivir is a weak antiviral agent. It doesn't work in ICU patients. And so already a while ago, the WHO said, no, we should not use remdesivir. Keep your money for other substances. So convalescent plasma, we tried, it didn't work very well either. So maybe one study was positive, but the other is not. Well, monoclonal antibodies are much more exciting, but in the early phases, at time of hospital admission, not when the patient is severely ill, already in the intensive care unit. So we did not really have these strategies arriving in the ICU. But as we know, we learned about the altered host response that characterizes sepsis, and that's how dexamethasone was found to probably help. The differences are quite impressive between dexamethasone and placebo in this large recovery experience. Now, there are still some questions about it, and Daniel De Backer and I and Elie Azoulay raised the question, are we so sure about the benefit of corticosteroids in every single severely ill patient? And others raised the same issues. Now we have this paper showing that perhaps 12 milligrams would be better than 6, although the differences did not reach statistical significance. So it's a wishy-washy type of thing. Maybe 12 is better than 6. We cannot say they are equivalent. Look at the mortality, 27% versus 32%, 32% versus 38%. So, but it's not statistically significant. There is also this question of should we use it early or should we use it a bit later? The optimal timing is still open to question. But then you have other forms of immunomodulation. IL-6 antagonism was particularly well studied, with tocilizumab in particular, some studies being negative, some studies being positive, but many of them were initially quite small until we really go for the large number of patients with the REMAP-CAP investigators, and in particular, the recovery platform, showing that tocilizumab may save lives in COVID-19. So we use it quite extensively in our department, but we must say that there are cost issues as the medication is quite costly. Blocking IL-1 is another option, and the results have not all been entirely positive, but recently, and it was presented at our symposium 2 months ago, Dr. Giamarellos and his collaborators showed a reduction in mortality with anakinra when they selected patients having high SUPAR levels. Now, SUPAR is a sepsis marker, which is not really great, but it's a good way to select patients having a high inflammatory response. Now, very recently in Belgium, we could not find a benefit from anti-interleukin agents. So this is still not entirely clear. Now, baricitinib as a JAK inhibitor seems to work, and it works as well as corticosteroids. So should we combine the two? Yes or no? Difficult question. Interferon beta, initially perhaps some positive results, but the most recent data just published 2 weeks ago show that it doesn't help, especially in critically ill patients. It could make things worse. So interferon beta, not in ICU patients. Complement inhibition, still being studied, we don't know yet. So corticosteroids probably, anti-interleukin 6 probably, JAK inhibitors probably, the other interventions. And, you know, it depends whether we give them alone or in combination. There are still many, many questions being raised about these therapeutic strategies. Now, zinc, vitamins, no real signal there. And unfortunately, we cannot give a good advice about this. So, dysregulated host response, could we eliminate the excess of mediators as Ronco and Navalesi and I proposed early on in the Lancet? You know, maybe there is a place for purification, but it's still open to question. We do not have enough data for this. We could have tried other therapeutic interventions like camostat, nafamostat earlier, like recombinant soluble ACE2. Estrogens, it didn't seem to work very well, although the women have a better outcome than men. Fluvoxamine, not sure. Famotidine, we don't know. Colchicine, we don't know. Melatonin even, or clofazimine. You know, we could have tried other agents, and we have not done enough, I'm afraid. Even Chinese herbs, in some meta-analysis, they were effective. That was our experience from China. So there is a lot of things to be done, lots of things that could have been studied. So what we learned is that we need to better identify the patient population. Even COVID is heterogeneous, and we need a better international collaboration. So hopefully, indeed, in countries like the UK, the authorities insisted for patients to be enrolled in clinical trials. And that was a very important movement for the patients to accept to be enrolled in trials. And then indeed, REMAP-CAP, Recovery, Solidarity, helped us to understand that we could use platform trials and we could test several interventions at the same time. And if one doesn't seem to work, we stop that arm and we continue with other interventions. There is a lot to say about genetic factors and how interferon may be influenced by this, but I see the time is running, so I'll move to personalization. We learned that even in a single disease like COVID-19, we need to personalize our therapy. Before COVID, we were already using prone position in patients with respiratory failure. And we learned that in COVID-19, it's actually better to use it early than late in non-intubated patients. And the optimal timing of endotracheal intubation was better defined. Not too early, as of course, mechanical ventilation is not a minor intervention, but not late, because a respiratory arrest is the worst case scenario for the patient. And we don't want the patient to have self-inflicted lung injury with large swings in intrathoracic pressures. So we learned how to identify the right time to intubate the trachea and not to do it too early. We also learned it's not only ARDS. Early on, Professor Gattinoni spoke about the type 1 and the type 2 respiratory failure in COVID-19. And this was good because we understood that it's not only ARDS. And even if it were ARDS is just a syndrome. We need to individualize our therapies. And the hemodynamic management initially was not well considered. When physicians saw this kind of chest x-rays, they wanted to give diuretics. Diuretics, give diuretics. But some of these patients had a too low cardiac output due to some degree of hypovolemia. So that was not a good idea. They may have needed some fluids to prevent multiple organ failure. And we learned the myocardium may be implicated. We learned that there could be pulmonary embolism associated with the coagulopathy, and we and others showed it on CT scans. You could find the thromboembolism in the pulmonary circulation, and this actually could contribute to death in some patients. And then, of course, with the release of many mediators, there is a risk of distributive shock. So all of this led us to consider the importance of preload, giving fluids to patients who need it, using a fluid challenge technique. Initially, people didn't do that, unfortunately. And many patients died in multiple organ failure associated with altered tissue perfusion. The addition of dobutamine in some patients was very effective. That's what we call the dobutamine challenge, to improve peripheral oxygen supply. And finally, for the last 4 minutes, prioritization. We often experience a full ICU with some difficult choices to make, but here it's worse, of course. And we know that when there is a high surge of patients, there is significant increase in the number of deaths because the quality of care is not as good as usual, and because we have to make some difficult choices. And this is very complex. It's a matter of proportionality of care. Should we do everything for everybody? Of course not. An elderly patient, a frail patient, at the end of his or her life would not benefit from mechanical ventilation. And it's not a good idea to start it. The survival is very unlikely for these patients being severely ill. So I like this sentence of a woman who says, you know, keep the respirator for someone else. She was a Belgian woman, but it's reported in the English press. So we had to apply the ethical rule of distributive justice to use our facilities in the best way we can, avoiding to have full ICUs with people who are clearly hopeless. So it starts with triage, and we had to go back and re-explore the principles of triage with consistency of the decision and with clear objective criteria. This has been published now quite many times. People had to use scores, a clinical frailty scale, a prognostic score, so that we all use the same tools to decide who should go in the ICU and who should not. And, you know, we had to be reminded that it's not only COVID-19, but that other patients, non-COVID-19, sometimes need ICU as well. So we cannot say that our ICU is full Sorry, what can I do? Yes, we cannot apply the first come, first served basis. We cannot use that. We must go back and see how we could make a bed available for someone else. It's not lottery either, because it's not just 2 patients for one single bed. It's much more complicated than that. So lottery does not really apply. So we have to give up for some patients, and this was difficult for some younger doctors, and we had to help them. We had to help them to consider that we cannot apply mechanical ventilation in every single patient. We cannot apply ECMO in every single patient. I encourage you to read this paper, which was just published 2 days ago in The Lancet, where these authors review very well the respiratory management, and they leave a good place for the question, is it appropriate to escalate treatment in this particular patient? When we use ECMO, it's not only, the decision is not only for this particular patient, but for the other patients in the ICU, because the nurses will be busier with the ECMO and they will have less time to take care of the other patients. So that's something which is important ethically, and some people neglect these aspects at the end. Mortality due to COVID, at the end, many patients could die with COVID, but they may not die from COVID. And so we need to take that into account as well. When a patient dies with COVID, it's not necessarily a COVID case. And finally, we need psychological support for everybody. Virtual visits, that's also something we learned. The family members can help a lot. Doctors have a face, and they could present their pictures for the patient to know who they are. It's not only doctors, it's also nurses. And let's try to keep the patient happy and the team happy. Remember this doctor who committed suicide after a night on call in New York City. So we need to support our teams and make sure that they can still be there on the next day and continue to take care of these patients. That's what we learned as well. And that's what we appreciate every single day now. They still need to be encouraged. They still need to understand that we work as a team. And this is always a very important aspect of our job. So this was a very quick overview, but my time is over. So I'll stop here, and I'll emphasize that we have made much progress. We can be proud of what we have done, and we learned a lot. Thank you.
Thank you, Professor Vincent. Since we are running exactly on time, let's go to the next talk, which is by Professor Daniel DeBacker. Daniel DeBacker, again, is no stranger to India and to our audience. He's going to speak to us on whether vitamin C is a magic bullet.
Hello, my name is Daniel DeBacker, and it's my real pleasure to discuss with you the role of vitamin C in septic shock. And in particular, is this really a magic bullet as it was presented by some? So we have data regarding the relevance of vitamin C or ascorbic acid on the multiple effects it may have in septic shock, including promotion of vasopressor, epinephrine particle synthesis, bacteriostatic effect through different ways, impact on microvascular perfusion impact on cellular apoptosis, impact on endothelial dysfunction, and all these factors may indeed play a relevant role in the potential effect of vitamin C in sepsis. So the buzz about the use of vitamin C was really around this trial which was showing that vitamin C, in addition to hydrocortisone and thiamine, in patients with severe sepsis and septic shock, was associated with a rapid decrease in SOFA score and a decrease in mortality, especially compared to the predicted mortality and predicted to a historical control group. So of course, this was not a randomized trial, but there was a lot of noise around that trial, a lot of discussions in many blogs. And then, of course, this was really a topic of huge interest in septic shock. It was such that indeed the vitamin C cocktail for sepsis was indeed proposed, and that there was minimal evidence about its effectiveness. Well, it's yes and no, because indeed, if we look back at some data we have in the on this, we can see that indeed we have experimental data showing that an animal predicted to die based on hemodynamic features. It improved hemodynamics, it improved oxidative stress, it improves the survival in these animals. Interestingly, it has no detrimental effects in the animals that were predicted to survive. It was really in the most severe animals that it was useful in these conditions. And it has a lot of impact, especially at high doses, on the inflammatory response. It is some impact on blood pressure, because indeed the vasopressor dosage was decreased. There was preservation or increase in cardiac output. There was some preservation of heart rate, less tachycardia in these conditions. Also, renal perfusion was improved with an increase in the renal blood flow. In addition, an improvement in the medullary oxygenation, an improvement in the creatinine clearance in these animals. So it seems to be really very attractive in these conditions. The blood lactate also decreased quite markedly. In humans, we have a little bit of data up to now. I mean, more complicated, of course, to have. And it seems that indeed, in a phase 1 trial, there was some improvement in the SOFA score, especially at high doses. It also may have some impact on blood pressure. Indeed, you can see here that this cocktail was improving the norepinephrine dose very rapidly compared to the control patients. And in many trials, it has been shown to indeed improve the hemodynamic states by increasing arterial pressure, increasing vasopressin release, decreasing heart rate, maintaining cardiac output in many of these patients. So one of these trials here showing indeed preservation of blood pressure and some impact here on the synthesis of norepinephrine and epinephrine through the metabolism here from dopamine to norepinephrine, which is dependent on the presence of ascorbate. So indeed, it can have some impact here. The same is true also for vasopressin to be transformed into the active form. We also request the ascorbate to be effective there. Some impact on endothelial function. Yes, there are also a lot of data here. It may improve the microcirculation even when it is given long after the insult in experimental models. And it seems indeed to be very effective here in these conditions. It has been shown repeatedly in several models, always showing indeed that it improves the microcirculation. It may act through modulation of the endothelial nitric oxide synthase by several mechanisms, but here it's mostly the most important one. You can see that indeed animals who were knocked out for the endothelial nitric oxide synthase failed to have any beneficial effects from ascorbate, while animals who were knocked out for other types of NOS were indeed still responding to the ascorbate in these conditions. One of the reasons why it may be so is because ascorbate is very important in promoting BH4 and transforming BH2 into BH4. And BH4 is a very important cofactor of the endothelial nitric oxide synthase. And it helps to maintain this enzyme coupled so that indeed it will produce nitric oxide and not transform oxygen into radical oxygen species in this condition. And we have shown that giving exogenous BH4 is associated with preservation of the microcirculation and improvement in permeability, improvement in organ function, and improvement in outcome in these animals. And others have found repeatedly exactly the same aspects in animals. And this is true in sepsis, but also in hemorrhagic shock and thus ischemia reperfusion injury in these animals. It could also have some impact on the vascular permeability. You can see here that the vascular permeability is improved in endotoxic animals receiving vitamin C in these conditions. And also, it can here, also you may see here, decrease the vascular leakage associated with sepsis and peritonitis in these animals. Again, the permeability was improved here by giving ascorbate in these conditions. So there was here some impact here on the plasma volume was also preserved in these animals, given the fact that vitamin C was given here and increasing urine output in these conditions also. So all these factors indeed suggest that vitamin C is quite effective in preventing some detrimental effects of sepsis. Some other mechanisms can be also implicated, maybe some anti-inflammatory effects, and also perhaps some anticoagulant effects also with the drugs. And very importantly also, it may also affect the development of trap nets. Traps are indeed something occurring in response to infection. It is beneficial, of course, in relatively focalized aspect, but not when it becomes diffuse throughout the vascular system. And then, of course, giving vitamin C may limit the development of trap nets in these conditions. Vitamin C has been shown to be somewhat useful in preventing also the inflammatory processes here after cardiac surgery, which is a good model of acute inflammation, of course. What about vitamin C in randomized trials? Well, we need to look at the data here, and admittedly, up to the MARIC trial in 2017, there were minimal randomized trials. But there was just after this a huge amount of trials that were published. Up to now, 8 to 9 trials have been published. A randomized trial looking at the impact of vitamin C in sepsis in different settings. One of the most important one is probably that from the citrus acute lung injury trial from Fowler and collaborators, who showed that indeed the primary endpoint was not reached. It was the decrease in SOFA score here. But it was very intriguing to see that vitamin C markedly decreased, significantly decreased the mortality in these patients. And interestingly, you can see that the effect was observed already here in the very early window during the therapy. So, of course, because this helped some patients to survive, probably the most severe one. The most severe in the therapy group were surviving this 3 group, while the other one were not. And so indeed, what we observed is that the in the patient dying, the high SOFA score was indeed still high, because indeed the non-survivors survived to that point, while the non-survivors died during that period of time, while the survived remained active there. So there was an imbalance toward a higher SOFA score in the survivors, because there was no elimination of the other patients. So there was another trial just after this, the ACTS randomized trial, that also found that there was no impact on the SOFA score here. Interestingly, that trial failed to find any impact on mortality. So what we just discussed about the citrus may not really be valid in that other trial. However, there were some other trials later and later, and the VICTAS is the latest one from the American group led by John Sevransky, and they found no real impact on mortality of the intervention. So we say, okay, perhaps the game is over. Well, if we look at the meta-analysis, and we have several ones, at least 3 published in 3 different issues this summer in critical care medicine, you can see that indeed these trials had some impact on the SOFA score by decreasing the SOFA score, and this was highly significant when all the trials were aggregated. So the minimal signal was observed there for each of the trials, and aggregating these trials was leading to an improvement in outcome. There was no major impact when we look at which part of the SOFA score on renal function. So it was mostly due to the improvement in hemodynamics that indeed there was some improvement in the SOFA score. 28 days mortality, no real impact here in all these trials. Here we can see that we are far from reaching this, even though we have to admit that we do not have yet enough trials for renal replacement therapy, and perhaps even for 28 days mortality in these conditions. So looking at some additional meta-analysis, including more trials, then you can see that indeed short-term mortality may perhaps be somewhat affected. At least there is a trend here in that direction, even though it was not reaching significance. Importantly, if we look at the total number of patients, it's less than 1,000 in each group. So this is really a major problem, because all these trials in isolation should have at least 1,000 patients in each arm to show a significant difference in mortality. So we are making some meta-analysis of small, underpowered trial, and we try to see whether or not there is some impact on mortality. So we are still a bit in doubt whether or not it may be effective in improving the mortality. There was some interesting other data from the other meta-analysis, and perhaps this aspect here, we can see that the most severe patients may perhaps benefit more from the vitamin C than the less severe patients. Also, the combined therapy may be perhaps less effective than the isolated administration of vitamin C. And looking also at the high of the doses, we can see that the high doses have really a single or even a significant difference in towards a beneficial effect, while lower doses do not have. So it may be a dose effect and also a combination effect. And again here, monotherapy was effective, but not combined therapy in these conditions. So where do we stand? Is it a magic bullet? No, definitely no. Perhaps a trend and a signal towards an improvement in hemodynamics, and some doubt about the potential beneficial effect on mortality that really needs to be evaluated in larger trials. So the problem will be patient selection. When do we give it? Just on clinical criteria, or do we need vitamin C dosages? Timing of intervention, also very important. Dosing scheme, probably high doses. Combined with timing, maybe not. And toxicity, obviously not from the current trials. And with this, I thank you for your attention.
Thank you, Professor Daniel De Backer, for a very nice overview of vitamin C. Next, we have Professor Mark Leone, and he's going to talk to us about septic shock, the endpoints of macrocirculatory resuscitation. bread and butter of routine intensive care. So Professor Marc Leon is from France, and his expertise includes sepsis and trauma in the critically ill patient. So let's, without wasting any time, listen to some.
Ladies and gentlemen, my pleasure today to present septic shock endpoint of microcirculation and resuscitation. By the fact, my name is Marc Leon. I work in intensive care unit and I chair the Department of Anesthesiology and Intensive Care Unit in Marseille, France. I really want to thank warmly the organization committee for this nice invitation. My conflict of interest and the 3 points that we'll develop in the few next minute define the septic shock, to show that standard criteria of resuscitation are not relevant, and finally to conclude that relevant criteria should be associated with outcomes. So first, briefly, I will define the concept of septic shock using the new definition, the 2016 definition, published by a group of experts led by Myriad Seeger. So septic shock is a suspected infection with several organ failure with a SOFA score above 2 or an increase in SOFA score of 2. That's the definition of sepsis 3.0. And to achieve the definition of septic shock, you need to have a serum lactate above 2 and the introduction of norepinephrine. So that's the definition of septic shock. So what are the standard criteria for septic shock resuscitation? The first clinical endpoint, which has been used by the Surviving Sepsis campaign in the first set of campaign in 2008 and 2012, where CVP in the target of 8 to 12, mean arterial pressure above 65 mm/Hg, urine output above 0.5, and SCVO2 or SVO2 above 70% or 65%. I just remind you that these criteria were used by the group of Emmanuel Rivers that published the early goal-directed therapy paper in the New England in 2001. And using these criteria, they improved the outcome of the patient admitted for sepsis in their emergency department. Unfortunately, these findings were not confirmed in 2 multicentric randomized controlled trials, showing that there was no effect of the use of the early goal-directed therapy using those criteria, and questioning about the relevancy of these criteria to manage this patient with septic shock. I will point out just few examples now to show that these criteria are probably not enough to be determined as a clinical endpoint. First, CVP. CVP is more a criteria of fluid responsiveness than a criteria of outcome. And even for fluid responsiveness, as you can see in this systematic review, grouping all the CVP in Y-axis, and as you show in X-axis, the deficit or excess of blood volume, and you can see that there is no relationship between the blood volume and the CVP. The CVP is a poor marker of fluid responsiveness and is very, very poor marker of outcome in those patients. So that's not a relevant criteria. Mean arterial pressure should be above the magic number of 65 mm/Hg at the initial stage of management. That's true, and we all agree with that, but it is not necessary to increase this level of MAP above 65 or to 85, for example. There was several randomized controlled trials, including one French trial showing that there is no effect, and a systematic review published by Lamontagne and colleagues showing that higher and lower blood pressure targets in patients with subjective result in similar findings and similar results. So there is some that makes sense to increase MAP above 65 in the first hour of sepsis. But after that, there is no signification to increase mean arterial pressure above this magic number of 65, and we have to personalize the approach, because in fact, we show in paper published in anesthesiology that using these criteria, CBP, MAPS, SpO2, urine output in our patients, and we were in the target for these endpoints. And we look at the microcirculation using tissular oxygenation. And as you can see, there was a very significant difference between survivor and non-survivor in terms of SpO2 between the two groups, showing that these macrocirculatory parameters were not coupled with microcirculation and were not relevant in terms of microcirculation. And finally, Dubin and colleagues nicely show that there is no relationship between the mean arterial pressure above 65 and the capillary macrovascular flow index. And this clearly underlines that there is no need to increase the blood pressure in most of our patients, except in a few cases. So the MAP by itself is not a relevant goal to resuscitate our patient. SpO2 is very critical endpoint because that's summary of hemoglobin level, VO2, SpO2, and cardiac output. But in fact, in our patients with septic shock, especially those in ICU, the low level of SpO2 below 70% is a rare event occurring in 5 to 10% of patients, not more. And that's not discriminant variables for predicting the outcome of patients. Probably high SpO2 may have a discriminant value, but there is less paper on that. So SpO2 and low level of SpO2 should not be used as a clinical endpoint for the resuscitation. So the standard criteria, CBP, MAP, urine output, SpO2, should be used. There is no problem with that, but they are poor predictor for outcome, and thus, consequently, in my opinion, they are not relevant as clinical endpoint for the resuscitation. They are not performant enough, and they are not relevant. So our microcirculatory endpoints should improve short-term outcome, improve long-term outcome. And we have to identify hemodynamic variables associated with poor outcome and associated with microcirculatory dysfunction. So I like to use this example. This group of experts looked for the criteria associated with refractory septic shock. And they use 4 clinical cases of septic shock and a group of more than 100 pediatric intensivists to run their field survey to determine the best criteria for defining the refractory septic shock. And if we can define a refractory septic shock, we can have the relevant endpoint for resuscitation. And after that, they use a validation cohort, which is very interesting. And finally, they find 2 scores, one computed septic shock score based on a formula including the vasopressor dose, the arterial lactate, and the presence or the absence of myocardial dysfunction. And there is a number of points which is attributed to each variables. But the 3 variables which are interesting are the dosage of vasopressor, the arterial lactate level, and the presence or absence of myocardial dysfunction. At the bedside, they constructed a score on 5 points. And once again, this the vasopressor dosage, the arterial lactate level, and the myocardial dysfunction, which are the relevant endpoint. They use a cohort for validation of this score, and as you can see, the performance of this score are very high, showing that it is really relevant clinically to use these 3 criteria to guide our resuscitation. We look at that with a group of experts from the EasyCom using an online survey, and we receive 820 questionnaires from 75 countries. And what was the criteria for introducing, for example, a second vasopressor, and that was a dosage of norepinephrine above 0.5 microgram per kilo per minute. And that's a really important response, because in fact that's not the level of MAP which is relevant. That's the dosage of norepinephrine, and we show with others that there was a relationship between the dosage of norepinephrine, and as you can see, when the dosage is above 1 microgram per kilo per minute, the mortality reached 90%. And when the dosage reached 0.5, the mortality reached 50%. And that was confirmed by other groups and other publications. So this is really relevant as endpoints to know that your patient has poor outcome if the dosage of norepinephrine is above 0.5, and you have to do something against that. The second point is the indication for inotropes, for positive inotropes. And what was the indications is the low cardiac output detected by ultrasound or thermodilution or sustained hypoperfusion for most respondents. So in summary, this survey shows that for clinicians, which is relevant in terms of outcome is norepinephrine dosage above 0.5 or low cardiac output detected by ultrasound or thermodilution or any other method. So we had this question: is this clinically relevant? Is this finding are clinically relevant? And so with my group, we use a multicentric cohort that we published 2 years ago in Shock. looking at the venous to arterial carbon dioxide partial pressure difference and looking at this criteria as predictor of outcome. And we use this cohort, this multicentric cohort, to determine 3 phenotypes of patients: a safe phenotype with low mortality and the low worsening in terms of organ failure, illustrated by the difference in SOFA score between T0 and at day 2. An intermediate cohort of patients, an intermediate phenotype with a mortality around 25%, and a poor phenotype associated with a high 28-day mortality and high organ failure worsening. And we use several step analyses based on a quite complicated statistical model. And what we show that the first step is the dosage of norepinephrine above 0.5, and we find the same number. So the use of norepinephrine above 0.5 was associated with a poor outcome. The second step shows that the lactate level above 3.4 was associated with a poor outcome, and the third step was a PCO2 gap above 6 mmHg was associated with poor outcome. So our phenotype analysis looking for variable associated with poor outcome, day 28 mortality or clinical worsening, where the dosage of norepinephrine at T0 and T6, and the serum lactate at T0, T6, and the PCO2 gap at T0 and T6. So the phenotype analysis, 3 variables, important to keep in mind: norepinephrine dosage above 0.5, serum lactate above 3.5, and PCO2 gap above 6 mmHg. So my take-home message is that the standard criteria, CVP, mean arterial pressure, urine output, SpO2, they are good criteria, and we still should use them, but they are not relevant in terms of outcome, and they should be used, but are not enough to guide our resuscitation. I will suggest, after the literature analysis and our database analysis, that 3 variables are associated with outcome and should be regarded as relevant as clinical endpoint: is norepinephrine above 0.4, serum lactate above 3.4, and PCO2 gap above 6 mmHg. And these 3 variables are stronger predictors than all the other, including MAP, SpO2, urine output, or CVP, or any predictor of fluid responsiveness. The benefit with these 3 variables is that they make the relation between the microcirculation and the microcirculation, which is the main determinant for the outcome of patients. So I hope that this message is clear for you, and I will be happy to respond to your questions. Thank you very much. Bye-bye.
Thank you, Professor Mark Leon. We are now at the end of this session 3 on sepsis, where we heard Dr. Daniel De Backer and Dr. Mark Leon speak to us on vitamin C, maybe high dose, some role in reduction of mortality. And clearly, what we know is that the endpoints of macrocirculatory circulation, the usual ones, are probably not relevant. So we need to combine macrocirculatory and microcirculatory goals in order to adequately resuscitate our patients. The prediction of mortality using a phenotype analysis where the norepinephrine dose of 0.4 or more and lactate of more than 3.4 and the veno-arterial CO2 gap of more than 6 may predict a higher mortality. So thank you for listening in on this session. For the next session, we have with us Dr. Urvi.
Good morning, all. Very warm welcome to joining the Best of Brussels today. We will start the session 4 on mechanical ventilation. Our first speaker is Professor Ricard. He has co-authored 160 peer-reviewed articles and participated in 9 clinical trials in the past 15 years. His areas of expertise are pneumonia, cerebral hypoxia, ARDS, and pulmonary edema. So, Professor Ricard.
Hello, everyone. My name is Jean-Damien Ricard. I'm very happy to be with you today. I will be addressing the question of nasal high flow in the ICU. So I work in a medical surgical intensive care in the suburbs of Paris. Here are my conflicts of interest in relation with this talk. Fisher & Paykel covered expenses to attend scientific meetings, and they are providing over 2 devices to centers that participate to a randomized control trial I'm currently running. So nasal high flow has undisputedly found its place in the treatment of acute hypoxemic respiratory failure. And COVID-19 has further shown the importance of this non-invasive oxygenation ventilatory support. Although this universal use of nasal high flow is welcome and should be encouraged, it's my belief that clinicians must be aware of potential dangers and pitfalls of this technique, and this is what I will be addressing. It's interesting to see that someone wrote 10 years ago that nasal high flow might be an interesting therapeutic option in case of massive outbreak of respiratory failure due to a pandemic, in instances of limited or exceeded capacity of invasive ventilation. And I was reminded by a colleague that, in fact, it was our team that wrote this 10 years ago. So nasal high flow, as reported here in this narrative review, I was very happy to coordinate and published in Intensive Care Medicine. You can see all the beneficial effects of nasal high flow: adequate humidity, dead space washout, increase of FiO2, increase of airway pressure, and all this leads to a decrease in the respiratory drive and the work of breathing of the patient and increases comfort. Importantly, I think it's very important to remember that most of these effects are only seen with a high level of flow at 60 liters per minute. And this is often overlooked. And it's very important to pay attention to the settings of nasal high flow. And clearly 60 liters per minute is not 50. So what do we expect from nasal high flow in acute hypoxemic respiratory failure? On the patient's perspective, obviously, the patient is interested in having alleviation of dyspnea, improvement in oxygenation, and decrease in work of breathing. And what is expected is this will avoid intubation and hopefully avoid mortality. On the healthcare institution's perspective, this will lead to reduced demand for ventilators, delay or even better still, avoid ICU admission, or help manage ICU bed shortage. Alleviation of dyspnea and oxygenation has been shown very early in the studies of nasal high flow. In one of the very first studies we published on nasal high flow, we were able to show that very early after the initiation of nasal high flow in patients with acute hypoxemic respiratory failure, respiratory rate, dyspnea, and use of accessory muscles decreased very early in less than 15 to 30 minutes. Avoidance of intubation has been documented and reported in the most hypoxemic patients in the Florali study published in the New England, as shown on this figure. In patients with PF ratio below 200, there was a clear reduction in the need in intubation in the patients treated with nasal high flow in comparison with those treated either with non-invasive ventilation or with standard oxygen. And this was associated with a decrease in mortality, as shown on this Kaplan-Meier curve. Clearly, the red curve is above the two others, indicating that there was a greater survival in patients treated with nasal high flow as first-line therapy when admitted to the ICU for acute hypoxemic respiratory failure. In the COVID pandemic, we have several examples of the increasing use of nasal high flow. I will illustrate this with two studies. The first one comes from France, published in Intensive Care Medicine. As you can see, clinical characteristics and outcome of over 4,000 patients were reported in this study. On this figure, you can see different periods of the first wave of the pandemic before March the 15th in light brown, between the 16th and 31st of March in green, light blue, from the 1st to the 15th of April, and in mauve after the 16th of April. And you have the different oxygenation and ventilator supports that were used and 90-day mortality. As you can see, during the period, we have an increase in the number of patients treated with nasal high flow. This was associated with a decrease in the number of patients intubated at day 1, an overall decrease in the use of invasive mechanical ventilation, and there was also observed an important decrease in 90-day mortality, as you can see on the slide, from 42 to 25%. Obviously, there are several confoundings, and the therapeutic options of these patients were improved during the time, and this may also contribute to improved mortality. But nonetheless, this study indicates that the more you use nasal high flow, the less there's need for intubation, and all this concurs to reduced mortality. And the second study is this one coming from England, Wales, and Northern Ireland. They looked at the patients treated during the first wave, just before, during the peak, and just after the peak. Here's just a busy slide, but just to illustrate that these patients were very similar in terms of severity during these three phases, before the peak, during the peak, and after the peak, indicated in blue, red, and green. And also too in terms of clinical parameters, PF ratio, incidence of acute renal failure. All these parameters were similar during these three phases. What changed during these three phases was the receipt of invasive mechanical ventilation. As you can see, the severe drop in the use of invasive ventilation between the pre-peak and the post-peak period. And this was associated with a decrease in 28-day mortality. And on the last figure at the bottom, you can see that the adjusted 28-day mortality was significantly reduced in the post-peak. There again, suggesting that when we have less invasive mechanical ventilation for the same severity of patients, we have an improvement in outcome. And this study, also from France, indicated the use of nasal high flow in comparison with other supports of oxygenation. Over 350 patients were included in this study. Half of them were treated with nasal high flow, and another part were treated with other supports, either non-invasive ventilation or conventional oxygen. On this slide, you can see that those patients who were treated with nasal high flow had a reduced need for invasive mechanical ventilation at day 28, from a reduction from 72% in those who were not treated with nasal high flow that dropped to 55% in those that were treated with nasal high flow. Another illustration of the benefits of nasal high flow to avoid intubation was reported from our group. We report here our experience of the first wave with over 60 patients treated with nasal high flow as first-line ventilatory support. A third of our patients did not require intubation and were discharged live, whereas 2/3 did require intubation. These were very severe ARDS-related COVID-19 infection. Median time to intubation in these patients was 10 hours. And so we can suggest that a nasal high flow may have avoided intubation in 1/3 of the patients. So clearly these data illustrate the benefits of nasal high flow in the ICU. However, as I mentioned, there are potential pitfalls and danger of high flow oxygen. One is the overuse of nasal high flow, that is the excessive prolonging of high flow with the risk of delaying a needed intubation. And the way to avoid that is to try and have an early recognition of patients that are failing under nasal high flow. The other pitfall is the underuse of high flow with inappropriate flow titration, and the risk is high flow failure, not because the patient is not improving enough, but simply because the device is not set properly and does not bring the maximum capacity to the patient. And the way to avoid that is obviously to optimize settings. We want to illustrate the underuse, this underuse of nasal high flow. I will take one study coming from Spain during the 2009 influenza pandemic. A proportion of patients were treated with nasal high flow. As you can see, 20 patients were initially treated with nasal high flow, 9 succeeded, and 11 were subsequently ventilated. When we look at the flow delivered to these patients, you can see that the flow was relatively low, between 25 and 30 liters per minute. So the question is, how would have these patients evolved had they received a much higher flow? Perhaps some of them would have avoided intubation. And there again, you can see that there's very few improvements in ventilatory parameters when nasal high flow is only 30 liters per minute in comparison with what occurs at 60 liters per minute. In the recovery respiratory support trial that has been released but not yet peer-reviewed, it's important to note that there again, mean flow, and there was no protocol for the way to conduct nasal high flow in this study, was 50 liters per minute. And once again, I show you again this study coming from Tommaso Mari, clearly indicating that all the benefits are shown with a flow of 60 liters per minute. So this is really of paramount importance. The overuse of nasal high flow, as I mentioned, is the excessive use or the prolonging of nasal high flow when clearly the patients would need to be intubated. This has been illustrated from this study where investigators looked at all the parameters and characteristics of patients that were intubated after initiation of nasal high flow. And they separated their cohort in two groups. Those patients that were intubated early, within 48 hours after initiation of nasal high flow, and those that were intubated late after 48 hours. Mortality was strikingly different between these two groups. As you can see, 39% mortality in those intubated early and over 65% in those intubated late. This is a very high level of mortality. When we pay a closer attention to the patient characteristics and we look at when and how long these patients did really actually have nasal high flow, you can see that in the early intubation group, the median duration was only 10 hours, although the cutoff was set at 48 hours. But in reality, these patients had a median duration of therapy of only 10 hours. On the opposite, those patients in the late intubation group had over 125 hours of nasal high flow before being intubated. And this is 5 days. So clearly we can suspect that these patients had an excessive prolonging of the use of nasal high flow, and this may explain the very high mortality rate in these patients. So clearly the question is, how can we identify those patients that are failing under nasal high flow and that require intubation? With my colleague Aryo Roca, we established an index called the ROX index, which is the oxygenation respiratory rate index, to try and predict outcome with nasal high flow. The way we constructed this index is that we looked at all the parameters that were different between patients that succeeded and those that failed nasal high flow. And we found that those parameters that was the most different between two groups were those that constructed the score, the SpO2, the FiO2, and the respiratory rate. And so this score is built up by the fraction of the SpO2 over FiO2 and divided by the respiratory rate. So these are clinical parameters that are always available at the bedside, and so this score can be repeated over time. And as you can see on the right of the slide, the Kaplan-Meier of the cumulative probability of being free of mechanical ventilation, so of not being intubated, was very high in those with a ROX index above 4.88 and much lower in those patients that were below. And we confirmed the performances of this index in a totally different independent cohort of patients, there again showing the same results, the very good performances of the index with the cutoff of 4.88. So those patients with the ROX index at 12 hours above this index had a very high probability of not requiring intubation, and those below had a higher proportion of intubation. When we applied this index to our patients suffering from ARDS related to COVID-19 infection, we were able to confirm our results. As you can see on this Kaplan-Meier curve of cumulative incidence of intubation, those patients who had a ROX index above 5.37 had a much lower incidence of intubation in comparison with those that had a score below. The question is, why did we have a different value of the ROX index between our former publication and this one? One easy answer is, as you know, patients with COVID-19 had generally much lower respiratory rates than non-COVID acute hypoxemic respiratory failure. And because the respiratory rate is the denominator of the score, then it makes sense that the overall result will be a slightly higher value. Interestingly, others investigations around the world have also confirmed the potential for the ROX index to predict outcome. And it's easy now and readily available on smartphones where you can very easily calculate the ROX index, and nurses can do that at the bedside. I think it's important to state that the ROX index should be a dynamic evaluation within the first 12 hours. If the ROX index increases, then there's a lesser risk of intubation. And if the ROX does not increase or decreases, then there is a greater risk of intubation. There's obviously a gray zone between the two values I had indicated, 4.88 and 3.85. Importantly, in our study, we found that only 11% of the entire cohort were inside this gray zone, and only 1/3 of them did require intubation. So the message is that very few of these patients have an indeterminate score, and even among these patients, very few required intubation. And the importance, as I mentioned, of a dynamic evaluation is to repeat the score. And this is what we show on this right part of the slide. In those, when we repeated the score, those patients who increased their ROX index. So the delta ROX was above 0.5, they had a higher probability of success. And those patients who either had a lower ROX index was a delta ROX that was below 0.5, as you can see on the red points, these had a higher incidence of failure. So this stresses the importance of repeating the score and seeing in which way the ROX index was changing. An important question is, well, how does the ROX perform versus traditional respiratory criteria? When we looked at this question and set the respiratory rate as criteria for intubation at 35 breaths per minute, we had, as you can see on this slide in blue, a high proportion of patients that did not meet the respiratory rate criteria for intubation. So they had a respiratory rate below 35 breaths per minute. However, they met the ROX index for intubation. And the interesting question is, how many of these patients did actually require intubation? And as you can see, a very high proportion of them did require intubation. So clearly, the ROX index seems to be performing better than traditional criteria. One last aspect of the use of nasal high flow in acute hypoxemic respiratory failure is to combine it with awake prone position. This has been very nicely addressed in a meta-trial recently published in the Lancet Respiratory Medicine Journal. This study compiled, in fact, several studies, randomized controlled studies in the world, and they decided to group their results. And this is what is this meta-trial. As you can see, over 1,000 patients were randomized either to receive awake prone positioning or standard care. And the primary outcome was based on treatment failure that comprised both need for intubation and mortality. And as you can see, those patients that were positioned prone during their ICU stay had a higher probability of survival without treatment failure. And when we look at the intubation rate, there again, those patients that were turned prone had a greater incidence of survival without intubation. So prone position reduced the need for intubation in these patients. Interestingly, the ROX index was there able to show the improvement of oxygenation in these patients. As you can see on the left, those who the ROX index increases when the patients are turned prone. A very important result on the right-hand side of the slide is the duration of the prone positioning. And authors were capable of showing that there's a clear cutoff if patients were able to stay prone for more than 8 hours. And clearly those patients who were with a prone positioning more than 8 hours had a much better outcome than those who did not. Take-home messages. I think and I hope I've convinced you that nasal high flow should be offered as first-line ventilatory support in ARDS patients, either non-COVID as well as COVID patients, in the absence of criteria for immediate intubation. Clinical surveillance of these patients is mandatory. Inappropriate use of nasal high flow is clearly associated with worse patient outcome, so it's very important to identify early these patients who will require intubation and avoid excessive use of nasal high flow. And the ROX index may help decide as to when to intubate these patients. And last point, it is very important to optimize the flow settings, bearing in mind that all the beneficial effects are flow dependent. So the higher the flow, the greater the benefit. Thank you very much for your attention.
Thank you, Professor Ricard. The next speaker in today's session is Professor Girardis. He's going to be speaking on conservative oxygen therapy and permissive hypoxemia. He has numerous assignments as well as a rich corpus of publications and scientific activities. He is an associate professor at the Department of Surgery, Medicine, Dentistry, and Morphological Sciences, and his special interest is in transplantation, oncology, and regenerative medicine. Professor Girardis.
So, good morning, or good afternoon, or good night. Depends on your time. It's a great pleasure to be here for me to discuss with you one of my favorite topics, that is the appropriate use of oxygen therapy in critically ill patients. I'm Massimo Girardis. I'm an intensivist working in Modena. Modena is a small town in the northern part of Italy, very famous for the Ferrari cars, but also for Luciano Pavarotti as a singer. I want, before to start, thanks the organizing committee for this opportunity to be here to the best of Brussels 2021. And in the next 15 minutes, my final goal will be to convince you that oxygen is a very important and dangerous therapy, and then we have to stay more focused on the correct application of this therapy in our patient. And also, I want to discuss with you to make a sort of order in the recently published trials on liberal and conservative strategies in our patient, intensive care patient. I think that some clarification is necessary in this patient. So, for this trial. So, I want to start with my conflict of interest, and I have no specific conflict of interest concerning this presentation. And I want to remind you the problem of oxygen. Since the beginning of the story of oxygen in the 18th century, oxygen has been considered a sort of magic molecule with some important and beneficial effects, but also with important harmful effects. And I think that another important point is that oxygen defies easy classification, and particularly today, to say what is normoxia, hyperoxia, and hypoxia is quite complicated, particularly in different pathophysiological conditions, as patient with brain trauma, patient with myocardial infarction, or patient with sepsis. Starting from this point, I also want to highlight that oxygen is probably the most used therapy, as I said before, and that in many of the clinical practice guidelines, specific limits for the low level of oxygenation, in terms of when to start oxygen, has been defined since many years, but the limits of oxygen saturation when we have to stop oxygenation, or oxygen therapy, sorry, has been introduced only in the last year in some guidelines. This is the reason why many of the ICU patients spend, as I said before, substantial period in hyperoxemia, in intensive care, as well as during emergency treatments or during surgery. And there's a reason why, because for the majority of the physician treating patient, mild hyperoxemia means PO2 level between 100 and 200 are considered safe, and that probably at that levels, the oxygen concentration in the blood is considered without no harmful effects. Safe in terms of buffer, avoiding hypoxemia, and no harmful effects. It's correct or not, I don't know. Here you have as I mentioned before, the guidelines on oxygen therapy in critical medicine. And you can see that only since 4 years ago, we have some indication for the upper limit when stopping oxygen therapy, only in 2 guidelines published, one from UK and the other from Australia. And as you see, the limits usually are in clinical practice, the 98 and 97 is always not respected as an upper limit in many patients. For sure, in ambulance, for sure, emergency department, for sure, at the beginning of intensive care management. But what we know about the effects of hypoxemia and hyperoxemia. In this slide, I disagree with the values in the x-axis. It's clear from pathophysiology as well as animal studies that hypoxemia as well as hyperoxemia may have detrimental effects. Hypoxia may cause many dangerous effects at the cellular and mitochondrial level. The same is for adrenergic response. The same is for pulmonary hypertension. But when we move to hyperoxemia, the effects are not different from hypoxemia. We have pulmonary effects, a very high level of oxygen concentration in the lung. We have induction of immune response, particularly apoptosis of immune cells. For sure, oxidative stress in all the cells of our tissues may be vasoconstriction. This is the reason why I think that it's not correct to say that having a safe buffer using PO2 levels between 100 and 200 is not harmful. But this is only a matter of discussion, or is this true? I think that the question today is not if hypoxia is better than normoxia or if high hyperoxemic level is better than normoxia. The problem today is to define which are the limits of target therapy. And for me, these limits means conservative strategy. I have to maintain my patient in the target and to avoid hypoxemia and to avoid unnecessary hyperoxemia. So the problem is which are these targets? Do we know in our patient where is the lower and the upper limit for this conservative strategy? Again, I want to repeat, conservative strategy means to maintain your patient in the target without any harmful effects of hypoxemia and hyperoxemia. Conservative strategy doesn't mean to maintain the patient at hypoxemic level. This is, I think, the most frequent confusion in the trial, as well as in many of narrative review that I had the opportunity to review in the last months, because I think that conservative means to maintain a sort of physiological situation for that pathophysiology of the patient model. We can have different, this is only theoretical model, we can have different U relationship. One is on the left part of the slide, you have patient where the conservative strategy, you have the same threshold in terms of upper and lower limits, but the susceptibility to hypo and hyperoxemia is different from the patient. This is clear. In healthy subject, for very low level of PO2 as well as for very high level of PO2, probably we have very small effects in terms of harmful effects. On the other side, if we move PO2 level in the patient with brain injury or sepsis or cardiac dysfunction, or particularly, not cardiac dysfunction, but myocardial infarction, probably we have important multiple effects. On the right part, you have another theoretical model that is patient with different susceptibility, again, cardiac and septic, but maybe different thresholds for upper and lower limits. Maybe coming from that, using data coming from literature, that septic patient it's better to stay in a sort of lower PO2 level compared to patient with cardiac dysfunction. This is only a theoretical idea, some pathophysiological or observational study, not randomized controlled trial. What we know in real life in patients on this U relationship, and I say in patients with in intensive care, majority of the patients intubated patients. We have until now two studies published on this problem, on the U relationship. The first one coming from Netherlands, published some years ago. The first PO2 value, the mean PO2 value in the first 24 hours in patient admitted to the ICU, and you have a clear relationship between mortality on the epsilon axis compared to effective mortality on the with the changes of PO2 level. And the best and the lowest mortality is in the window between 70 and 80 millimeters of mercury of PO2 level. And the other is our study on intensive care patients, where we observe again a U relationship with the PO2 median value during the ICU stay, with the best performance in terms of mortality between 90 and 95 millimeters of mercury. So if I had to apply the concept of conservative strategy in our patient using real life data, I have to state probably my conservative strategy is probably something between 70 and 100 or 95 millimeters of mercury of PO2 in the blood of our patient. Of course, again, this is a sort of median of the population included in the study, but I think could be an idea, and could be our target in our patient. Of course, patient with chronic respiratory dysfunction could have different values in terms of target, and I think that as a first approximation, I think that this could be considered normoxia in critical patients, mechanically ventilated. What about the new trials? When some years ago, we take a look to the new trials that were ongoing at the time. Now, one of these trials have been published. We looked at the conservative group, particularly in the PANVA trial, the number 11 in terms of references, as well as the ICU ROCKS trial, for sure, allow CO2 trial, and maybe especially in out ICU trial, the so-called conservative group maintain PO2 levels and oxygen saturation level probably below the target that I showed you before, below the so-called normoxia, or at least the normoxia indicated by previous data coming from critical ill patients in real life. So I say it was considered conservative strategy. In my view, no. This could be considered a sort of permissive hypoxemia. And this was quite clear in the liberal conservative oxygen therapy, the LOCO2 trial, where the authors included randomized 200 patients, one for conservative oxygen, the other for liberal oxygen. But in the conservative oxygen group, the half of the patient, as shown in this part of the slide, half of the patient, 58 patients in the conservative oxygen group, had a median of 2 arterial blood gas samples in a range between 33 and 55. It is for sure, lower than the threshold that I showed you before, between 70 and 95. And this is the reason why I think we can call this conservative oxygen, but we have to call permissive hypoxemia. In fact, they observe in the conservative group more mesenteric ischemia. This is the reason why this trial was suspended. More arrhythmia. Interesting to see that in patients with low oxygen level, the ventilator-associated pneumonia as well as septicemia, means blood infection, was lower than in patients with lower liberal oxygen. Was a trend too, not really significant due to the low number of the patient included, but this is a signal. So again, I just want to conclude that for this slide, to summarize this slide pay attention. Conservative oxygen is not permissive hypoxemia. Permissive hypoxemia could be at risk, could pose your patient at risk for high mortality. So, I tried to summarize all the recent published trial on conservative oxygen strategy compared to liberal oxygen strategy in critical age patients in this slide, where you have in the upper part the U relationship with the threshold indicated before between 70 and 95. And in the blue and the yellow box, you have the conservative group and the liberal group as published, not as goal in the protocol, as real data published from this trial. And I start with the first one was our trial conservative group was in with a median of 87 compared to liberal was 102 millimeters of mercury for PO2. Looking into the trial of PANWAR, 103 patients, again, mixed ICU. The conservative was lower than our trial between 78, 73, and the liberal was in the normoxic phase within the threshold. What about ICU ROX trial? Interesting. The conservative group was within the conservative strategy, but the same was for the liberal, because the liberal was more or less in the conservative thresholds between 90 and 108, just a little bit higher than, but it's quite similar. What about the LOCO2 trial? As I showed you before, the conservative was in a sort of hypoxemic group between 65 and 77, and the liberal was quite liberal, but again, the median value was quite close to the threshold of normoxy. The ICU published only in acute respiratory failure patient. This year, in 3,000 patients, they use conservative, which is a sort again of tendency to the low level of normoxia compared to liberal that is still in the normoxic range. Of course, just a more liberal than conservative. Taking just a general look to this data, many of the trial had considered conservative and liberal groups within the threshold, and in some trial, conservative group are permissive hypoxemia rather than conservative strategy. So for me, it's quite difficult to accept that no difference observed say something for the effects of hyperoxemia in critical patients. I think that we have to discuss more on what we believe is conservative strategy and what is really liberal strategy. And for this reason, I think that probably in the last trials, liberal strategy are not really liberal because they appear to be in the normoxic range and without clear exposure to hyperoxemia. I want to conclude with this important, I think, meta-analysis published some months ago. The authors divided the trial in two groups. One is trial with patients with severe hypoxemia included, no effects of conservative strategy. And the other group is included trial without patient. Is for the trial where patients with severe hypoxemia were excluded. As for example, our trial on sepsis, we can see that in this case, in patients without hypoxemia, the use of conservative strategy seems to be positive, seems to be helpful in terms of reduction of mortality. This is another important point. It depends on the patient again. It depends on the EU relationship and the susceptibility of the patient to hypoxemia and hyperoxemia. My conclusion on this point is that conservative strategy means since the beginning, because we use for the first time conservative strategy for our trial published in 2016 is to maintain a patient in normoxic target to reduce hyperoxia and hypoxia exposure. Normoxic targets may be different in different populations in terms of best values as well as susceptibility of the patient. Normoxic targets and the duration of hypohyperoxemia in terms of harmful effect should be better defined. And for me, in the recent trial published, the threshold for conservative strategy as well as for liberal were not correct, because conservative sometimes was a permissive hypoxemia, and for sure liberal strategy are in the normoxic range. Waiting for the next trial, Megarox trial, but I think that it will suffer of the same problem. Liberal will be quite similar to conservative strategy and again in the normoxic range. I think that we have to keep calm and maintain our patient and ourselves in normoxic state. And thank you so much for the invitation. I hope that you enjoy my presentation, a lot of discussion, and I wait your email for discussing or to discuss in a live session. And I want to thank you again for the kind invitation.
Thank you, Professor. The third speaker in this session on mechanical ventilation is Professor Oriol Roca. He's going to be speaking on prone position during NIV and HFNO. Professor Roca has published 28 original papers, of which 26 are indexed, and he has 8 chapters in scientific books. He's a director of 3 doctoral theses that are ongoing. He has special skills and expertise in intensive care medicine, pulmonology, emergency medicine, mechanical ventilation, and intubation. And he's especially known for the ROX index that we have been using lately. Professor Roca.
Good morning or good afternoon, and thank you very much for the invitation to the Best of Brussels. My name is Oriol Roca, and I'm an intensivist in Barcelona in Vall d'Hebron University Hospital. In the next 20 minutes, I would like to talk about awake prone positioning in patients with acute hypoxemic respiratory failure. Well, these are my disclosures, and this is more or less the agenda of our talk. Well, the first report of the use of awake prone positioning was almost 20 years ago. It was used in 4 cases in where the aim of using APP was to avoid system mechanical ventilation. And what they observed is that all patients present a good tolerance, and there were also a rapid increase in PaO2, and intubation was avoided in all 4 patients without any complication related with the use of APP. A little bit later, another report, in this case of the use of APP, was reporting 2 patients with primary graft dysfunction after lung transplantation, in whom APP was combined with NIV with light to moderate sedation, and also they report an oxygenation improvement with no with no secondary effects. But the main thing is the issue of using APP is if prone position in awake patients has the same physiological effects that in intubated patients. And I want to show you only two studies. The first one is this one that was performed in healthy volunteers that were supported with high flow. And what we observed is that during prone position, there was an increase in lung homogeneity during tidal inflation compared to supine position. And the other promising physiologic issue that could be of interest is also the reduction in inspiratory effort and in transpulmonary pressure that was observed in patients who were prone, even though these patients were intubated, but they were allowed to breathe. So during prone position and spontaneous breathing in intubated patient, there is a reduction in inspiratory effort and transpulmonary pressure. So it seems that there is some physiological background that supports also the use of awake proning in patients who are not intubated. But how should we prone a patient who is spontaneously breathing? We can easily do it with some of, we only have to show to the patient to do it in a safe way. And it means that we have to prepare the patient, we have to place him or her in the correct position, ensuring that the oxygen supply is preserved. We can optimize the position using some pillows, and during the procedure, we need to monitor what happens to the patient in order to minimize the risk of the procedure. And what is the clinical evidence in non-COVID patients? This is the first series that was a retrospective analysis that included 15 patients with more than 40 procedures. And it should be noted that only 2 prone position maneuvers need to be interrupted due to the intolerance, and there were no complications, and there were no alterations in terms of hemodynamics, and therefore they conclude that APP was feasible and improves oxygenation in patients who were spontaneously breathing. A little bit later, or more recently, APP was described in patients with moderate to severe ARDS that were supported with high flow or with NIV. They include only 20 patients, and only 2 patients did not tolerate APP. And the rate of intubation was quite similar to the one that we have without the use of APP, which was around 40%. However, they also observed that the time that the patient would be on APP or on prone was not so long, with a mean duration of less than 2 hours. And another important point is that oxygenation before prone position maneuver was a predictor of failure in those patients who were on NIV. In fact, all patients who fail on NIV had a PF ratio below 100 before being prone. And this is what we had before the COVID-19 pandemic. And during the COVID-19 pandemic, the use of APP was increased due to the fact that in some cases there were no ventilators for everybody, and we tried to keep the patient on using non-invasive strategies as much as we can. And the third report were 2 letters that were published in JAMA. The first one included more than 20 patients that were supported with different kinds of oxygenation therapies. And interestingly, more than 50% of the patients were able to tolerate prone position for more than 3 hours. but only 25% of the responders, which was defined as an increase of 20% of PaO2 with prone position, were not sustained after supine. So there is a poor oxygenation response. But if we compare with other group of patients that were supported with NIV, the mean duration was similar, around 3 hours, but all patients respond in terms of oxygenation. And this oxygenation improvement was sustained after supination. After these two letters appear a paper in Lancet Respiratory Medicine that analyzed the feasibility and the physiological effects of APP in a cohort of more than 50 patients who were prone, that mainly were treated with helmet CPAP. They conclude that APP was feasible in more than 80% of the patients, defining feasibility as if the patient could tolerate more than 3 hours on prone position. 50% of the patients respond, that in this case was defined as a sustained improvement on oxygenation after resupination, but there were no difference between intubation rates between responders and non-responders. And then appeared the first observational study, but that tried to match patients who were prone with patients who were not prone. All these patients were supported with high flow, and they observed that there were no difference in intubation rates or mortality. And what it seems clear is that APP improves oxygenation, and in observational studies, in a meta-analysis that include all of the observational studies that were published by that time, there were no difference in intubation or mortality, regardless the subgroup of patients that we analyzed, regardless the time, the duration of proning, regardless the method of oxygenation supportive therapy or the oxygenation impairment before proning. And then appeared the first randomized controlled trials that compare the use of APP with the standard of care. And the first one was this trial that compared two groups of 30 patients that were mainly treated with conventional oxygen. And they observed also that they had important crossovers between groups, and there were no adverse events related with the use of APP. They didn't observe any difference in terms of respiratory escalation, in terms of which was the main outcome. And they conclude that despite the low adherence, because most of the patients in the APP group spend less than 4 hours prone, and some patients in the standard of care group spend some hours prone, so there were significant crossovers. Despite that, they conclude that the use of APP in these patients was feasible and safe. Then we have another randomized controlled trial that include patients that were treated with high flow and NIV, and they didn't observe any difference again in terms of the rate of intubation. And again, a problem that was shown also in the previous study, there were significant crossovers between groups, and some patients in the control group spend more than 3 hours prone, which could lead to difficulties in terms of detecting differences in the primary outcome. And in this context, we perform a collaborative meta-trial that includes 6 different randomized controlled trials with the aim to determine whether APP reduced the rate of treatment failure at 28 days, define either death or intubation in patients with severe COVID-19 acute hypoxemic respiratory failure who require respiratory support with high flow. In the last week of April, 5 RCTs agreed to participate, and the last RCTs joined the group at the end of August. The difference between the meta-trial and the traditional meta-analysis that we know is that we had a common inclusion and exclusion criteria, and we harmonized the plan intervention across all the trials that joined the meta-trial. We also set, of course, data that includes primary and secondary outcomes could be extracted from each trial, and we also perform collaborative interim and final statistical analysis. All participants agreed to report findings jointly, and once the meta-trial result was known, it gave a clear answer. The individual status still recruited would be terminated for the loss of equipoise. The inclusion criteria were acute hypoxemic respiratory failure due to COVID-19 pneumonia, and acute respiratory failure was defined as high flow with PaO2 below 300 or SpO2, FiO2 below 315. Of course, we need to exclude pregnant women, those who were hemodynamically unstable, or with a body mass index above 40, or if they have any contraindication for APP. And patients in the APP group were instructed and assist to prone as long as frequently as possible each day. Its use as a rescue intervention was strongly discouraged in the standard care group, and high flow was initiated with the maximum tolerated flow, and FiO2 was titrated to maintain an SpO2 between 90 and 95, and we predefined the criteria for endotracheal intubation, which were worsening respiratory failure, hemodynamic instability, and deteriorating mental status. The primary outcome was defined with treatment failure within 28 days of enrollment, that was also defined as intubation or death. And here you can see the list of secondary outcomes that we also assess. In the last months of 2020, we had a sudden surge of inclusions while preparing the secondary interim analysis that was planned at 400 patients. The results of this second interim analysis were available in December. 800 patients at that time had been already included. And then the steering committee decided not to perform the third interim analysis and move directly to the fourth. In this short time required to make this decision, 928 patients had been included. And in the interim analysis performed with these 928 patients, they finally end up with the decision to stop the recruitment because we crossed the boundary for efficacy. At that time, of recruitment interruption, more than 1,100 patients had been included. This is the flow chart of the screening, enrollment, and randomization. And as you can see, we screened more than 2,000 patients, and finally, more than 1,000 were randomized. As you can see, the SpO2, FiO2 before or at the time of inclusion was around 150, and the vast majority of the patients were treated in the ICU or intermediate care units, and only 5% of the patients were treated in the ward. This is the physiological response to APP. As you can see, there is an improvement with proning that is partial, that it keeps partially after resupination. that is partially maintained after resupination. This is what happens with respiratory rate that decrease with proning and is fully maintained after resupination. And these are the effect on the ROX index, which is defined as the ratio between oxygenation and respiratory rate. And as you can see, it's pretty similar to respiratory rate because there is an improvement and it is maintained with the resupination. This is the data regarding the primary outcome. And as you can see, there is a significant reduction in treatment failure at 28 days. And in fact, we need to treat 15 patients to avoid one treatment failure. And it is mainly due to the fact that APP decreased the need of intubation of the patients supported with high flow. And only 14 patients were needed to treat to avoid one intubation. There were no effect in mortality at 28 days. And patients in the APP group were more likely to be weaned also from high flow. In terms of safety outcomes, because there is a special concern about if APP may delay the intubation of those patients who are not doing well and will need to be intubated and mechanically ventilated. And as you can see, the mortality in those patients who need to be intubated is exactly the same between groups. And the time to intubation or treatment failure is practically also the same. And the duration of mechanical ventilation in those patients who survive is also exactly the same between groups. And there were there is no increase in other safety outcomes such as screen breakdown, vomiting, or cardiac arrest. In fact, there were no cardiac arrests during APP or in relation with APP in the outcome. We make some additional analysis and that generates a hypothesis for future studies. This is the effect of APP in terms of intubation or in treatment failure, according to the duration of awake prone positioning. And treatment failure occur only in 17% of the patients who remain in APP for more than 8 hours, as compared to 48% of those patients who remain less than 8 hours. So it means that the longer APP duration, the lower risk of intubation. Of course, there were some limitations. The study could not be blind. There were some crossovers. One of every 10 patients in the standard care group was finally prone, but in this case, this may lead to any kind of underestimation of efficacy in the APP in the intention to treat analysis. And of course, there were some meta-trial related design limitations. We had a slightly different inclusion criteria between trials. Some of the trials include patients with DNI or DNR order. And also we had some complexity of tracking the global inclusion rate. And this may contribute to overshoot the planned interim analysis or trial sample size in the case of efficient recruitment. But for sure, these limits are outweighed by the benefit of setting up very quickly an international randomized study generating high level of evidence in a short period of time. So in conclusion, in this meta-trial of patients with acute hypoxemic respiratory failure due to COVID-19 treated with high flow, APP appeared to be safe and had a favorable effect on the primary composite outcome of intubation or death within 28 days of enrollment. I would like to finalize and note with thanking to the patients and relatives for their participation, also for the independent advisory boards, Rich Callet and Paolo Viselli, and all the members of Awake Prone Positioning Meta-Trial Group for their contribution. Thank you very much, and I will be very happy to take any questions that you may have.
Thank you, Professor Roca. And the final speaker in this session before inauguration is Professor Neil Ferguson. He's going to speak on driving pressure and mechanical power in ARDS ventilation. He heads the critical care medicine at University Health Network and Sinai Health System in Toronto. He's a senior scientist at Toronto General Research Institute and a lead for Toronto Central Local Health Integration Network. He's a scientific program chair for Critical Care Canada Forum and Canada's premier critical care conference. He is a frequently invited speaker at national and international meetings, having given more than 300 such talks. And his research mainly focuses on mechanical ventilation, ARDS, and ECMO. Professor Ferguson.
Hello, and thank you very much to the organizers for the invitation to speak at this virtual Best of Brussels conference in India. Obviously, we very much prefer if there were an opportunity to travel in person to India, but hopefully that will happen in future years. My name is Neil Ferguson from the University of Toronto, and today we're going to talk about driving pressure and mechanical power in the setting of minimizing ventilator-induced lung injury. These are my disclosures, nothing particularly relevant for this talk. So when we're thinking about how to prevent further lung injury in a ventilated patient, the first thing we realize is that this patient with what appears to be diffuse airspace disease is very often this patient. And when we look at the CT scans, we see areas of dense consolidation, atelectasis in the dependent lung regions. And then we see other areas of the lung, the so-called baby lung, that are relatively normal and would receive a much higher proportion of any stress and strain that we deliver to the lung. And we know from 2 or 3 decades of nice bench to bedside work that overstretching the lung, volume trauma, can lead to local inflammation, which then spills out into the systemic circulation and can drive the multi-organ failure that produces death in many patients with ARDS. So if you were to know only one randomized trial of mechanical ventilation to prevent ventilator-induced lung injury, it's probably still this one, the original ARDS network trial published in 2000, which randomized patients to either 6 or 12 mils per kilogram predicted body weight tidal volumes, and also in the lower stretch group, limited plateau pressures to less than 30 and raised respiratory rates to try and match the previous minute ventilation. And as you can see here, just by adjusting some knobs in the ventilator, we had a very significant, large 9% absolute risk reduction in mortality. And whether you're a 6 mils per kilogram for everyone person or just avoiding 12 in some people, regardless of which side of the debate you're on, and we'll get into that, to some of the subtleties of that later in the talk, this trial definitively shows that the way in which we use the ventilator has a big impact on mortality in patients with ARDS. But following this publication, there were some data that started to come out to suggest that while 6 mils per kilogram and plateau pressures less than 30 might have been a good start, they weren't necessarily the final answer. In this nice physiologic study, Marco Ranieri and colleagues took patients with ARDS and religiously followed the ARDSNet low tidal volume protocol. And they did CT scans at the same time to see what was happening. And you can see that in about 2/3 of patients, when they went from expiration down here to inspiration, not a lot is happening. The lung still looks good. However, in about 1/3 of patients, those with the most severe lung injury, the smallest amount of baby lung, as you see, even with 6 mils per kilogram, as you go from expiration to inspiration, you see all sorts of red showing up on this CT image, which in this schema is indicative of hyperinflation. When we looked at data from the large LungSafe study from 5 years ago now, and these investigators tried to look what could be changed that were modifiable, that were associated with outcomes. Again, a few things related to mechanical ventilation come up. respiratory rate, PEEP, and the driving pressure, as outlined here. You can see that driving pressures, there seems to be a bit of a safe plateau, certainly under 10, maybe even under 15, but above that, a linear rise in proportion of death. This is Marcelo Amato's well-known paper in the New England Journal, 2015, an analysis of several randomized trials and a couple of observational studies, again, showing this relationship between driving pressure, which is the plateau pressure minus the PEEP, and adjusted mortality. Here's where that arrow is supposed to go. When we look at matched PEEP levels, it's the driving pressure that really is associated with mortality here. Now, Luciano Gattinoni and colleagues have taken this one step further and said, really, it's not just driving pressure, it's the whole intensity of mechanical ventilation. And we can calculate mechanical power, the joules per minute that the lung is receiving, using this formula, which includes respiratory rate, tidal volume, elastance of the respiratory system, and airway resistance. Now, this may be mathematically correct, but I think you'll agree it's a little clunky to use at the bedside. Hard to wrap your head around that. So fortunately, there's a simplified way to estimate mechanical power, and Ari Serpa-Neto and colleagues have used that here in this observational study, calculating mechanical power in joules per minute by using tidal volume, respiratory rate, and the difference between the peak inspiratory pressure minus the driving pressure divided by 2. And using this simplified method, again, they were able to show clear associations between the intensity of mechanical ventilation and outcome in 2 different ICU databases, MIMIC-3 and EICU, and consistent across 3 different ways of using multivariable analysis here. Again, similar to what we saw with driving pressure, there seems to be a bit of a safe zone down here. But again, once you get above, in this case for power, above 17 joules per minute, things seem to increase in an almost linear fashion. Now, just a couple of words about measuring driving pressure and power in patients who are breathing spontaneously on the ventilator. This is something that we're seeing increasingly commonly these days, with lots of patients either breathing on modes like pressure support or breathing spontaneously on pressure control or volume control. And this, as Laurent Brochard, Dart Slutsky, and Antonio Pincenti point out in this piece in the Blue Journal a few years ago, may drive further ventilation-induced lung injury. And I don't think we have to invent new mechanisms for this to happen. We just realize that when patients are on pressure support, their driving pressure may be much higher than the ventilator thinks, or that you think, because unless you make a special maneuver, you're not capturing the component of driving pressure to which the patient is contributing. The nice images in clinical medicine here from Roy Brower and colleagues, showing that when you have a spontaneous breathing patient and you do an inspiratory hold, in fact, the plateau pressure is higher than peak inspiratory pressure, somewhat paradoxically. And this simply reflects the diaphragm rising back to its resting position. With the airway closed, we now have the same amount of gas in a smaller container. And so the pressure rises to exactly the same extent as the patient lowered it with their negative inspiratory spontaneous effort. And this, by doing a plateau pressure maneuver in a spontaneously breathing patient, you may more accurately capture what the true driving pressure is. Now, not every ventilator will allow you to hold a plateau pressure like this in a spontaneously breathing patient, and not every patient will cooperate and just relax at the end of an inspiratory hold like this. So another way to estimate what the real driving pressure is, including the patient's own work, is to do a simple end expiratory and expiratory occlusion pressure, what we call the P occlusion or the P-OC. And this you can do on almost every ventilator. Sometimes it's called a NIF measurement. Sometimes it's just an expiratory hold. But you just do a stealth expiratory hold. Don't tell the patient it's coming. They breathe against the closed airway and generate a negative pressure that's proportional to the amount of effort that they're making. And it's proportional to their transpulmonary pressure. And you can use this by either to estimate the amount of muscular pressure that the patient is generating and to estimate what the true driving pressure is, which is the driving pressure that the ventilator generates, peak airway pressure minus PEEP. And in addition, the driving pressure that the patient generates. And we estimate this by taking about 2/3 of the occlusion pressure and adding it to the ventilator driving pressure. It says minus here because occlusion pressure is always a negative number, so 2 minuses make a positive. Now, the second part of the talk here, I'm going to move on to talk about 2 or 3 clinical studies and associations with outcome. First, here is Martin Erner's paper in the Lancet Respiratory Medicine last year of a large observational cohort of patients with respiratory failure. So not just ARDS, but all comers who are receiving mechanical ventilation, and then further separated down to those with hypoxemic acute respiratory failure in 3 different gradients of 200 to 300, 100 to 200, and PF ratios less than 100. And just in terms of how these patients were managed, you can see that in many cases, about 3/4 of patients were receiving tidal volumes of 8 mils per kilogram or less. Almost everybody was receiving plateau pressures of less than or equal to 30 centimeters of water. So that looks pretty good. But then we start looking at driving pressure and power, and still driving pressure less than 15 in about 80% of cases. This is just the ventilator measured, not the patient's contributions. Mechanical power was actually higher than 17 in a substantial number of cases, especially those with lower PF ratios, as indicated in the orange and yellow lines here. The overall outcomes of these patients are illustrated here, and there's certainly a hazard ratio that's associated with baseline PF ratio, with patients with very or no significant hypoxemia being discharged alive more than 75% of the time, whereas those with PF ratios less than 100 on day 1 had about a 50% mortality rate. And when we look at driving pressure, you can see here, this is dynamic driving pressure, just the peak inspiratory pressure minus PEEP, available in 10,500 patients. Again, a plateau and then a linear rise when it hits above about 15. Comparing 15 versus less than 15 in those patients who we had a true static driving pressure, again, a large separation in mortality. Now, the very interesting thing that Martin then did was to look not just at day 1, which is how most analyses of ventilator data are conducted, but to look at everyday mechanical ventilation. And what you can see on this graph is that the hazard ratio for driving pressure increases is above 1 on every day of mechanical ventilation, not just on day 1. And it's accentuated in patients who are more hypoxemic. This is also true when we looked at mechanical power. Again, on every day of mechanical ventilation, the amount of mechanical power that's delivered to the ventilator and to the patient is associated with mortality in a complex multi-model analysis here. Again, some interaction with baseline hypoxemia. Now, in the last few minutes, 2 secondary analyses of previous trials here. The first, both in the Blue Journal in the last year or so. The first here from Eduardo Costa and Marcelo Amato and colleagues looks at basically the same data set that they used in the original New England Journal publication. And just again compares driving pressure and tidal volume and mechanical power. And you can see here that while you have quintiles of driving pressure, certainly there's a threshold above which driving pressure seems to be strongly associated with mortality, not so much of with tidal volume. Again, driving pressure, yes. Quintiles of power, a little less convincing, but in the end, some signal there as well. When they looked at the two main components of driving pressure, of mechanical power, driving pressure and respiratory rate, separated out here in the left of this figure, both were associated with worsening outcome, but the slope, i.e. the strength of the association, was much stronger for driving pressure than for respiratory rate. So driving pressure is this solid line here, and respiratory rate is the dashed line. And that's important because the two things often set themselves off. We turn down driving pressure and tidal volume, and then we often increase respiratory rate to try to maintain CO2 clearance. And this just shows that strategy usually is effective and will lead to lower mortality, or is associated with lower mortality, unless the patient has a very relatively high compliance, in which case sometimes it's the higher driving pressure and lower respiratory rate that may win out. But usually this relationship here says that driving pressure dominates. Finally, a reanalysis of several randomized controlled trials comparing higher versus lower tidal volumes that were conducted in the mid to late 90s, including the ARDS network trial that we talked about earlier, but also several smaller trials, including Amato's first report and some small trials from France and Canada. And what Ewan Gallagher's shown here is that the effect of tidal volume reduction that we talked about earlier is actually heterogeneous and modified by the elastance of the respiratory system. And we can see that here. Normalized elastance, so this is just the elastance divided by tidal volume in mils per kilogram. The driving pressure divided by the tidal volume in mils per kilogram. Remember, elastance is just the inverse of compliance. If compliance is change in volume divided by change in pressure, elastance is change in pressure divided by change in volume. So just to orient you, 2.5, a normalized elastance of 2.5 is equivalent to a driving pressure of 15 with a tidal volume of 6 mils per kilogram predicted body weight. 15 divided by 6 is 2.5. So above, if we're mostly using 6 mils per kilogram, this is another way of saying when the driving pressure is low, there's not a big difference between higher versus lower tidal volumes. But as the driving pressure increases, the elastance worsens, there is a large signal here. And this is just this difference between these two lines is plotted in this figure on the right, where at very low elastance, very high compliance, if anything, there's a signal towards potential harm in the low tidal volume group. Pretty minimal and not, obviously not clinically, not statistically significant. But as you, most of the signal in terms of we see a benefit in terms of lowering tidal volumes comes in these patients with the lower elastance, which is another way of saying that driving pressure is really the thing that changed outcome in these original trials. Here's another way of looking at these data in a Bayesian analysis. And on this figure on the left, you can see that the probability, the posterior probability that there was at least a 5% decrease in mortality with lowering tidal volume. That's the blue line here. Comes around when the elastance, you get to be about 75% or probable when the elastance is 3 or higher. There's definitely some benefit in terms of mortality in anybody who's if you're taking about 80% as your cutoff, anybody with a normalized elastance of about 2.5, i.e., again, driving pressure below driving pressures of 15 with tidal volumes of 6 mils per kilogram predicted body weight. So in this talk, I've tried to show you that the intensity of mechanical ventilation is important to consider. And driving pressure and mechanical power certainly track together. They have some of the same components. I personally think it's reasonable to start with 6 mils per kilogram predicted body weight, and then adjust your strategy further according to your driving pressure that you're achieving. And adjust further, maybe just simply reducing tidal volume or driving pressure directly, or it may mean trying to recruit the lung and improve mechanics with higher levels of PEEP. Finally, I've tried to point out to you that it's important to consider both machine and patient efforts when you're assessing the intensity of mechanical ventilation, obviously when patients are breathing spontaneously. And with that, I will stop and thank you very much for your attention. Anybody who's interested in coming to Toronto to work with us as an international fellow, please contact me. And you're all invited to Critical Care Canada Forum, which unfortunately will be a virtual event, but a really fantastic program coming up in early December. Thanks again to the organizers for inviting me to speak today.
Thank you, Dr. Ferguson. And with this, we come to the end of session 4. Let me remind you to put your questions in the chat box for the JAMA session later in the day. And please stay online for the inauguration function that will soon follow. Thank you so much.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम् या
Good afternoon. Good afternoon. On behalf of the Pune ICCM Pune branch, and BOB Organizing Committee, I take this opportunity to welcome all delegates, faculties, and all dignitaries for this particular BOB. All of us know that because of the COVID, we were not able to did it in the last year, but this year we decided to go ahead virtual so that we can have a communication gap in between the physical and last physical. So might be the next year we'll come up with the most popular this BOB event physically in Pune. And I take this opportunity to appreciate all efforts of my ICCM Pune branch as well as the organizing committee. In a short time, they have put everything to go ahead with this particular virtual event. And special thanks to Dr. Samir Zog for having such an excellent academic feast. And I'm quite sure every one of you must have been enjoyed the pre-lunch session. And I'm sure in next 2 days, including the JAMA, don't miss the JAMA in the evening both days and have your academic doubts clear. So with this short introduction and welcome speech, I invite Dr. Prayag to have his opinion. Sir. Prayag, sir.
Unmute, sir, please.
Okay, I think there is some technical delay, but I'm sure sir will join shortly. I will again request all delegates to join for the JAMA session. I'm sure on this world of the virtual webinars and virtual conferences, everybody will be very keen to connect each other live. And I think that's a great opportunity. Don't miss that opportunity today afternoon, evening at 4:30 onwards. We'll have the stalwarts from the critical care to answer all our queries. You can communicate, still you can communicate through WhatsApp or mail to our event manager. We'll try to include those all questions and try to get the best answers from our eminent faculty. And I'm sure today and tomorrow, those two, we are trying during this all virtual events, we are trying to connect lively. That's what the whole purpose of such academic session. Let's hope we will succeed in our this venture in communicating and connecting with you during this virtual world of the COVID, and hope next year we'll have physical interaction with each other. And let me tell you, most awaited workshops at the ICCM Pune branch, I'm sure, and I'm aware that, and we all are aware that you are waiting for our physical workshop. Those were very popular workshop since last 25 years the Pune branch is doing. We will do it. We'll do it in next year. Most probably from the March we'll start our workshops physically. So please follow our website as well as our communication for the detail about how to get connect to the workshop. Subal, you can have your opinion.
Yeah. Welcome everybody again to this virtual BOB on behalf of the Indian Society of Critical Care Medicine Pune branch. It has been an excellent organization, and it has been a very excellent scientific feast, and thanks to Dr. Samir Zog and all the international faculty who have contributed within the short period of time. On behalf of the ICCM Pune branch and also on behalf of the organizing committee, I would like to thank all the delegates who have registered from different parts of the world and different parts of the country for this virtual Best of Brussels 2021. I also like to thank all the faculty as well as all the organizing committee members of the local ICCM Pune who have put in immense efforts in a short period of time to make this event a grand successful. I would like to thank Brian, Lena, and the entire team of Medwins and Meetings and More, Arun and Archana from the ICCM staff, office staff to contribute and support the entire organizing team. And in the end, I would like to thank all our support to be given on behalf of ICCM Pune branch. I would like to thank all the delegates. I would like to thank Sanofi, Pfizer, Cipla, Air Liquid, Alchem, Fresenius, and Acumentis for giving unrestricted educational grant for today's event, as well as for the Best of Brussels 2021. I would also like to thank all the support staff from ICCM Pune who have helped us to organize this event, and also the audiovisual team who have given seamless connectivity for hosting this event. Thank you very much and welcome you all again to this Best of Brussels 2021 virtual, and see you all physically in 2022. I request Dr. Prayag to now kindly give his opening address. Prayag, sir.
Am I audible?
Yes, sir. Yes,
Am I
sir.
audible?
Yes, sir. You're audible, sir.
Okay. Yeah. Thank you. Yeah. Thank you. It's a pleasure to welcome everyone for the BOB.
Sir, your voice is gone, sir.
Okay, there is some connectivity issue with the Praxair net. So unfortunately, we will miss those wisdom words from the sir. And I'm sure in the next 2 days course, he will brief us again, might be tomorrow morning or in the afternoon. And with this, I will say that this will conclude the inaugural session.
Yeah,
and we'll have the national
Kapil,
anthem.
I'm on.
Yes,
is it
sir.
okay? If I currently
Yes, sir.
I'm on. So is it okay by my
Yes,
next?
sir. Yes, sir. Please.
Yeah. Okay. Yeah. So welcome. As I was saying, welcome everyone to this edition of BOB. You know how the BOB started was that 8-10 years ago, when we were attending the ICCM at Brussels, we found that the number of Indian delegates were handful, and the amount which was spent by the country for a handful of delegates to attend that meeting was huge. And we decided that if we can get those faculty members to India for a meeting, and then expose those faculty members to a larger number of Indian delegates, then it would be a huge benefit to all the Indian delegates. That was the original idea of starting the BOB. And from that angle, we decided to host the Best of Brussels meeting. Fortunately for us, Dr. Jalui, Vincent, and everyone agreed to it. And over the last 7 years, Best of Brussels has created history. History in terms of a number of innovations. We have a single hall conference, which is attended by 800 people who hardly leave the hall. We have very innovative sessions, not just the routine talks and debates, but case presentations, just ask me anything sessions, panel discussions, the ever popular workshops of Pune ICCM branch, and very innovative entertainment programs also. So it has been an iconic Congress which has been going on for the last 7 years. And everyone in the country is looking forward to the organization and of this particular Congress. The amount of scientific material and the stature of the faculty has been phenomenal. And we owe all our success of the Best of Brussels to this phenomenal faculty and their very great presentations which have happened over the last 7 years. All in all, this has been a symbol of sophisticated, heightened learning, which has never been experienced in India before. Unfortunately, in 2020, we ground to a halt because of the COVID. Everything in the world ground to a halt. ECSHM could not be held, and therefore the BOB had to be cancelled. We had a very difficult time. Every one of us working in intensive care have had a very difficult period in 2020. We have experienced phenomenal disruption of the whole world. We have experienced personally very difficult times because of the physical, mental, and emotional reserves being stretched to our maximum. We have seen the intensive care use at its height during the COVID pandemic. All our capacities, all our skills, all our dedications have been tested to the maximum. And I'm pleased to say that most of us in India have found this not only challenging, but also extremely rewarding. We all of us have some wonderful, huge amount of stories of emotional nature, which have been shared between us, of the COVID patients coming to the ICU, some of them getting better, some of them not getting better, and causing us a huge amount of trauma. All this has been a very, very difficult time to manage the staff, to manage ourselves, to manage the patients, to manage the relatives. Has been an extremely tough time. It has taught us a lot. It has brought out our compassion. It has brought out our skills at webinars, and it has brought out our skills to understand the new disease, face the pandemic, and also understand it and trying to adjust to the ever-changing paradigms of management of these patients. So it has been a very, very testing time for all of us. And I personally feel that the compulsory masking of all of us has really unmasked us all, because it has shown us the true nature of each of us, how hardworking we are, how compassionate we are, how scientific we are, how we are grateful for the small mercies of this world, how opportunistic we are, how dedicated we are. All this has come out because of the unmasking which has been done by the COVID pandemic. But I must mention one major thing. Above all, it has given us an enormous amount of satisfaction, primarily because what we started off in the Indian Society of Critical Care Medicine 20 years ago, the teaching of mechanical ventilation in form of workshops has paid off phenomenally. Paid off in the sense that the number of people whom we had trained over the last 20 to 22 years in mechanical ventilation is more than about 5,000 people have been trained. And these 5,000 have gone to all the nooks and corners of this country and have benefited the patients of COVID who had come to the ICUs and who required mechanical ventilation. So we are drawing huge amount of satisfaction from the fact that the only long-standing workshop of the country, the workshop on mechanical ventilation conducted by the ISCCM Pune branch, has been the major contributor to the saving of lives all over the country. And this to us is a moment of huge satisfaction and pride in all the debacles that we have faced over the last year. So what is in store for the next year? We don't know. As Kapil and Subal have mentioned, we hope to see all of you. Hopefully there are no more waves. Hopefully we will all get together and enjoy the camaraderie and enjoy the company of each other and enjoy the Congress when it is held live. Meanwhile, in ICU, we will still continue to be there, continue to work as hard as we have always done, and continue to use the sciences which has been preached by the faculty which we have been gathering together over the last 7 years. And using these skills and using our dedication, we hope that we'll make a difference in the lives of the patients that we are trying to treat. So friends, let's hope that we all get together in 2022 and continue to enjoy Best of Brussels. And thank you all for all the support that you've been giving us over the last 8 years. Thank you very much.
Thank you, Prayag sir. This marks the end of the inauguration ceremony. I thank again all the delegates and welcome you all for this virtual Best of Brussels. And I request the next moderators, Dr. Khalid, to please take on with the industry session. Thank you very much.
Thank you.
Good afternoon, everybody, and welcome to this exciting afternoon session we have. This particular session is supported by Fresenius, and we have 3 exciting lectures lined up in the coming minutes. We have lectures on metabolism by very, very eminent faculty in their field. Our first speaker is Professor Annika Rantham-Blaser. She has specialized in critical care and emergency medicine. She works in Estonia in the Department of Anesthesiology and Intensive Care. And she is also attached to the Intensive Care Medicine Department in Switzerland. Her special interests are in gastrointestinal dysfunction in the critically ill patient. She is the chair of the working group on gastrointestinal function and dysfunction of the European Society of Intensive Care Medicine. She is a member of the executive committee of the Abdominal Compartment Society. So over to you, Professor Annika.
My name is Annika Rantham-Blaser. I'm currently working in Lucerne, Switzerland, and I'm also involved in University of Tartu in Estonia with my scientific work. And our topic today is phosphate in critical illness. Here are my few disclosures, and they are not relevant for this talk today. And we start with terminology. You maybe already noticed we were talking about phosphorus and phosphate. Phosphorus actually is an element. What we measure in plasma is phosphate. 2 different forms, as you see here on the screen. And they have been called inorganic phosphorus. And the reason for this is to distinguish in plasma measured anions from the phosphates that are within the ATP, phospholipids, and other organic molecules in the body. Plasma level of phosphate, or inorganic phosphorus as you like, is given here and is quite standard for most of the labs with small differences. Phosphate is mainly in intracellular room, and only 1% of it is present in the blood. So what we measure is only 1%. Phosphate is involved in virtually every cellular process. Actually, it's important in metabolism, in energy, in signaling, you name it, everywhere. So very important. In serum, the role is actually limited because there is only 1% in the blood, as you already heard. But often the serum level reflects body deficiency. So if the serum level is deep, then it can be expected that also intracellular level is deep, but it's not sure. We only measure extracellular. And you see, body is very efficient. There is a lot of phosphate in the bones. We also eat phosphate, but all the time the extracellular pool is kept very much controlled with absorption and then secretion, and also kidney is getting rid of phosphate if there is too much. If there is more than 5% of phosphate excreted and this leads to hypophosphatemia, then it is called renal phosphate wasting. So it's a kidney that is a problem, that the body has not enough phosphate. And controlling kidneys takes place with co-transport with sodium. And this is regulated by phosphate intake, how much we eat, and also parathormone. Phosphate excretion usually increases when there is volume expansion that we often do in our patients. Acidosis also quite common in critical ill, and also some drugs and interventions that you also know that we do in critical illness. Some other interventions or conditions decrease phosphate excretion. The hypophosphatemia can be caused by inadequate intake absorption, or let's say the phosphate deficit in the body. And these are the causes for inadequate intake or absorption. Also diarrhea if the phosphate is not absorbed in an adequate way. And another important mechanism in critical illness also is redistribution of phosphate into cells. And here are the causes: insulin, catecholamines, correction of acidosis, also development of acute respiratory alkalosis, and also refeeding. And we will now stop for a moment on refeeding. If the body doesn't get enough energy for a certain time period, plus there is acute illness, then intracellular deficiency of these electrolytes, so potassium, phosphate, and magnesium develops. And then if we start to feed the patient again, then glycemia increases insulin secretion, and insulin moves the glucose into cells. And also these electrolytes are moved then into cells. And water is taken with because of osmosis. And then, first of all, water retention occurs. There is also thiamine deficiency developing because the metabolism will be changed, and carbohydrate dependent anabolism and tissue regeneration uses a lot of thiamine. So the thiamine levels get low. And also, as already said, these electrolytes, important ones, and we concentrate today on phosphate, they are getting low because they are disappearing from serum and move to the cells. And as we already heard, phosphate is important for energy production. And if there is not enough phosphate, then there is cellular energy deficit developing. And also hypophosphatemia causes a lot of neurological, cardiac, hematological problems in the body clinically, and also muscle weakness. And most important for us probably is respiratory muscle weakness also. And some other electrolytes are also causing problems or contributing to those caused by hypophosphatemia. So this is why we are talking about refeeding syndrome and think that it is dangerous. And we know that there are several risk factors named for hypophosphatemia. However, in ICU patients, these risk factors, such as low BMI, no food intake, low electrolyte levels before nutrition, and etc., that they are not so well working in critical ill patients. 2 studies showed that the risk factors did not well predict the patients who develop hypophosphatemia and who not. So it wasn't predicted by these NICE criteria, neither by clinical signs and symptoms, neither by initial phosphate levels at admission. So we think that all critically ill patients actually should be considered at risk of refeeding syndrome and be monitored for serum plasma phosphate levels, because we cannot predict who develops it and who not. And now we come again to kind of definitions and look at the different severity of hypophosphatemia. In the literature, it is based on old studies and not ICU patients. Mild hypophosphatemia has been defined as phosphate below 0.8, but above 0.65 millimole per liter here shown. Moderate is the next state, and severe the next. We have been discussing and hypothesizing whether we shouldn't call severe hypophosphatemia cutoff being 0.65. Because these old studies say that hypophosphatemia should be corrected when it is severe or symptomatic. But symptomatic is almost not possible to clearly detect in an ICU patient who is sedated and maybe neurologically unwell, etc. So actually, we don't know whether the patient is symptomatic, and that's why we should move the correction level probably up. We don't know clearly yet, but this is the rationale. In one day point prevalence study, hypophosphatemia occurred in 15% and severe in 7%. Otherwise, hypophosphatemia is quite common in almost 1/3 of patients in the ICU, admitted to the ICU, it can occur. But hyperphosphatemia is also common, mainly in patients with renal failure. And problem is that there have been different cutoffs and no study measured phosphate in all consecutive ICU patients. And this is the real problem. Refeeding phosphatemia, so hypophosphatemia, which is developing after initiation of feeding, is probably more common than just hypophosphatemia, and as hypophosphatemia at admission, clearly. We did a systematic review and were shocked by the low level of evidence what we found. We only found 3 RCTs and 2 of them were published in only in abstract form, and this shows what is the level of evidence. So we tried to answer several clinically important questions that we formulated before taking this task. And we said that probably hypophosphatemia is associated with the development of organ failure, also with muscle weakness, and that we probably should aim also caloric restriction if hypophosphatemia develops after initiation of feeding, not only correction of phosphate. But we couldn't answer the actually even more relevant questions. Should we aim to normalize phosphate levels within 24 hours? Should we assess phosphate at least 3 times a week? And should we target a certain level? And these questions, unfortunately, we couldn't answer. After our systematic review, some others managed to do a meta-analysis, but it is important to see that in this meta-analysis performed for hospital length of stay, these studies included, they had different level of hypophosphatemia, or different level of serum phosphate defining hypophosphatemia, let's say. And they showed that length of stay was longer in patients with hypophosphatemia. They didn't show clear association with mortality, but of course there also was a problem that many studies included had defined hypophosphatemia with phosphate level above 0.8 millimole per liter. Excuse me. And it has been also hypothesized that maybe hypophosphatemia is just a marker of disease severity and not itself influencing outcome necessarily. There are several new studies after our systematic review, but unfortunately all of them are retrospective. A large study in Australia, 11% of patients had hypophosphatemia, more had hyperphosphatemia, and there was an independent association with increased mortality for both hypo and hyperphosphatemia. Another study in septic patients, about the same range, 13 patients had hypophosphatemia, defined a bit differently, and more patients had hyperphosphatemia. And there was no association between mortality and hypophosphatemia on the first day of ICU, in the ICU. So on admission day, hypophosphatemia was not associated with mortality, but hyperphosphatemia was at the same time. And here, very interesting, a large number of patients with aneurysmal subarachnoid hemorrhage was studied, and the majority of them had hypophosphatemia. In American cohort 72 and in Danish cohort 55, many patients. And if we think about these patients, they are long time in the ICU, long time immobilized, and long time they might have noradrenaline infusions or so to keep the pressure high and to treat or avoid vasospasms. So actually not so astonishing that so many had hypophosphatemia with long stay and stress factors. And there was no association with mortality in matched analysis in this study. Some more retrospective studies, patients with bloodstream infection, hypophosphatemia was associated with mortality independently also. Another study in neurocritically ill patients studying refeeding hypophosphatemia, and it was shown that development of refeeding syndrome and delta phosphorus, so change in phosphate levels, were associated with mortality. So to summarize, there is different prevalence and impact on outcome depending on the study cohort. And probably there is also association with feeding practices. And then we could ask, does association with outcome depend on measurement time point? And thereby also on mechanism of hypophosphatemia, because several studies who studied outcome based on admission phosphate didn't see any effect, whereas the ones studying refeeding hypophosphatemia detected an association with outcome. And these are the studies on refeeding syndrome, DAY-1, an RCT, and showed that despite electrolyte levels, including phosphate, were corrected in both groups, outcome was better in these groups where caloric intake was also reduced. So we tried to block the mechanism of refeeding and not only correct the levels. And also in both of these studies, Althoff was retrospective, but it was shown that mortality occurred much later in these patients and not then when electrolyte disbalance occurred. So the mechanism somehow had to be important. And to mention one study on thiamine, didn't show a difference in mortality, small RCT. And in one group, thiamine was given and in another one not, in patients developing refeeding syndrome, and there was no difference on outcome. However, major shifts may be more relevant as the absolute value of the phosphate, and it seems to be rational to avoid major shifts with reduction of nutrition in these patients. And also one recent study, also retrospective, quite a large amount of patients admitted to the unit where nutrition was started early with those targets, and hypophosphatemia was corrected based on standard. And the amounts of phosphate given were quite high. And it was shown that 1/4 of patients on admission had hypophosphatemia, whereas much more patients had developed hypophosphatemia after initiation of feeding. And if we now consider here that the phosphate level was even corrected in between, then it is even more astonishing, the result that so many patients still developed hypophosphatemia, also indicating that normal level before starting feeding does not mean that the patient won't get hypophosphatemic. Current practice, phosphate is not very commonly measured. Only 1/3 of ICUs reported that they measure phosphate daily. Very few don't ever measure. And most of them measure 1 to 3 times a week. Phosphate changes are fast, so this, in my eyes, is clearly insufficient. And phosphate correction was undertaken in this range of phosphate levels in 40%, but if the phosphate level was below 0.65, what we were discussing, should we call it moderate or severe hypophosphatemia, then only slightly more than 50% of cases, this rather severe hypophosphatemia was corrected. So many didn't correct. And phosphate repletion protocol was available in 40% of participating ICUs. So monitoring of phosphate is actually not routine in many ICUs all over the world. Now, shortly to correction, there is again very insufficient evidence actually on this. can be replaced or corrected orally, but severe, I think, should always be corrected intravenously. It has been shown that 40 millimoles per day is safe, but this is also old information. Some patients need more, but the dose should strictly be based on repeated measurements of phosphate. And hyperphosphatemia is bad because it leads also to hypomagnesemia, hypocalcemia, hypotension, and also crystal deposition in the kidneys. Required amount, how much needs to be given, cannot be predicted by the phosphate level because shifts take place and we don't know how much the shift is at the same time taking place. And prophylaxis shouldn't be undertaken. So normal phosphate levels should be corrected with thinking that maybe the shift will take place. There is narrow normal range and accumulation of phosphate occurs in renal dysfunction, so we need to be careful. And outside of ICU, it has been shown that routine replacement in diabetic ketoacidosis was not beneficial, had no advantage regarding outcome, and caused more hypocalcemia. I personally think that hypophosphatemia is underdiagnosed in our ICUs because phosphate level is not measured. But when it is identified, then it's probably overtreated in critical ill. And now we come to practical summary. Phosphate level and its changes cannot be well predicted, so it needs to be measured. Possible very fast changes can take place in case of refeeding syndrome or correction of acidosis. But at the same time, there are also complications with overcorrection of hypophosphatemia. So we need to be really careful. And the therapeutic range is narrow. Refeeding syndrome is important. This electrolyte imbalance after beginning nutrition. And the most effective way to treat it is to be aware of it and start feeding slowly and measure phosphate. And repeatedly measured values of electrolytes are important. Administration of thiamine, we do it regularly in all those patients, but it hasn't been shown that it has an effect on outcome. My personal summary is that hypophosphatemia at ICU admission is probably not so bad and maybe not associated with bad outcome, impaired outcome. But development of hypophosphatemia with refeeding mechanism is probably associated with adverse outcome. And there we need to pay attention. So the process, the mechanism and magnitude and speed of change in phosphate is maybe more important as the absolute value. And the idea that patients with hypophosphatemia have longer ICU and hospital stay, I would actually turn it around and say that the patients who stay in ICU longer are more likely to develop refeeding hypophosphatemia. And I personally think that hypophosphatemia is bad and may kill patients, but it is based on large amount of case reports and my personal experience rather than all the studies that we have, which are all retrospective once again. And I think that avoidance of rapid major changes or decreases in phosphate level may save lives. Thank you very much for your attention.
Thank you very much, Professor Annika, for a good lecture on phosphorus metabolism. Our next speaker and our next topic is HLH in the ICU. Our speaker is Professor Evangelos Giamarellos Bourbolis. He's a professor of internal medicine and infectious disease at the Medical School of the National and Kapodistrian University, Athens. He currently serves as the president of the European Shock Society and the chair of European Sepsis Alliance. His main research contribution has been in the field of immunomodulation in sepsis and in auto-inflammatory disorders, for which he has received prestigious Young Investigator Research Award and given to him by the European Society of Clinical Microbiology and Infectious Diseases. He is involved in various clinical trials based on the treatment and vaccination. He has published landmark work on complex immune dysregulation in severe COVID-19 patients. So over to you, Professor Evangelos.
Hello. I would like to thank the organizers for this kind invitation to present a new concept and a new syndrome, which is becoming more and more often for patients who are hospitalized in the intensive care unit. These are patients who are suffering from macrophage activation syndrome. Today, I will present you the characteristics of macrophage activation syndrome for sepsis. However, all of us who are managing patients with severe COVID-19 in the last few years, we know very well that most of these cases who are arriving at the critical stage, they also have characteristics of macrophage activation syndrome. This is my conflict of interest disclosure for the presentation, and I would like to acquaint you a bit about what is known so far about the main features and main characteristics of this patient. This is a cumulative table of several publications, and as a matter of fact, you see from several places of the world, publications, many great years now, patients who have underlying disorders like lupus and acute pancreatitis, patients overall admitted in the ICU, patients with sepsis, and patients also with malignancies. And the characteristics that are described for these patients is that they are suffering from high-grade fever. They have hepatomegaly and splenomegaly. They may have thrombocytopenia, hemophagocytosis. Surprisingly, they have increased triglycerides, and they're also suffering from hemophagocytosis in the bone marrow. What is exactly the syndrome and how this is produced? Actually, what is playing a major role for the pathogenesis of the syndrome is the interaction of 4 different compartments. In one compartment, we have tissue macrophages that you can see in the upper left corner. The second compartment are liver Kupffer cells and liver hepatocytes. The third are NK cells, and the fourth are CD8 cells. So imagine that all of a sudden, LPS, bacterial lipopolysaccharide, is binding TLR4, the receptor, the transmembrane receptor on tissue macrophages. This ends up with the activation of NF-kappa beta, and this ends up with the production of pro-inflammatory cytokines, the NF-alpha L6, for example, but there also is a major cytokine, which is IL-1 beta. IL-1 beta is leaving the cell. However, before this is happening, so far I have presented to you what is happening through the activation of TLR4 by LPS, but there may be other agonists like viruses, particularly CMV, which are bound to another intracellular receptor, which is called TLR9. And this leads to the activation of NF-kappa beta, and of course, it leads to further production of IL-1 beta. So look what is happening to IL-1 beta. IL-1 beta has a short half-life, and why that? You can very difficultly isolate that in plasma at huge concentrations in these patients. However, IL-1 beta in these patients acts in an autocrine way. It binds to the receptor of IL-1, and this leads to further stimulation of NF-kappa beta and further production of IL-1. What is happening in this situation is that you have a tissue macrophage which is overactivated. And as a marker, as an indicator of this excess activation of tissue macrophages, the receptor that you see, which is named CD163, becomes soluble and it's shed into the systemic circulation. Overall, IL-1 beta travels further and it goes to liver hepatocytes, and there it leads to overproduction of ferritin and downregulation for the production of fibrinogen. IL-1 beta is also acting on NK cells, and this leads to downregulation of perforin, That means less apoptosis of NK cells and more production of cytokines from these cells. Why? Just because they don't die due to inhibition of apoptosis. In parallel, as you have seen, several viruses, they act on CD8 cells, and this leads to further cytokine production. So look what we have. We have excess cytokines, and one of them is interferon gamma. And these are coming from tissue macrophages. They're coming from NK cells. They even come from CD8 cells. And interferon gamma is acting on bone marrow for the induction of hemophagocytosis. This is a macrophage activation syndrome, a syndrome that we also like to call hemophagocytic lymphohistiocytosis, the acronym of HLH, which is part of the title of my presentation. And look here, a characteristic of bone marrow. You see there a gigantic histiocyte. It has phagocytosed neutrophils and red blood cells. And the question comes, why is this important? You remember, all of you, that for almost 3 decades ago, we are having in the critical care field several randomized clinical trials with the use of biologicals to stop the activity of cytokines and improve the patient. However, very few of these trials were positive. One of these trials, the phase 3 trial, where anakinra, a blocker of the activity of IL-1 beta, was given to patients. Overall, the trial was negative. However, when this entity of macrophage activation syndrome became known to the world, data were reanalyzed. And there we understood that we had 4 strata of patients. As we're moving from above to down, you can see the survival of patients who do not have traits of macrophage activation syndrome, either receiving treatment with placebo or with anakinra, no difference at all. Then you have the solid black line of patients with traits of macrophage activation syndrome who are receiving treatment with anakinra, and only 35% of them die. But those who are in the dashed dark line are those with traits of macrophage activation syndrome. They receive treatment with placebo, and 65% of them dies. And this difference is statistically significant, introducing the notion that the inhibition of IL-1 beta may be an important managerial tool for these patients. And then after this publication, what came to us was the need to understand what is the real incidence of macrophage activation syndrome in patients with sepsis. This is the cohort of our Hellenic sepsis study group. In 2016, we had full clinical data of 5,121 patients. We split them into one test cohort and one validation cohort. You can see the main infections that were the drivers for sepsis. And what we did is that we collected in this patient's blood in less than 24 hours from the onset of SIRS. But in parallel in these patients, we tried to develop tools that can diagnose macrophage activation syndrome and also to see the kinetics of these tools. As a matter of fact, there is a diagnostic score, a classification score, which has been elaborated by the American College of Rheumatology. This is called the AHS score. It comes from hemophagocytosis. And as you see, we had few patients in both the test cohort and the validation cohort who were scoring positive for hemophagocytosis by the score. And the incidence of what we call macrophage-like activation syndrome was 3.7% in the first cohort and 4.3% in the second cohort. Let's see now whether the patients, they bear really clinical traits of macrophage activation syndrome. You see that the incidence of hepatobiliary dysfunction and disseminated intravascular coagulation is much greater among patients with traits of macrophage activation syndrome compared to patients without traits of macrophage activation syndrome. In parallel, you see that these patients in red, in both cohorts, they have increased concentrations of triglycerides. What you also see, and that's the most important, The characteristics of macrophage activation syndrome is early mortality. Mortality the first 10 days. And this is our multivariate analysis, separately for the test cohort A, separate for the validation cohort B. And you see that in the analysis, we have enrolled 4 clinical syndromes: ARDS, acute kidney injury, and septic shock. And even in the presence of ARDS, acute kidney injury, and shock, macrophage activation syndrome was an independent situation, independent syndrome leading to early death the first 10 days. Someone would say, now we are in need of a tool. Indeed, we measured different biomarkers and we managed to identify in our test cohort that ferritin at however sky-high concentration, more than 4,420 nanograms per ml, could be diagnostic of macrophage activation syndrome. And actually, those patients, they had a mortality rate close to 67% after 28 days, compared to only 33% of patients who did not meet that high cutoff of ferritin. Exactly the same survival was confirmed in our validation cohort. And however, someone could say that these patients are coming from Greece, probably the huge resistant rates that we are facing in our country may impact on these results. So we were in need from an independent cohort coming from another country. And indeed, with lower resistance, we used a cohort coming from Sweden and which fully validated our data. With this in mind, we ended up that ferritin at such concentrations has a specificity of 97.1% and a negative predictive value of 98% of the diagnosis of macrophage activation syndrome. In other terms, if you come across a patient who has such high levels of ferritin, something for which you are certain is that he's suffering from macrophage activation syndrome. However, in order to further validate the data, we asked ourselves whether hyperferritinemia is accompanied by hypercytokainemia. Allow me first of all to show you the data for IL-18. IL-18 is also a pro-cytokine, which is secreted by tissue macrophages and parallel 12 beta. It has, however, a higher half-life, and this prolonged half-life allows the measurement of IL-18. Indeed, the more ferritin you get, the more IL-18 you get. And then there is the famous ratio of IL-10 to TNF. This ratio is an indicator of the anti-inflammatory to the pro-inflammatory balance of the host. The lower the ratio, the more the pro-inflammatory the patient is, and indeed, patients with high ferritin, they had lower ratio. In parallel, these patients, they had more interferon gamma. I mentioned to you at the beginning of my talk how important is interferon gamma for the induction of hemophagocytosis in blood marrow. And also, they had increased soluble CD163. Please remember at the beginning of my talk, I stressed that as a result of the hyperactivation of tissue macrophages, CD163 is shed in the systemic circulation, and this is an index of the activation of macrophages. The question, however, comes, can ferritin be also a surrogate of improved outcome? You see in blue the concentrations of ferritin on day 1, and in red the concentrations of ferritin in day 3. And you see that in survivors, ferritin goes down. In non-survivors, it remains stable. And as a matter of fact, this decrease of ferritin is a surrogate of improved outcome. What our other groups have shown? This is a publication coming from Charité. It was published in 2018 in Shock. They described 9 patients who had positive HS score. And the question comes, what does this mean? Can all patients have macrophage activation syndrome? Is this just hyperinflammation, which is a unique entity of the older? Or in order to have macrophage activation syndrome, we need our tissue macrophages to be constantly primed. So when there is a stimulus, to have a hyperproduction of albumin. Look at the evidence. This is a very interesting trial. It has to do with patients who have cardiovascular risk. Actually, they are patients who have survived from a first episode of myocardial infarct and they had CRP more than 2. These patients, they enter into a randomized clinical trial and they are split onto once every trimester treatment, either with placebo or the administration of a single shot of canakinumab. Canakinumab is a long half-life inhibitor of alpha beta. The primary endpoint of the trial is the first new cardiovascular event from start of the trial. And as you see, the primary endpoint was met. The incidence of a new cardiovascular event was lower among patients treated with canakinumab. And what does this mean? That means that when you have cardiovascular risk, you probably have your tissue macrophage primed for alpha beta, and this could probably mean that patients who are under cardiovascular risk, like patients with diabetes, coronary heart disease, chronic heart failure, are more prone in our ICUs to develop macrophage activation syndrome. These are patients with sepsis under long-term follow-up. We collect from them blood the first 7 days and after the first 7 days. And you see that these patients, they are divided into those who have a late peak of HMGB1. HMGB1 is an alarmin which is stimulating TLR4 in exactly the same way as the lipopolysaccharide is doing that I presented earlier to you. And you see that those with late peak of HMGB1, that means after day 7, they have more ferritin, and above, on top of that, they have more interferon gamma. In other terms, those with late peak of HMGB1 are prone to the production, to the constellation of macrophage activation syndrome. So look here. In these patients, we divide them into 4 groups. Those who do not have any cardiovascular factor, those in blue who are suffering from type 2 diabetes mellitus, those in green who have a late peak of HMGB1, and those in red who have both diabetes and a late peak of HMGB1. As you can see, the odds ratio for death by having only diabetes or only a late peak of HMGB1 does not introduce a significant increase of the risk for mortality. However, if you have both, all of a sudden the odds ratio is extremely increased. And the same applies if instead of having diabetes mellitus type 2, you have chronic heart failure. And what is the explanation? The explanation is that if you're suffering from diabetes or chronic heart failure, you are primed in your tissue macrophages for the production of alpha beta. And all of a sudden HMGB1 comes and alpha beta is heavily produced and you develop macrophage activation syndrome. With this in mind, I would like to end up with some concluding remarks. There is no doubt that I presented to you today a distinct entity of pathogenesis, which is driven by excess production of alpha beta. Ferritin concentrations more than 4,420 nanogram per ml. They provide a specificity close to 100% for classification. This syndrome is a driver for early mortality, and this 28-day mortality is reaching even 70%. However, what we have in front of us, we have in front of us a clear-cut example of personalized approach because we know that we have a lethal syndrome, which is driven through alpha beta, and probably anti-L1 therapies are the future for these patients, providing, however, that we can early recognize them. This is a
Thank you very much, Professor Evangelos Giamarellos Bourbolis, for a lucid lecture on HLH. And he has given us so many valuable points and clinical markers, how to look at these particular subsegment of patients who present with this macrophage activation syndrome. Thank you very much, Professor. Our last speaker for the session is a lecture on glycemic control in the critical care unit. Professor Jean-Charles Prese will be delivering this particular lecture. Professor Jean Charles is a professor in the Department of Intensive Care at the Erasmus University Hospital in Brussels. He is a medical director for biomedical research and clinical teaching at Erasmus University Hospital, Brussels. His main areas of interests are in the metabolic aspects of critical illness, its consequences in terms of nutritional needs, in terms of sugar management and long-term outcomes. He is involved in path-breaking research in these areas. He is an associate editor of the Journal of Parenteral and Enteral Nutrition, Critical Care, and the Annals of Intensive Care. He is involved in international and national education programs on nutrition. He has published many articles, guidelines, and book chapters. Over to you, Professor Jean.
It's a pleasure to meet you virtually. My name is Jean-Charles Prézère. I'm an intensivist in Brussels, Belgium, and I've been involved in the field of glycemic control for about 20 years now, and I've been active in this field. And I will be pleased to share some of the new findings in this field. So glycemic control in the ICU. I've got a few disclosures. So since the discovery of the benefits of tight glycemic control in 2001, there were a lot of studies which were unable to confirm the clinical benefit of strict or tight glycemic control with intensive insulin therapy. So most of the studies were performed all over the world in large cohorts of patients randomized to either a strict or tight glycemic control versus a conventional arm with different targets, as we will see. Overall, that's the point, there was no survival benefit of this strategy to keep blood glucose within a narrow range of 80 to 110 milligram per deciliter. And then the enthusiasm for this glucose control in the ICU slightly decreased over time. Still, there are about 80 publications per year retrieved on PubMed when using glucose control and ICU as search terms. So what did we learn during this period? What did we learn during this intense period of research before 2009? First, we learned that safe, efficient glucose control is not that easy to achieve. Second, we changed a little bit our minds for the definitions and understanding of the three domains of this glycemia: hyperglycemia, hypoglycemia, and high glycemic variability. We also learned about the acquisition of diabetes in the ICU, so long-term consequence of the ICU stay. And we have several other unanswered issues that need some reliable research tool to be solved. So first, the safe and efficient glucose control is not easy to achieve. Safe means without hypoglycemia, and efficient meaning achieving the predefined target. So this slide shows that even in the context of large prospective randomized controlled trials, it's not easy to achieve the target range. Either the low range or the high range can hardly be achieved with our current technology. And in fact, as shown by Marcus Schulz on this important slide, the implementation of tight glucose control is related and depends on the reliability of several factors. First, the type of device you use for the blood glucose measurement, the type of device you have for the delivery of insulin, the algorithm that you will be using, the administration of glucose, and finally, the training skill and motivation of the nursing team is really a key factor for the achievement of the predefined glucose targets. We looked at this in the context of the glucontrol study, and we saw that the intensive insulin therapy required an increase in workload by 17%, which is really important. So now the second point that we learned during this period of intense studies, the definitions and understanding of the three domains of dysglycemia. First, hyperglycemia, second, hypoglycemia, and third, high glycemic variability. Each of these domains are related independently with a poor outcome or worsened outcome, as we will see. But there is also a synergy when you have a patient with both hyper and hypo, or both hyper and high glycemic variability. There is an additional penalty, if you wish. So first, hyperglycemia. We know that to some extent, stress hyperglycemia is a physiological response needed to survive during the first hours of injury. This was nicely shown on this review on different animal species by Marek and Bellomo. Now, if we consider that 80 to 110 milligram per deciliter of 4 to 6 millimolars, if you prefer, is considered as normal glycemia in fasting condition when you are healthy, this definition of normal glycemia cannot be held or cannot be kept for critical ill patients which are stressed, which are fed, and they also receive some therapies that will increase blood glucose by itself. If we look at the mechanism of insulin resistance, and we know that this is the key mechanism of stress hyperglycemia, you can see on this slide that the sensitivity to insulin, so the opposite of resistance, is really extremely low. The normal value would be on the higher level of this panel. So there is a really very low insulin sensitivity, so a high resistance, which is much more important or larger magnitude than in type 2 diabetes. So there is a huge insulin resistance during the first hours after injury. In addition to the insulin resistance, the illness by itself, the predisposition of the patient, and the treatment itself can also amplify the level of blood glucose. Now, if we look at the available data in the literature, if on the study associating hyperglycemia with outcome, we found in this scoping review about 43 studies which were fit with our criteria, mainly from North America and mainly in trauma patients. So the definition used for stress hyperglycemia was most often higher than 150 milligram per deciliter or 8 millimolar, and in some cases higher than 180 or 10 millimolar, or higher than 200, about 12 millimolar. So the definition of stress hyperglycemia or hyperglycemia per se differed from one study to another. And also the outcomes recorded were largely variable from studies to study. We have the number of studies on the x-axis and the type of outcome on the y-axis, with the number of records for each outcome in number of patients. You can see that the mortality, the rate of infection, the length of stay in the ICU in the hospital, the need for mechanical ventilation, the need for transfusion or renal replacement therapies were recorded by some teams, but not by all. So there is a large heterogeneity in the outcomes recorded. And one of the important unanswered questions in this regard is, what is the optimal blood glucose in patients with chronic hyperglycemia? We know that in patients with poorly controlled diabetes, there are some mechanisms developed over time, but it takes a long time, several years, by the cells to protect themselves from the toxicity of high glucose. These mechanisms have been described by Michael Brownlee, published in Nature in 2001. Clinically, we know, and this is a summary of 3 different large cohort studies, that the mortality, the curve relating mortality to blood glucose level is different. The blue one is in patients with chronic hyperglycemia. The red one is the patients without chronic hyperglycemia. And you can see that these curves are quite different. This holds true also in the studies from the Leuven group, which describes the first study in 2001 of the benefit of strict glycemic control. This benefit was not observed in patients with diabetes. So again, the optimal target or the optimal blood glucose can be different in patients with diabetes than in other patients. And likewise, we know from the field of diabetology that there is a way to estimate the average blood glucose based on the A1C level by the Nathan's equation published in 2008. So we can see that using this equation, you can estimate the usual blood glucose in patients. When we looked in ICU patients at the relationship between the glycemic ratio and the mortality. The glycemic ratio is the admission blood glucose divided by the average blood glucose calculated by the Nathan equation, so based on the A1C level, the hemoglobin, the glycated hemoglobin level. You can see that there is a U-shaped curve, suggesting that the closest the patient with the closest to 1 with the glycemic ratios closest to 1 had the best survival. This was also shown by a team from Australia, from Greg Roberts and colleagues. The outcome was not the mortality, but the need for ICU. So the percentage of patients having critical illness was also different, and this between patients with a low versus high A1C according to the admission glucose, suggesting again that the optimal level glucose can differ between the patients with or without chronic hyperglycemia. Now, the issue of hypoglycemia, which is of course a complication of intensive insulin therapy. The treatment can be worse than the disease, and this was shown by the investigators of the NICE sugar trial, published in 2009, and they published this second paper in 2012, also in the New England Journal of Medicine. They showed that the hypoglycemia was associated with an increased mortality even after stratification for treatment, suggesting that indeed the treatment by insulin complicated with hypoglycemia was associated with an increased 90-day mortality. So the this treatment could kill patients because of hypoglycemia. And this was also shown in this meta-analysis from Judy Jacobi, showing that there was an increase by a factor 5 of the rate of death in patients randomized to strict glycemic control by intensive insulin therapy who underwent hypoglycemia. Now, this was for absolute hypoglycemia. Now, the new concept is the concept of relative hypoglycemia in patients with diabetes. You can imagine that if the usual glycemia is about 8, having 6 can be considered as a relative hypoglycemia. Another team in Australia looked at this issue, and they indeed found that patients with relative hypoglycemia, defined as a glycemia below 30% of the usual average glycemia, was found at a higher mortality. This was shown in this was a comparison of patients with relative hypoglycemia as defined, or without relative hypoglycemia, so in a cohort of 1,500 patients. They indeed found that the outcome of patients with relative hypoglycemia, so a blood glucose lower than usual, was worse, so the survival probability was lower in those patients with the blue curve for the patient who got relative hypoglycemia. And this was also found and confirmed in the multivariable analysis. Now, if hypoglycemia is dangerous, it's probably for the brain that the damage will be the highest. Indeed, glucose is the obligatory metabolic fuel for the brain, and there are no cerebral stores of glucose. So the glucose diffuses from the plasma or the cerebrospinal fluid to neurons and astrocytes on a concentration-dependent manner. In case of severe hypoglycemia, we can see the falls of ATPs and cortical activity recorded by EEG. And this was shown on a short-term basis and also on a long-term basis. This is hard to read, but this group looked and investigated children several years after an ICU stay, and they could they described cerebral abnormalities by sophisticated tests several years after the ICU stay in the children who underwent hypoglycemia, and this was not found in the children who did not. So long-term consequences of hypoglycemia during an ICU stay were described by this team at least. Now, the third domain of this glycemia is the high glycemic variability, which is easy to understand. So the same average value of 8, but the swings in blood glucose are much higher, much larger on the left than on the right panel. So the variability is much higher on the left than on the right panel. And indeed, we know from the literature in diabetology that the swings of blood glucose are very toxic for the cells. This is shown in vitro. Also in patients, we can see in patients with type 2 diabetes, the oxidative stress measured by this urinary marker is much higher. It's proportional to the rate of variability. Now, to assess the variability of blood glucose, we have several possible markers. The standard deviation is the easiest to use. It can be divided by the average blood glucose to yield the coefficient of variation, which is commonly described. But these markers, these indices of variability, are not weighted for time. And time is an important factor when you measure several times the same blood glucose. So other markers, more sophisticated, are used and provide a more accurate assessment of variability. When you look only at the standard deviation, this paper from another team in Australia reported that the standard deviation, so the variability in rough terms, was more closely associated with decreased survival than the average blood glucose itself. This was also shown by Jamie Crinsley in this study looking at the glycemic variability, which was also associated with a higher mortality than the mean blood glucose value. We also looked at this with a team in Italia with patients with sepsis. And we could also show that different indices of variability were associated with a poor outcome more closely than the average blood glucose. Also with name Ailey in the US, we also confirmed that the GLI, so the glucose liability index, was associated with a poor outcome. So there is, and this was shown with the size of GLI on this slide, which was associated with the mortality. And we also looked further in patients with diabetes versus non-diabetic patients in a large cohort of more than 5,000 patients with Crinsley. And this slide shows that the relationship between mean blood glucose, the coefficient of variation, and the rate of hypoglycemia and outcome differed according to the baseline level of A1C, so of the chronic blood glucose. So in other terms, we need to assess the effects of keeping glucose within a range according to the baseline blood glucose, the estimated average blood glucose. Another issue that we learned is the rate of diabetes acquired during the ICU. So non-diabetic patients admitted in the ICU having stress hyperglycemia. How many of these patients were diabetic after ICU? The appearance of post-ICU diabetes can be embedded into the large definition of post-intensive care syndrome, as suggested by our group. And indeed, in this meta-analysis published recently by a team from Australia again, showed that the prevalence of patients having diabetes was multiplied by a factor of 3 when they got stress hyperglycemia during an ICU stay. So the development of ICU-acquired diabetes is not uncommon. This was shown by several teams in different settings. Finally, we got several unanswered issues. We need reliable research tool, such as continuous glucose monitoring, to achieve safely a narrow range of blood glucose. We did a study a few years ago, and we could find that the guided strategy of keeping blood glucose within a range guided by continuous glucose monitoring was much safer in terms of the rate of hypoglycemia, which was much lower, 4 times lower, in the patient randomized to the strategy guided by continuous glucose monitoring than with standard of care. This was also shown by this team in the UK when they coupled the continuous glucose monitoring with a closed loop system for insulin delivery. They were able, this is the red area, they were able to improve largely the time spent in the desired range when they used this closed loop system connected, linked with continuous glucose monitoring. It was also shown by this team from Japan in post-operative patients. So to summarize, this glucose control in the ICU yielded some disappointing results, but there are many unanswered issues. This is a continuing story. I will be able to take any question if possible. Thank you very much for your attention.
Thank you very much, Professor Jean-Charles Fraser, for a crisp session on sugar control, sugar management, and practical points what we require to follow in an ICU. This brings us to the conclusion of this session on metabolism. We move on to an exciting session now in a short while, and that is the JAMA session, Just Ask Me Anything. Signing off from here, good evening to all of you. Hello.
Hello, good afternoon, everybody. I'm Dr. Samir Zog. This is quite strange to be in touch with you for the JAMA session, which is very favorite session in our Best of Brussels, when we have all the faculty members sitting on a podium, and then we ask any questions which are haunting us in our day-to-day practice in critical care. This is quite popular session. We have all witnessed this, but unfortunately, because of this COVID pandemic situation, we are forced to be online. And fortunately, there are few faculties who have agreed to join us for JAMA session, which will start exactly at 4:30, because all the faculties will join at that time. So we still have around 18 minutes to go. In the meantime, we have got many questions from delegates regarding today's lecture. But I would like to clarify this, that like every year, all the faculty members are available for answering your questions. This year, we have to make a lot of compromises regarding this. So we have 3 to 4 faculty members who have spared their time for our JAMA session, and those will join for our JAMA session. So our questions are a little adjusted, I would say, suited for the speakers or faculty members who are available today for our session. So I would like to summarize what we learned throughout the day. Before that, we had a planned one lecture by Professor Samir Jaber. Unfortunately, because of some technical difficulty, we are not possible to run his lecture on bicarbonate therapy in ICU. So if you have any questions regarding bicarbonate therapy in the ICU, Samir Jaber will be live with us. So he'll be answering our questions. I hope he joins from France. So till we start our JAMA session exactly at 4:30 p.m., we are still getting a lot of questions from our chat box, but I would just like to summarize what we learned from 9 a.m. Those who have missed many lectures since morning, and believe me, they were fantastic lectures given by eminent faculty members. And I would like to just summarize today's 13 lectures which we just had since morning. The first lecture by was Manu Shankar Hari, who is a pioneer in sepsis 3 definition along with Professor Mervyn Singer. And he talked on COVID cytokine storm. Is it really a storm? And it was quite provocative lecture, especially on the context of Indian understanding or Indian doctors' understanding of cytokine storm. And he concluded that it should not be called the storm, because if you compare the cytokine release to bacterial infections or fungal infection, that is the real storm. And he coined the term called cytokine breeze in his lecture. It's not the storm. So it was really a provocative lecture, and you will have this lecture available recorded with us on our website. So don't miss this lecture, and you will get a brilliant concept or mind-shaking concept about cytokine storm, so-called cytokine storm in COVID. Then we had a second lecture by Professor Massimo Girardis, who talked about immunomodulation and inflammatory response of COVID. And he also had the opinion of the similar thing, that very high pro-inflammatory markers are seen in bacterial or fungal, whereas it's not common, it's not that seen in COVID. So in his talk, he talked about steroids, he talked about antivirals, he talked about anti-inflammatory agents, especially tocilizumab. And today we really don't know which patient will really benefit and which patient won't benefit with tocilizumab. And the point he raised was the secondary infection issue. If we give any of the anti-inflammatory agents like tocilizumab or itolizumab or anakinra, there is significant rise of secondary bacterial infection or fungal infections in the ICU, which whole world has seen this. So he has given a word of caution regarding use of tocilizumab or any anti-inflammatory agents. Then we had an excellent lecture by Alan Combs from La Salpêtrière, Paris. Alan Combs had been with us in 2017, and he's considered as a famous ECMO guy in critical care fraternity, and all of us know his study called EOLIA study, which he published in 2018 in severe ARDS patient. And today all of us listen to his lecture, which is a brand new presentation, which he published in Lancet Respiratory Medicine about COVID, ECMO in COVID ARDS compared to ECMO in non-COVID ARDS. And his conclusions were the two things which I would like to mention, that he categorically mentioned 2-3 important contraindications of not doing ECMO in COVID patient. One is age above 65. Second is mechanical ventilation days more than 10 days. Then their center were considering this as a contraindication for ECMO. And patient having multiple organ dysfunction syndrome were considered as a contraindication for doing ECMO because they never got benefit from ECMO. Another thing which Professor Combs alluded to was the VAP percentage in ECMO patient was almost 87% as compared to just 39% in EOLIA, which is in non-COVID ARDS ECMO patients. So this is mostly because of indiscriminate or overuse of steroids and anti-inflammatory agents, not only in India, but all over the world. And we are probably in India facing the same issue of significantly high number of ventilator or hospital-associated pneumonia in patients with COVID. Then Professor Girardis again gave a second lecture on, then of course, we had a keynote address by Professor Jolly Vincent, which you really missed. Those who missed that lecture, I would urge you to go again on our website, which all of these lectures will be available for you to listen to. And it's an excellent lecture, how a senior intensivist or how a senior professional from our fraternity give a panoramic view of the dreadful pandemic on various aspects of preparation of ICU, recruitment of new manpower or new workforce in ICU, what we learned during COVID about COVID and about the ICU processes, and what should be the future direction of our research in the ICU. One thing which I would like to mention here about Professor Vincent mentioned is, just because of one small study from France about hydroxychloroquine, whole world started talking about hydroxychloroquine, which Professor Vincent had written an excellent review article way back in April 2020, giving us a caution about the so-called benefit about hydroxychloroquine. And today, after 1.5 years, all of us know that hydroxychloroquine is a useless drug. And we have proven this beyond doubt with multiple studies. The point Professor Vincent mentioned was huge amount of money and grants were spent on doing trials and research on hydroxychloroquine in various indications in COVID as a primary prophylaxis, post-exposure prophylaxis, as an initial treatment, early treatment, late treatment. And the point he mentioned is very important, that there has to have a biological plausibility of action of a certain drug or therapy in a disease. Then only we should move on to do a testing or trial of this particular, any study in future. So the point we learned from COVID pandemic is we should not go with the social media pressure of a particular drug or therapy, but our age-old method of biological plausibility, historical data, small patient cohorts, and then doing large studies should always be followed. Then we had an excellent lecture by Professor Daniel Dibakar, who talked about vitamin C. I think 3 years back in 2018 also, Daniel talked about the same thing, which vitamin C was very fashionable at that time. When Paul Merrick published his first paper on vitamin C, thiamine and steroid in sepsis and severe sepsis and septic shock. And today, after 3-4 years, all of us have used vitamin C in various doses, in various combinations with thiamine, with steroid, without steroid, in various patients with sepsis, septic shock, ARDS, and multiple other patient types. And today, we believe that it is not the magic bullet which works in all patients. There are certain number of patients in whom vitamin C is beneficial after the initial standardized resuscitation of septic shock. Then only it is useful. But still, worldwide, the data coming from randomized controlled trials is not very conclusive about use of vitamin C. So vitamin C is not a magic bullet, which was actually a title of Daniel's lecture, and he perfectly delivered the same gist in his lecture. Then Professor Mark Leon spoke about endpoints of macrocirculatory resuscitation, and I think this was the highlight of today's presentation in a very crystal clear message. The other wording, when we say enough is enough in this patient, and we should talk to family regarding end of life care, or when to stop further resuscitation in our septic shock patients. And his presentation was absolutely clinical based on his own experience and publication. And I urge you to go to this lecture on our website, which will be available soon after 2-3 days, and go back and listen to this lecture. Well, then we had a whole session on mechanical ventilation and respiratory assist, especially on COVID as well as in non-COVID. We had 4 lectures on that. The first lecture was by Professor Jean-Damien Ricard. He's from France, and he's an authority in high flow nasal oxygen. He was a co-author in the famous Floralis study, which was published in 2015, and thereafter all of us started using high flow nasal oxygen. So his topic was HFNO in ICU, which was again an excellent lecture, and I hope Professor Ricard will join us for a JAMA session. So we will ask many questions about HFNO, especially in the context of COVID pandemic, because all of us in India have used HFNO significantly in large number of patients. If you give an example, our hospital bought new 25 HFNO machines in April 2020, assuming that this, in case of surge, this will be our first line therapy to be provided in a pandemic surge when mechanical ventilation is not possible to provide to all patients who need. And on this point, I would like to mention Pune ICCM effort of original study which we designed, and the study is completed, and we are writing the manuscript of our study, which is called as non-invasive respiratory assist devices in severe hypoxemia in COVID patients. We have collected data of almost 1,200 patients, and soon we will be presenting our studies in one of the meetings, and we will be publishing it in some journal. So HFNO is a very good topic or burning topic in COVID as well as in non-COVID. Professor Ricard talked regarding this very well. Hopefully he will join us for JAMA. We'll ask him many questions about HFNO in COVID as well as in non-COVID ARDS. Then we had a second talk by Professor Massimo Girardis. Massimo Girardis is from Modena, Italy, and Italy was the first Western country besides China who borne the brunt of COVID-19 pandemic. And so Girardis was one of the early Italian intensivists who were involved in the management and studies and research in COVID-19. So his second talk was about conservative oxygen therapy and permissive hypoxemia. All of us have experienced this, that many of our COVID patients remain clinically stable without much tachypnea, even at saturation of 86-85%. If we compare this cohort with our standard viral pneumonia patients or community-acquired pneumonia patients who are non-COVID, anybody who is saturation of 85, 84, they are quite tachypnic and they are quite distressed. So which oxygen level or which saturation level we should accept in which patient is really a moot question. And recently there are at least 4 publications, 3 from New England Journal, one in 2019, one in 20, and one in 21, talking about what is the oxygen saturation level or what is the oxygenation level, best level for our ICU patients. And Professor Girardis talked excellently about the oxygen targets or oxygenation targets in our ICU patients. And again, I urge you to go to our website after 3 to 4 days. to listen to this lecture to understand what are the oxygen targets in our daily ICU practice in various cohorts of patients. For example, in cardiogenic shock or in stroke, the oxygenation target will be different than from a COPD exacerbation patient or a patient with sepsis and septic shock. So this is a very interesting talk about permissive hypoxemia and conservative oxygen therapy. Then we had a lecture by Oriol Roca. He's a young dynamic intensivist from Barcelona. He talked about the prone position during HFNO or during non-invasive ventilation. All of us have practiced this in last 1.5 years. Many of our patients in wards, even in the ICU, are in the prone position in COVID because all of us believe that prone position helps in early recovery. Whether this patient is on mechanical ventilator or patient is on non-invasive ventilator or patient is on high flow nasal oxygen. Prone position definitely helps. So Oriol Roca talked about awake prone position, which is called APP, which is the famous short form in last 1.5 years in various publications, APP. So awake prone position along with HFNO or NIV, and the results are quite encouraging. So hereafter, even the COVID ends. So one day COVID has to end, and there will be normal routine ICU patients will be there with us. So we should try awake prone position in patients who can tolerate well during HFNO or when on non-invasive ventilation. So awake prone is probably a gift COVID has given to us in our ICU, because before COVID, I think we rarely trying proning in non-invasive ventilated patients or HFNO patients. So this is one thing which COVID has probably taught us in mechanical ventilation. Then we had a lecture by Professor Niall Ferguson from Toronto, who talked about mechanical power and driving pressure in ARDS ventilation, and give very good insights about how to calculate power, how to calculate driving pressure, and actually practice or convert idea of power and driving pressure into our day-to-day decision making in ICU. Then we had just last session, which was a metabolic session. We had an exciting talk on phosphorus metabolism in critical illness by Annika Reintham-Blaser. She mentioned a very excellent point of new hypophosphatemia, which is developing during the ICU stay, irrespective of diagnosis of a patient, whether it is acute kidney injury on dialysis or acute pancreatitis or sepsis or septic shock. The new development of acute hypophosphatemia during the ICU stay is more deleterious, and we should all monitor routinely phosphorus levels in our ICU patients. So development of new hypophosphatemia was associated with probably higher morbidity and mortality, as per this lecturer Annika Reintham-Blaser. Then we had a very interesting talk on HLH in ICU. All of us know HLH reasonably well because we treat a lot of dengue patients in our ICU. Dengue is associated with HLH, and Mycobacterium tuberculosis infection is also associated with HLH in significant numbers. So, and recently COVID was also considered as HLH because it is difficult to differentiate between a COVID response or COVID inflammatory response and HLH because of very high ferritin levels or maybe triglyceride levels. This was an exciting lecture by Evangelos Giamarelos, who talked about HLH in ICU and its management. Unfortunately, we could not relay or transmit Samir Javed's lecture on bicarbonate therapy because of technical difficulty in his presentation. So this is now 4:29, and we will start our JAMA session soon. So we have got many questions from delegates who attended today's 14 lectures since 9 o'clock. And we will take as many questions as we can because we have agreed to stop at 5:30 p.m. because all the faculty members who are joining us live have spared their time on their weekends on Saturday. This is at exactly 12 o'clock or 12 noon in Europe. Most of our faculties are from Europe. So they have agreed to join us for 1 hour. So let's start our JAMA session and let's see how many faculties have joined us for our JAMA session. Professor Reichert, John Amin Reichert, have you logged in?
Hello.
Hello.
I'm very happy to be with you today.
Professor Reichert, can you hear me?
Yes, I can hear you.
Yes. Okay. So can we start with the questions regarding your lecture?
Yes.
Okay. So we have got a first question for you. The question is, when to intubate a patient of especially COVID and non-COVID, because the ROX index, which you talked about, failure of HFNO in deciding intubation, which is not the case in COVID patient, because all of us were experiencing a huge surge of patients and our ICUs were overwhelmed with mechanical ventilated patients. So we did not have that much amount of manpower and machines with us. So we continued with HFNO for probably longer period of time. Even our ROX index was dropping down. So what was your opinion? What is your opinion on use of ROX index in decision making of intubation in COVID patient when the pandemic is at peak, and your opinion on ROX index in non-COVID patient, which probably you have proven your model?
Okay, thank you for your question. That's a very good point. There is obviously a key issue is the number of ICU beds that are available. And I agree with you that we tended to perhaps have patients under nasal high flow for a longer period of time, despite the fact that the ROX index was suggesting intubation. However, my experience is that in these patients in whom we did prolong the use of nasal high flow, when these patients were ultimately intubated, their course and the extension of their lung injury when we performed CT scan was perhaps poorer. So I do feel that it is important to keep in mind that if the ROX index does suggest intubation, if we have the capacity in terms of beds and ventilators, I think it's important to do so. Obviously, if we're not in the capacity, then obviously we're going to maintain the patients under nasal high flow for a longer period of time. As I mentioned, it's really the question of, do we have the capacity to ventilate the patient or not? If we have this capacity, then I think we must respect what the ROX index informs us and do it. And in non-COVID patients, obviously we're not facing a surge, then I suggest to do that. We are currently, with my colleague Oriol Roca, we're currently conducting a study based on an algorithm of the ROX index, just to see if clinicians are happy with performing intubation when the ROX index suggests to do so.
Okay. Thank you, Professor Reichert. I can see Marlies Osserman has joined our session. Hi, Marlies, are you around? Hello. Hello.
I am around. I was planning to listen in.
But we take this opportunity to ask you a few questions, which I'm sure you will be able to answer. So
One second.
Can you take some questions? Because we are ready with our questions.
Perhaps there's another question I can answer whilst Marlies is getting ready.
Yes. The second question, till Marlies is ready, the second question is for Professor Reichert is, what is your experience of using high flow nasal oxygen after extubation? Because again, in surge time, we have to vacate the ventilator as early as possible for the next possible patient. So a lot of us have early extubated patients and put them on high flow nasal oxygen after extubation. So what is your experience and opinion about use of HFNO post extubation?
Well, I believe, as you mentioned, if we do have the number of devices available, I do strongly encourage the use of nasal high flow in post-extubation, especially in those high-risk patients, high risk of reintubation. I think the randomized control trial, the HiWeen trial that we published in the JAMA, and Arnaud Thiele was the first author, clearly shows that the combination of nasal high flow and non-invasive ventilation versus nasal high flow alone proved to be efficient and reduced the number of reintubation. Interestingly, this was especially true in patients with chronic respiratory disease. So the results of this study do indicate us that nasal high flow alone is also capable of reducing reintubation in these patients. So once again, if the devices are available, then yes, I encourage the use of nasal high flow in post-extubation, especially in high-risk patients.
Thank you, Professor Reichert. Dr. Marley, are you around? Can you hear me?
I am.
Yeah. Thanks a lot for joining us extempore, because I saw your name in attending the lecture, so I took the opportunity to ask the question. Hello. Hello.
I can hear you.
Yes. One interesting question regarding dose of norepinephrine in septic shock. And we had one lecture in the morning. Mark Leon talked about use of norepinephrine and second vasopressor agent like vasopressin or use of dobutamine. So what's your practice of highest dose of norepinephrine, and when you introduce second vasopressor or inotrop in a septic shock patient?
That's a very good question. So the latest surviving sepsis guideline again suggests that norepinephrine should be the first line vasopressor, and vasopressin should be considered as the second line, and it should also be considered before the dose of norepinephrine escalates. And then as per surviving sepsis guideline, dobutamine should be considered in case of reduced cardiac output. Now, all of this means that patients who require this type of support should have, if possible, some hemodynamic monitoring to assess degree of vasoplegia and also cardiac output. I think with regards to the exact triggering doses, at what dose do you start vasopressin and at what dose do you start dobutamine? I think the evidence is very limited and practice is variable. So we, in our practice, start vasopressin in those with escalating doses of norepinephrine. By that point, patients would already be on hydrocortisone. So if patients require escalating dose of noradrenaline, the first thing would be to introduce hydrocortisone as an adjunct, and then to give vasopressin, to add vasopressin. As I said, it's very variable what people do. Most think of vasopressin when the doses go to 0.5, 0.6. It's vasopressin, the combination is very powerful, but it's powerful at raising the blood pressure, but it's also very powerful at inducing side effects and mesenteric ischemia. And that needs to be remembered. So patients who require those two drugs need to be adequately filled. Otherwise, you have a higher risk of mesenteric ischemia and bowel infarction. The dobutamine, adding dobutamine is usually done, again, in patients with clear evidence of impaired cardiac function, as evidenced by a low cardiac index and echocardiography findings.
Thank you, Marlies. Since Professor Alan Combs have joined us, Professor Combs, can you hear me?
Yes.
Yes. So this was an excellent lecture on ECMO in morning. So you have got one question that you showed your series of ECMO in COVID patients and compared them with your previous Eolia experience. So one of our delegates is interested in knowing the proportion of patients who underwent VA ECMO, veno arterial ECMO for cardiogenic shock, because we have experienced the myocardial depression effect of COVID pathology. So how many of your patients were undergoing VA ECMO for cardiogenic shock, and how many of them were undergoing veno-venous ECMO for refractory hypoxemia?
So for COVID, a vast majority of the patient did receive VV ECMO for respiratory failure, and very few actually received VA support. We had quite a few patients who had myocarditis, and also some of those who had the late form of multi-inflammatory syndrome, which was mainly seen in children, but we also observed a few cases in adults, young adults. But overall, I would say less than 5% of the patient hospitalized for COVID disease in the ICU for super severe COVID disease needed a VA ECMO support. Very few.
And just part B of this question, because COVID being a significant thrombotic disorder, not many patients we have treated of pulmonary embolism in this COVID pandemic. And what is your experience of doing ECMO for pulmonary embolism in COVID?
So we had a few patients who had pulmonary embolism in the first day of VV ECMO support, especially in the first weeks of the disease back in March 2020. But I would say that since we have increased the anticoagulation strategy and target, we did have much less patients with severe PE. We had some patients coming to the hospital with PE because of the COVID disease. In that situation, we usually set up VA ECMO, and then the discussion, if the disease is super severe, of course, because the first line is to use thrombolytic agents. But if the disease is severe enough and refractory to conventional treatment, we usually set up VA ECMO, and then there is a discussion: should we stay only with VA, or should we go to the radiology interventional doctor to remove the clots internally, or in some situations should we discuss with a heart surgeon to remove the clots? But this is quite a second line discussion, and I would say once the ECMO has been set up, the patient is stabilized, and usually the prognosis is quite good. Should the patient not have initially been receiving CPR for a prolonged time, which is the real factor which is associated with a dismal prognosis.
Thank you, Professor Combs. We have got another interesting question. Today morning, we had a lecture by Professor Massimo Girardis, who talked on conservative oxygen therapy and permissive hypoxemia. Professor Alan Combs and Marlies Osterman had been with us in Pune in our previous editions of Best of Brussels. So they know the format that all the faculty members are sitting on a podium. So unfortunately, all faculty members cannot join for today's online JAMA session. So those who have joined us would have to answer the questions. Of course, I will ask the relevant questions to the relevant person, but this is an interesting question regarding oxygenation, and I request Professor Jordan Ricard to answer first, and then I will switch the same question to Professor Alan Combs. Professor Ricard, what oxygen saturation target would you keep in patient when you are giving high flow nasal oxygen support, whether saturation of 88, 89, or saturation of 94, 95, or you do frequent blood gases, or you look at PCO2 values? So what is your routine practice of accepting saturation when patient is on high flow nasal oxygen?
Well, thank you. That's a very good point. In the absence of chronic respiratory disease, where we know that the targets are much lower in case of exacerbation of chronic respiratory insufficiency, I believe that in dealing with patients with acute hypoxemic respiratory failure, a target between 94 and 98% of pulse oximetry is reasonable. Obviously, all depends if there are other organ failures associated or not, and also to what are the other signs of the tolerance of the strategy, the non-invasive strategy. And on this, obviously, we will base the clinical evaluation with the respiratory brace, the use of accessory muscles, and if we are fearing some kind of respiratory fatigue, obviously arterial blood gases with the value of the PCO2 may indicate that there is some kind of decrease in alveolar ventilation and the risk of respiratory and muscle failure. So clinical and something between 94 and 98% as a target.
Okay. I would like to ask the same question to Professor Alan Combs. What should be your oxygenation target if somebody is on veno-venous ECMO for severe ARDS?
So here it's a different situation. I completely agree with what Jean-Damien said about the patient on conventional non-invasive support. It's for sure the target. There's been a lot of papers over the recent years with different targets of oxygenation, and probably it's not necessary to reach the highest possible. In VV-ECMO, it's a rather different situation in which the patient has already undergone a refractory respiratory failure. The first message I would like to pass here is that, especially for those who had developed hypocapnia, it's very necessary to decrease slowly the capnia in these patients, because there's been a lot of data accumulating showing that decreasing rapidly the PaCO2 in those patients who are put on ECMO may be associated with brain hemorrhage, probably due to vascular events within the brain. So this is the first message here. And then second, a patient on VV-ECMO, it's very difficult to reach higher than 80 or 100 of PaO2 and a blood saturation of oxygen of 95 to 98. So the target here is usually to reach a blood saturation in oxygen, which is over 90%. This is much enough to provide sufficient oxygen to the body. And there may be the other way around, specific situation in which it's difficult to reach this target, especially for those who have the most severe disease, completely white lungs. And we have seen these patients again with the COVID. In that situation, you may need very high flows, and sometimes it does not, is it not sufficient? You need to, in some patients, decrease the body temperature, sometimes use beta blockers also to decrease the cardiac output of the patient. So there's, in some patients, problems with reaching the oxygenation target because of the severity of the disease and because most of the oxygenation is actually provided by the device in that situation.
Okay, thank you very much. So there is another question. Anybody can answer, but I would like to have first Professor Marley's opinion on this, and this is regarding immunomodulatory agent tocilizumab. So I'm sure all of you have used this agent in COVID at some point of time, maybe during first surge, second surge, or in between, and the data is not very conclusive on tocilizumab. So I would like to ask each of you the question about in which patient you would use tocilizumab in COVID-19. First, Professor Marlies, and then Alan Combs, and then Professor Reichert. Marlies?
So the tocilizumab data were obviously supported by the REMAP-CAP trial. And the REMAP-CAP trial was strongly supported by the Department of Health in the UK. And therefore, when the results came out, the Department of Health and the government issued some guidance. And so tocilizumab is available in the UK. It's recommended in the UK, and it is used in patients with severe COVID-19. According to the departmental and national health system guidance, but it's strongly supported by the Department of Health.
Yeah, but can you give an example in which patient and when you will use tocilizumab?
We use it in patients who need oxygen and are critically ill, and before they come to the intensive care unit. So it's a high number of patients.
Professor Alan Combs, any experience or any opinion about use of tocilizumab either in the ICU or before ICU? What is the practice in Paris in general?
So I have just the same opinion as Marlies regarding the use of tocilizumab. The fact is that in France, for now, it's not been used a lot. And I would say most of the patients who are treating now, especially in my unit, patients who have been treated first line in another unit and who have been refractory to conventional treatment, most of them did not receive tocilizumab. The data and the meta-analysis of published studies are still in favor, but probably in the subgroup of patients who have the highest signs and biologic signs of inflammation. So in our group of hospital in Paris, it's the way it's still recommended is a need to have a look at the D-dimers and the CRP to determine if it's needed or not. But obviously, when looking at the number of prescription, it's probably much less than in other countries. Jean-Damien, I don't know if you agree with that.
Yeah, Professor Reichardt.
Yes.
Your opinion on tocilizumab?
So my personal opinion is to use it very often, and we use it systematically in all our patients coming to the ICU. And what is discussed is to give a second dose based, as Anna just mentioned, on the C-reactive protein. But any patients coming to the ICU requiring high levels of oxygen, or even more so if they're already intubated, receives a first dose of tocilizumab, and we evaluate at 72 hours. If the inflammatory response is still important with a C-reactive protein above 50 milligrams, then the patient gets a second dose. And in fact, based on our experience, in fact, we never stopped giving tocilizumab. So we were very happy that the REMARCAP trial was positive, because that comforted us in what we were doing. But I must admit that since June, July 2020, we were systematically giving tocilizumab to our patients. Yeah. And I agree with Marlies, what said, even in the wards, when these patients are just under oxygen, studies have shown that the requirement of ICU is decreased in those patients that do receive tocilizumab. So I think everybody would agree that it's relatively safe. I mean, we haven't noticed any serious complications. So it is a drug that is very well tolerated. So even if in some instances the data is perhaps lacking, I think clearly the overall risk-benefit evaluation is for the drug.
And it's,
Amir, could I add one point?
Yes, go ahead, Marlies.
I fully agree it is very well tolerated. The only challenge is that the inflammatory markers become difficult to interpret, because the CRP will then be dampened, and it is then much harder to, once you've given tocilizumab, it's much harder to recognize the beginning of another infection or a superadded infection, because the CRP may be suppressed. That's a bit of a challenge in people who've had tocilizumab.
And just one point, it's very specific of the patients I treat in my ICU, which are those who have been refractory to everything. Most of them come with severe lung superinfections, bacterial superinfection. And I'm not sure that in those patients, it might help giving these type of treatments. So once again, question mark for that. But probably early in the course of the disease, this might help clearly.
And just small one question, that in India, it was quite common to do interleukin-6 levels and decision of tocilizumab based on interleukin-6 levels. So is there any data which support this notion of doing interleukin-6 levels, IL-6 levels, and then make a decision of giving tocilizumab? Marlies?
I'm not sure actually. I am less familiar with that. So in the remap cap, obviously the interleukin levels were not measured. So I'm not sure. I don't think I'm the right. Apologies, I'm not sure.
But I don't think it's necessary to go into that detail of the inflammatory response. Studies were based on the levels of CRP, and so once again, because these patients are very inflammatory at the beginning in any case, I think this is sufficient to initiate tocilizumab, again based on the requirement of oxygen, because that's where the inclusion criteria in most studies, and these are the results in these patients. When it is initiated, then it reduces the risk of complications and ICU admission.
So we have got a bunch of questions on use of bicarbonate in our ICU, because we had one lecture from Professor Samir Jaber about bicarbonate, but unfortunately Samir Jaber has not logged in. So I would like to ask the question to three of you in different perspective. First to Professor Marlies, about use of bicarbonate infusion or use of bicarbonate bolus doses in patients who have got acute kidney injury and who are not yet getting any renal replacement therapy.
So an excellent question. Obviously the study from France showed that the supplementation with bicarbonate prevented progression to severe acute kidney injury in their sub-analysis. And in fact, whether it can also apply to critically ill patients with acute kidney injury and prevent renal replacement therapy is a question which has not been answered. But in the UK, a large national study has been commissioned by the NIHR, so the National Institute for Health Research, to explore exactly this question in patients with acute kidney injury. I think it's stage 2 or so. Can the administration of bicarbonate prevent the need for renal replacement therapy? And it was considered to be an important question of high interest, so that taxpayers' money is being used to answer the question. In 2 or 3 years' time, we'll hopefully have the question. At the moment, it's a research question.
But what is your practice in your ICU? Do you use bicarbonate therapy in patients who are yet to dialyze, or you don't use bicarbonate at all?
No, not yet. So I have used, so if patients meet criteria for renal replacement therapy, then I only use bicarbonate in the interim to, say, for instance, to treat hyperkalemia until the renal replacement therapy starts. So it's a bit of a rescue therapy before the next treatment starts. Having said this, during the COVID time, during the COVID pandemic, when we ran out of renal replacement therapy machines and had major supply problems with dialysis fluid, for instance, we used much more bicarbonate to get patients through a difficult period and bridge them before they had severe metabolic acidosis. So we don't use it routinely, as the answer. We only use it in emergencies when treating with severe hyperkalemia before the dialysis machine or renal replacement therapy machine starts. But we are waiting for the large trial.
In the meantime, Professor Samir Jaber has joined. Welcome, Professor Jaber. Hello. Professor Jaber, can you hear me?
Hello, everybody. Sorry for the delay. I listen to you. Hello. Hello.
Yes. So actually the original question is towards you. of use of bicarbonate in the ICU. The Marlies has answered the question of use of bicarbonate in renal replacement in acute kidney injury patients who are yet to undergo dialysis. But are there other indications of use of bicarbonate in our day-to-day practice, Professor Jaber?
Yes, I think that today we have some data according to the recent randomized trial called the bicarbonate ICU, when we evaluated the interest of infusion of bicarbonate in a patient with metabolic acidosis defined by a pH less than 7.2, and the study showed that it could have a benefit in a subgroup of patients, especially the patients with an acute kidney injury. And in this subpopulation, we observed that a decrease of renal replacement therapy required, and also a decrease of mortality. This could be a subgroup that could benefit from bicarbonate. That's why now we are performing a new study called the bicarbonate ICU2. We plan the study to include 680 patients with a primary endpoint that will be the mortality in this selected population. That means with metabolic acidosis and acute renal failure. And now the progress of this study, we reach half of the inclusion. We are waiting the second interim analysis very soon. And the hypothesis of the study is to decrease the 10% of mortality in this population from 80% to 70%, because it's a population with a high risk of mortality, around 80%. And then whatever the results about this study or the previous one, we think that the bicarbonate, we did not observe side effect in the first study. When you monitor correctly all the metabolic, electrolytic, blood arterial gases, and some things like the calcium and potassium mainly, we did not observe any side effect, and we have a benefit of decrease of renal replacement therapy. That is the major data that we have today on the topic of bicarbonate in ICU.
I would like to ask the same question to Professor John Damian Reichard about if we are in a resource-limited setting, especially like an Indian ICU where extracorporeal CO2 removal is not available and ECMO is not available in most of the ICUs in India. In such situation with severe ARDS patient, if you are ventilating severe ARDS patient and patient is developing respiratory acidosis, it is common practice to give bicarbonate if patient has got significant respiratory acidosis, especially if pH is below 7.25 or 7.2. So what is your opinion, Professor Reichard, about use of bicarbonate in respiratory acidosis?
Well, that's obviously a good question and a difficult one, because one of our fears in these patients is fluid overload and increasing, because it's an ARDS patient with lung permeability alterations. The risk is a worsening hypoxemia and perhaps also to fluid overload if we're also with kidney injury in these patients. When we have respiratory acidosis, one of our concerns is, can we reduce instrumental bed space? For example, if patients are with a filter, an HME filter, then we change this for a heated humidifier, because we will gain between 40 and 90 milliliters, and that can make a tremendous difference, especially when tidal volume is reduced. So we use all these little techniques to try and decrease instrumental dead space and therefore increase alveolar ventilation. Obviously, we can try and see if we can increase tidal volume and respiratory rate, knowing that it's more efficient to increase tidal volume than respiratory rate in the CO2 clearance in these patients. This is how we try to manage this situation. There
is another interesting question has popped up. It is for Professor Alan Combs as well as for Professor Raikart, but Samir Jaber can answer. Somebody has asked about doing awake ECMO. Have you ever tried? Because there have been some case reports of doing venovenous ECMO in awake patient, those who can tolerate. So any experience of using awake ECMO? Without intubating or without mechanical ventilation, doing ECMO on HFNO or on NIV?
So we have published a clinical case recently about patients who treated COVID-19 patients who treated without intubation. But I need to say that it's one of the very few who tolerated awake ECMO, and most of these patients are so sick, have so severe disease that it's virtually impossible to let them breathe by themselves without a tube. It's probably especially because of the very high intense inflammation within the lungs. These patients, they cough all the time. It's very uncomfortable, and it's virtually impossible to let them awake without a tube. So there's very few. It might be tested in some patients. It might be different for other types of ARDS. It might be different for ECMO in other types of setting. For example, patients in lung transplant centers who are bridged to lung transplantation on VV ECMO. Usually those patients should be bridged on awake ECMO. But for the most severe forms of ARDS, I doubt that this strategy may be adopted on a large scale.
Professor Jaber, any opinion about use of ECMO in without intubating the patient? Any experience or any opinion about that? Samir Jaber, Professor Jaber.
I don't understand the question, Samir.
So the question was, any experience of using ECMO in non-intubated patient? When patient
no, we don't have it. I don't have it. I think the best person is Alain, who knows very well the ECMO, I think, in the world.
Thank you. So we move on to the next question. It is a different question, but any of you can answer. This is about vitamin C. It is quite popular in India to give vitamin C for many patients in septic shock. The data is not very conclusive about use of vitamin C in septic shock. So first, I would like to ask the question to Professor Marlies Osterman about use of vitamin C, because obviously kidney side effects of vitamin C. So her opinion on use of vitamin C in septic shock, and then any of you can answer.
So again, I have to refer to the surviving sepsis guideline, which has just come out. And the expert panel, which put the guidelines together, looked at the existing data and concluded that there was no role for intravenous vitamin C in the management of sepsis. That was the recommendation and guideline as published a few months ago. Now, since then, Professor Bellomo has published a large meta-analysis, and it suggests that maybe very high doses of vitamin C may have a role in decreasing mortality. So I think the question has not been answered. There are still unknowns, and more research with regards to the dose of safety and efficacy of very high doses needs to be established. But at present, my practice is to follow the guideline, the recommendations by the surviving sepsis guideline, not to use vitamin C routinely.
Professor Jaber, what's your practice of using vitamin C in septic shock?
I don't have really a clear position according to the data available that we have in the last issue in Intensive Care Medicine Journal. A nice review. I think that Marlies know very well. And all that said, I agree with all what said Marlies, but I don't know if we could recommend today use vitamin C, but in another point of view, we have really few side effects of vitamin C. I don't know, this is not evidence-based medicine, but I know that some of my colleagues use it systematically. They believe the effect of vitamin C. I have no position clear in this indication. I think that using have no effect, have no side effect. Vitamin C, personally, I take it in the morning when I'm very tired, but I don't know what exactly if there is or no side effect on ICU patient. I don't have clear idea on this position.
Okay.
I don't know if Alain or Jean-Damien or other colleagues have a clear idea. Khalid. Jean-Damien, what you do?
Well, I don't use it. I mean, there's no, the data is not there to recommend it. I don't see why we should use systematically a drug, even if there's no side effects. I mean, either it works and we prescribe it, or it does not work and we do not prescribe it. I mean, it's an intravenous administration. It takes time for the nurse to prepare it. There again, and I'm like you, I use it when I've got a cold and I'm tired. Apart from that, I don't see any reason to give it to my patients.
Thank you very much. Another question is about extracorporeal CO2 removal. This technique has been getting quite popularity in Indian ICUs because of the cost involved in it is much less, and it is claimed that it can be performed with our routine CRRT machine or dialysis machine. So I would like to ask all of you about your position of use of extracorporeal CO2 removal in severe ARDS patient, especially when the resource limited setting is there and we really cannot run an ECMO. Either the machine is not available or the trained personnel is not available, or because of various reasons we cannot use ECMO. But can we, in such situation, we use extracorporeal CO2 removal? Professor Alan Combs first, and then others can contribute.
So there is a very strong rationale for using ECOR in ARDS patients. For sure, not those who have refractory hypoxemia, because ECOR does not provide sufficient oxygenation. It may be used to decrease the intensity of mechanical ventilation in those patients who have mild to moderate forms of ARDS. But for now, we lack data. And the only study we have, which has recently been published, a study performed in the UK, the REST trial, actually is not in favor of using ECOR in these patients. The mortality was the same, and there was a trend towards longer time on the vent with the device, and of course also more complications because it's a kind of invasive device which needs full anticoagulation. So for now, I would say we need more. We need to have new studies, because the study which was conducted in the UK had some drawbacks as well, which need to be addressed in a future study, especially regarding the device which was used, the degree of CO2 removal. There's many things which can probably be improved. But for now, this device should not be used in all ARDS patients outside registries at the minimum, or randomized studies.
Professor Jaber, your opinion on extracorporeal CO2 removal?
It's very easy to answer this question, because we are now writing with Alain Combes a narrative review, and I inform you that very soon Intensive Care Medicine Journal will publish a special issue on extracorporeal organ support and the machines in ICU. And there are several papers in this special issue on the machines, especially one review written by Alain, myself, and all the experts on ECOR, one on ECMO, and the other in renal replacement therapy, and then that is going. And I share all what Alain said, that we have experience, and now we have recent data. The last recent study should be taken into account, and we should be very, very cautious, as said Alain, that it should be used according in a registry regulation, very clear, and it's possible to use it probably in a lot of ICU in comparison to ECMO that could be used only in expert centers. This is an interesting point of view, but we should now not recommend for all RDS patients or for all COPD patients. It should be just used for us in the context of research and randomized trial or observational studies.
Professor Ricard, your opinion on extracorporeal CO2 removal or any experience of using ECOR when ECMO is not available or not possible?
So we have not used it in the indication that you just mentioned, and I agree with what Anna and Sabien mentioned. Our experience is in severe COPD patients, and it's really used in a very limited number of cases. We have had some positive results. I remember at least 1 or 2 patients that were not ventilated and that were set on the ECOR machine and that evolved favorably. But there again, these are just individual situations, case report on which obviously we can't base any strategy. So we have the device, but we don't use it very often, only in some specific situations of severe COPD patients.
Marlies, your experience of using ECOR in your ICU for ARDS patient or for COPD exacerbation?
So we took part in the REST trial, which was already mentioned by Professor Gomes. And as already mentioned, it showed no benefit, and there was the REST trial showed an increased risk. The REST trial was terminated because of adverse events, because of bleeding complications. So it is not as a therapy with, at the moment, clear unproven effect in ARDS, and a warning and a caution that it is quite invasive and has side effects. We did try CO2 removal in combination with CRRT, because then you already have the device, you just combine the therapies. And we found that when you combine it with CRRT, the effect is not very, it's very minimal, because obviously the blood flow is low, much lower. And as a result, the CO2 clearance is significantly lower. So we didn't really see a clinical effect from the minimal CO2, additional CO2 clearance. So in a nutshell, we don't use it routinely in clinical practice.
Now we are coming to last 2 questions for our JAMA session. One is on anticoagulation practices. Has COVID changed anticoagulation practice or prophylactic anticoagulation, prophylactic use of heparins or directly acting agents? So each of you, I would like to ask this question. Has your prophylactic anticoagulation has changed practice after COVID, or during the COVID, has it changed? And same is about your therapeutic anticoagulation. Professor Alan Combs first, and then I would like to ask the same question to all of you.
So it's going to depend on the type of patients who are talking about. I told you a bit before that for ECMO patients, we have increased the target of anticoagulation because of the number of severe PE we saw at the beginning in those VV-ECMO patients, something we had never encountered before. Regarding anticoagulation in patients on the ward of patients on high flow oxygenation in the ICU, or those who have been intubated, we have recent data showing that probably there's no need for massive and full anticoagulation in these patients. But once again, it probably have to be tailored indication by indications and timing by timing as since the onset of the disease.
Professor Ricard?
Yes, I agree with Anna. Following the first descriptions of cardiac arrest after massive PE in some COVID patients, we had a very aggressive anticoagulation strategy that ultimately was perhaps not supported by this data that came. So we did change our strategy a little by being perhaps not as aggressive as we were just during the first wave. And we have had 1 or 2 cases of hemorrhage due to this strategy. So as I just said, the data does not support such an aggressive strategy. We base our strategy obviously on the level of the D-dimers, and obviously we do have very easy access to CT scans to eliminate P. So clearly these patients aren't managed as they were before as non-COVID patients, but even in the COVID patients, we have perhaps decreased a little our intensity in terms of anticoagulation.
Professor Jaber, your opinion about use of anticoagulation in COVID?
I share what's said by my friend Alain and Jean-Damien. We have similar practices, but I think one of the major messages could be to monitor. When you use the anticoagulation, consider monitoring more than you monitor usually in very patients at risk, whatever COVID or non-COVID. This is my main message. And we have a practice now because I work in a liver transplantation center, and we usually monitor not only the classical monitorage for hemostasis, but also the antithrombin 3. The antithrombin 3 could always, the cofactor of heparin could be always monitored in such patients that sometimes we forget it. And this could be for interest, is my major message for monitoring anticoagulation.
Marlitz, your opinion on anticoagulation, especially in COVID patients in ICU?
Good question. So anticoagulation has had a lot of attention in our unit in the last 18 months. And the changes which have occurred was that we have a much more intensified anticoagulation regime for people who need renal replacement therapy. And that's because our usual protocol of citrate was not effective, or is less effective. And we had more problems with filter clotting. So we have intensified our anticoagulation during renal replacement therapy. And secondly, due to the high risk of clots, but also the high risk of bleeding, we've changed our monitoring protocol, and we now monitor heparin using anti-10A, and we hardly use APTTR anymore. And we believe that anti-10A is a more reliable reflection of the anticoagulation. So yes, there have been substantial changes following the challenges during the COVID time.
And this is a question from all of our organizing committee, that what COVID has affected you and your unit. It's not a scientific question, I'm sure. It's completely individualized question. So how you have tackled the situation on the personal front, as well as on your, as a leader of your ICU or head of your department, how you have tackled in last 18 or 19 months about the COVID. First, Professor Samir Jaber, and all of you will answer this question.
I'm sorry, I don't well understand. Sorry for.
It's question about the burnout issue in intensivists, in your staff. How you have tackled the issue of burnout, especially due to COVID pandemic, at personal level, as well as at an organizational level in your ICU.
I have a bad I don't listen very well. Sorry, could you repeat slowly? Because I have a bad connection.
Samir, le burn-out de tes équipes.
Ah, okay. Okay, thank you, Alain. We have less burnout in our team than in other team who received the majority of the patient, because in my hospital we have 5 intensive care units, and all of us receive some patient. We have 2 intensive care medical who received all the majority of the patient, and in this center there are some burnout, and in other units that receive less, there are less burnout. It seems that we have a clear correlation between the number of COVID patients treated in one ICU and the occurrence of burnout. This is our observation, but we have more and more, and then this new 5 wave in France that we called it 5 wave in France will start now. Everybody is really very, very tired, and we are afraid how we will do if we have a high wave, but we hope that it could be low. But we are afraid, and we try to help all the member of our healthcare staff, especially the nurse. I don't know if my colleague have the same impression, the same thing.
Professor Combs, your experience, any personal experience about burnout in COVID and experience of your unit about burnout in this 19 months?
Yeah, there's been a nice study which was led by Elie Azoulay in the Greater Paris and showing that there is a significant number of doctors, nurses who had signs of high stress, anxiety, depression especially during the first wave. Then over the months, we have been more used to the treatment of these patients, maybe a little bit less fear of going into the unit and getting COVID personally. And of course, since the vaccine have been available, the situation has changed. The problem is that we have been overwhelmed by patients at least 3 times now in our unit, and the fear is that we'll probably face another major surge in the coming weeks, as it's already the case in Germany, for example, in Europe. So many of our nurses decided to move away. There is a turnover in every ICU worldwide. In my ICU, they usually stay on average 3.5 years in the ICU. And we had a lot of departure back in last August. So we were lucky to be able to replace for now all of these professionals. But there's a major issue in France regarding the salary of nurses. Actually, maybe not only in France, but especially in big cities like Paris. It's a major issue because those people, they cannot live downtown because of the very high prices of the apartments. And it's quite complicated for an ICU which runs 20 to 30 beds with let's say up to 100 nurses to have a team which is complete, which allows you to open all the beds. And actually in France now, there's up to 10 to 15% of the beds which are closed just because of a shortage of personnel.
Professor Jaber, your experience. Yeah, Professor Reichardt. John Emil Reichardt, your experience of burnout in your unit?
Well, I agree with what Anna said on the nurses. We're facing some shortage of nurses because they decided to either to completely leave the job as nurses and decide to do something else, or to leave the ICU. So this is a key issue for us right now. The way we tackled at least the first wave, and we in fact doubled the number of ICU beds we had. So we had nurses coming from all over France and doctors too to help us. We created in fact a second ICU in our hospital. So this was at the same time a quite extraordinary experience, a collective experience, and we came out of this first wave quite exhilarated by this all working together, this teamwork. So in fact, the first wave was I would say relatively well lived because of this wonderful experience, in fact, and the second and the third wave, they had really a very important toll on the morale of the teams, and this explains why many have left and decided not to carry on in the ICU. The other way we tried to tackle this is we had regular meetings where everyone could just talk and express themselves, give their feelings on a particular situation of one particular patient. And we had many dramas in our ICU, like in many ICUs. A lot of parents-less children. We had many parents, in fact, that died and leaving children without their parents. So this had obviously a high impact on the team. So having group discussions, things like that, helped, I think, many of us, at least I hope so, to live through this terrific experience. Obviously, as Samir has just mentioned, we are very wary of an extra or coming wave, also too, because we are in a dire shortage of nurses. And I mentioned the number of beds, not only ICU beds, but just all hospital beds that are closed all over France because of a shortage.
And last to Marlies, your experience of attrition or burnout in your unit due to COVID?
Yes, it's a problem in the UK National Health Service. It's a huge problem in intensive care units. And it is getting a lot of attention at the moment in the press. I believe the government is also listening, and there are many programs now starting to address this, to essentially keep nurses in the intensive care unit and attract nurses. So they're developing new programs to improve the professional opportunities, to improve their training and their well-being. So yeah, it's a crisis, but there are plans to stop this and make some good out of it. The other thing I want to say is that we were still very fortunate, although we had a crisis, but we were in a well-developed country. And when I speak to colleagues in South Africa, in Asia, I'm so amazed by how they coped with many more patients and less resources. And I've certainly learned from that, and we adopted a few things from talking to people in Asia or talking to people in South Africa when we were and I think that it was for me something so important that yes, I work in a high resource country or a high resource hospital. In fact, in a crisis, we can all learn from each other, and we definitely adopted practices when we were challenged, which came out of hospitals in Asia in this case. So I do hope that the current problem with burnout and so will also lead us to recognizing the nursing staff a bit better, and giving them more opportunities to develop in their profession. And the beginning of these programs, they're happening, and I hope it will be successful.
Thank you very much. It was really an interesting session with all four of you. I thank all four of you for sparing your valuable time on a weekend. So I thank personally and on behalf of organizing committee of Pune ISCCM. And I hope that in July 2022, next year, all of us will meet in Pune, which will be our 10th Best of Brussels. So we have nomenclature as BOB-10. So I hope and we will meet in person. So thank you again. Thank you, Professor Jaber. Thank you, Marlies. Thank you, Ala Combs, and thank you, Professor Damien Ricard. Thank you very much. So I thank here all the delegates who were there for JAMA session, and I hope you have enjoyed this live discussion from our eminent panelists. So I invite you for tomorrow's session as well. It will start tomorrow morning, and tomorrow also we will have a second interesting JAMA session with different set of eminent faculties tomorrow. So stay tuned with us tomorrow for our Best of Brussels Day 2 on 14th of November. Thank you very much.
Thank you to you for organizing this.
Thank you. Bye.
Take care.